Good morning for everybody. This is an important session. We're going to start now about DAPT therapy. It's a very important issue with some recent papers showing important information about this therapy after percutaneous intervention in acute coronary syndromes. And we're going to have important experts in this field, our speakers, and also panelists that will be discuss this speech. We are going to do a final discussion in the final of the meeting, except for Dr. Peter Smith. Dr. Peter Smith is in vacation, so after his speech, the first speech, we are going to do a short discussion with him to let him free to enjoy his vacation. Thank you very much, Dr. Peter, to be with us. And also, I'd like to present my friend, my colleague, Fausto Feres, from São Paulo. Fausto Feres is the director of Dante Pazanese Institute of Cardiology here in São Paulo. He's going to be the co-moderator with me. Okay, so let's start the session. The first speech is short versus long-term DAPT therapy in high-risk bleeding, rationale and preliminary results of master DAPT trial. It's going to be presented by Dr. Peter Smith from Netherlands. Dr. Peter is cardiologist and director of the Interventional Cardiology Department of Maastad Hospital in Rotterdam. Please, Dr. Peter, feel free to make your speech. It's a pleasure to us to have you here.
Great.
In the meantime, and when Dr. Peter is putting his presentation on screen, I'd like also to invite everybody to make questions. We have a digital moderator, is Dr. Pedro Lemos, also from São Paulo, Brazil. Dr. Pedro Lemos is director of Interventional Hemodynamic Laboratory from Hospital Albert Einstein in São Paulo. So, Dr. Pedro, thank you also to be with us. And so feel free to make your question directly in the chat for all the speakers, okay, and also your comments. Dr. Peter, can you share your screen with us? Can you hear me?
Introductory slides to the master DPT trial. It's about short versus long-term DPT therapy in high bleeding risk patients, and study on the rationality of the master DAPT trial. Well, we all know that after coronary bleeding remains unclear, and specifically PCI patients with the clinical indication for oral anticoagulation present previous oral vitamin and in this trial, the ISA trial, which investigated the benefit of triple or dual therapy in patients. This trial, they did something quite interesting. They did not give aspirin after the PCI anymore, and that was the double therapy from the start after PCI. And the comparator arm was triple therapy, at least for 6 months, up to 12 months. And the result you can see on the left, you see for the bleeding, any bleeding, that could be BARC 1 or BARC 2 or BARC 3, significantly higher bleeding rates with the triple therapy compared to the double therapy, so only clopidogrel and a vitamin K antagonist from the start after PCI. The benefit on the bleeding. If you look at the right, the ISA triple study, they took it a little bit different. They 6 weeks or 6 months triple therapy in patients. And in fact, in this study, there was no clear benefit in the reduction of bleeding seen in the patients receiving double therapy compared to the short triple therapy compared to this long-term triple therapy. As you can see, no difference in BARC 1, 2, or 3 bleedings. If one specifically look at ischemic events, like cardiac death, MI, target vascularization, stent thrombosis, and stroke in the WOOST trial, by amazing benefit was seen in the benefit in ischemic reduction in the double therapy compared to the triple therapy. A little bit unexpected. Whereas in the ISO triple study on the ischemic events, truly ischemic events, only cardiac death, MI, stent thrombosis, and stroke, no difference was seen between 6 weeks and 6 months triple therapy. So those both studies with vitamin K antagonists have a little bit discordant results and a little bit confusing what should be the optimal DAPT regimen in patients having a vitamin K antagonist. We have since those previous studies, we have seen many more studies coming up in high bleeding risk patients. On the left, you see all the studies that are comparing a registry with a single arm registry studies, and on the right, you see the randomized clinical trials. And on the left, of course, those studies were very instrumental in showing that you can safely reduce DAPT from 3 or even to 1 month post-stenting in high bleeding risk patients. But the single-arm registries, they lack a very good comparator, from an unbiased comparator arm. And they also excluded in many times high-risk ischemic patients with STEMI or with complex stenting like bifurcations or very long stenting. Those were often excluded in those single-arm registries. On the right, you see the randomized trials. But in brown or in gold, it's mentioned the trials that really compared actually 2 stents with each other, and not a randomized trial on the duration of the DAPT. And those stent trials are really very instrumental in finding what is the most suitable stent for high bleeding risk patients, but it does not tell us anything about what should be the optimal duration. Many of those stent trials compared a death compared to a bare metal stent, or compared a death versus the biofreedom stent. In any case, the and only after DAPT trial is looking at an abbreviated, meaning 1 month DAPT versus a prolonged DAPT regimen. But before we go into some more details of the DAPT trial, we have seen that in the meantime, we have 4 important NOAC studies looking at what is, and they more or less what they compared is those 4 NOAC studies: the Augustus, the Redual, the Pioneer AFPCI, and the Trust study. They compared, of course, that the NOAC versus a vitamin K antagonist, but only the Augustus trial also took out the equation of aspirin, whether you should add aspirin or not. The Augustus trial, for that respect, is one of the best trials of those 4 NOAC trials. And what they actually did, they compared with the vitamin K antagonist in all cases, and they did triple therapy in almost in all cases, except for the Augustus trial in 1 arm. And those triple therapy was quite low later on. But those NOAC trials were really interesting, but if you put them all together, a nice study done by David Capredano. He made a kind of reconstructed Kaplan-Meier curves for MACE, for ischemic events, showing on the left for all those 4 NOAC trials, and showing that in the NOAC studies with a single antiplatelet therapy was actually in ischemic events quite similar to the vitamin K arms with dual antiplatelet therapy, so the triple therapy. And actually there was no increase of ischemic events in the NOAC studies with single antiplatelet therapy. On the right, you see a meta-analysis on the bleeding. And you can see that there is a clear benefit of the NOAC studies to be compared to the triple arm comparator studies for NOAC studies, showing that bleeding reduction was already obtained early on in the early phase and continued up to above 1 year. And based on these meta-analysis of the NOAC studies and some sub-studies, the guidelines, at least the European and also the North American guidelines, have now changed. They changed as you can see here on the right of this, of the patients not on OAC, that now dual antiplatelet reduced to 3 to 1 month, up to 3 or 1 month, and that is not only for non-STEMI patients. Also, the recent European Society Atrial Fibrillation guidelines show actually the same for the high bleeding risk patients, that you can go down to 3 or 1 month. That is shown on this slide. You can see that they advise in the triple, and then for the patient on the OAC, they advise triple therapy for up to 1 week. Triple therapy, and then stopping dual antiplatelet therapy, continuing with single antiplatelet therapy, so dual therapy up to 6 months, and then giving OAC alone. But you can also give triple therapy to up to 1 month if the ischemic risk is high, and continuing your single antiplatelet therapy with your NOAC up to 1 year. So a double therapy up to 12 months, and after 12 months, all the antiplatelet therapy can be safely stopped, and that is actually a quite stable, that's a quite firm recommendation, whereas all the stopping at 1 week or 1 month or 6 months as rather more a weaker recommendation to with a level C, more an expert opinion. And actually, that the same was observed the same was described in the North American perspectives, where you have again an advice, a very recent advice, to give only triple therapy for shortly after the PCI procedure up to 1 week after, and then discontinue your triple therapy and continue only your dual antiplatelet therapy if in high bleeding risk patients up to 12 months. Or up to 6 months, depending on whether patients are at low bleeding risk or high bleeding risk, as you can see on this slide. What we can say, if we look closer to the comparator of all those NOAC trials and also of the WHOOS trial, is first of all, the time prior to randomization was quite different between all the studies. In Augustus, it was 1 week, so 1 week triple therapy before the patients were randomized. In other studies, it was shorter. Only the WHOOS, they stopped the aspirin immediately after the PCI. But what is also important to note is that triple therapy was given quite extensively long in all those comparator arms. Up to 67%, up to 12 months triple therapy in WHOOS, 100% triple therapy up to 6 months in the Augustus trial, almost 50% triple therapy up to 12 months in the Pioneer RF, in the dual 83 to up to 3 months, and in Untrust more than 50% in 12 months. So it's for the long-term comparison, it's really there was not so big surprise to me, at least, that NOACs were performing better than vitamin K antagonists in reduction of bleeding, because the comparator arm was quite heavily loaded with triple therapy. Another interesting observation for meta-analysis, several meta-analysis, is that if you put all the 4 NOAC trials together, you see that there is a clear benefit in reduction of bleedings, any type of bleeding, as you can see in red. But there is a small signal in increasing of ischemic risk if you discontinue your DLPT after 1 week, and that is shown on the right, on the bottom and on the right. You see a small signal for increase of myocardial infarction, and just a borderline significant increase in stent thrombosis. So it is not that clear yet that it's that safe to stop the antiplatelet therapy after 1 week in patients post-PCI. There are several meta-analyses looking at those. This one is on the there's a signal myocardial infarction and stent thrombosis, and another study where the NTRUST was not included. There was another meta-analysis showing the same, that there might be a risk on increased risk of stent thrombosis when you are stopping the antiplatelet therapy maybe before 1 month. So the master DAPT trial is about management of high bleeding risk patients post-bioabsorbable polymer-coated stent-embolization with an abbreviated versus prolonged DAPT regimen. It was an investigator-initiated randomized trial. We enrolled 4,579 patients at high bleeding risk in 140 hospitals worldwide in 30 countries, and South America and Argentina were definitely part of this important trial. We investigated abbreviated versus prolonged DAPT in patients treated with Ultimaster drug-eluting stent. We used the drug-eluting, the Ultimaster stent, because it's one of the few current stents that have a small strut, have a polymer coating only with the abdominal side, and of which we previously did an OCT study investigating at what time point the strut coverage was almost complete, and we found in a serial OCT study where we investigated patients post-PCI at 1 and 2 and 3 months post-PCI. We interrogated how often strut coverage was observed in an all-comer situation, and we found out that strut coverage was already obtained in almost 86% at 1 month. And here you can see the outline of the drug release and the bioabsorbable polymer of the Ultimaster stent. It's 4 months that the drug is released, and also that the bioabsorption of the polymer is completed, also between 3 and 6 months. Quite comparable to other stents like Synergy, for instance. We included patients that had to have, of course, high bleeding risk criteria, and those that at that point the ARC HBR criteria were not published at that moment. So we had our own high bleeding risk criteria. You had to be on oral anticoagulants, or they had to have a recent non-access bleeding that required attention, or they had a recent bleeding which required hospitalization, or they had to be above 75 years old or above, or they had the systemic conditions associated with increased bleeding, like thrombocytopenia or hemophilia, or they had to have anemia repeatedly, or needed for transfusion in the last month before enrollment, or they had to be on chronic steroid treatment or as chronic non-steroid anti-inflammatory drugs, or they were diagnosed with a malignancy other than considered at high bleeding risk, or a stroke, or at any time in transient ischemic attack in previous 6 months, or a precise depth score of 25 or above. So the inclusion criteria was quite simple. They had to be above 18, at least one eye bleeding risk criterion, and all the lesions should have been treated successfully with the Ultimaster stent. And they were randomized at 1 month, and within that first month, they had to be more or less stable on their medication, and of course, they did not have to have a new ischemic event before randomization at 1 month that needed prolonged DAPT. That would be unethical to put those patients at a short DAPT regimen if they had a recurrent ischemic event shortly after their index procedure. Exclusion criteria were very few, and I will only mention a few, because only patients that were not treated with the Ultimaster stent within the 6 months prior to index PCI could not be included, or treatment for instant restenosis or stent thrombosis at index PCI the 6 months result before, or treated with a bioabsorbable scaffold at any time, and then some other things which are not really that really important, but I would like to stress that it is a true all-comer study. There was no exclusion on geographic or procedural characteristics. So any number of vessels or type of vessels could be treated. There's no limitation on number of lesions or number of stents, of length of stents, of type of lesion or type of treatment or clinical indication, except as mentioned above. So this was more or less a true all-comer, more-comer study. The study design was a little bit complex, so I will try to enlighten you a little bit more on this. So as I told you, the randomization was done at 1 month. Enrollment could be done within that month. And patients were randomized with an abbreviated DAPT or a non-abbreviated DAPT regimen. And after randomization, patients were stratified for whether there was a clinical indication for oral anticoagulation. If there was no clinical indication for oral anticoagulation and they were on abbreviated DAPT was stopped immediately at 1 month, and single antiplatelet therapy was continued for 11 months. If the patients were on oral anticoagulation, triple therapy was stopped immediately, so only dual antiplatelet was stopped. They continued for single antiplatelet therapy for 5 months, and usually clopidogrel, and oral anticoagulant, of course, was continued. The non-abbreviated DAPT regimen, if there was no indication for OAC, then DAPT was continued for at least 5 months, based on the clinical presentation, and the P2x12 receptor was stopped at 5 months after the randomization, so 6 months after PCI, or could be stopped at 12 months depending on the clinical presentation. And if they were on, if they were on an oral anticoagulant, then triple therapy was continued for at least to another 2 months, so 3 months in total triple therapy, and thereafter single therapy thereafter. Single antiplatelet therapy up to 11 months thereafter, and of course a continuation of oral anticoagulant therapy. We have 3 co-primary endpoints. NACE, MACE, and BARC 2, 3, and 5. First, we look at the patient at the whole, whether there was no increase in ischemic or bleeding events. Then we only looked at, if that endpoint, non-inferiority endpoint was reached, we looked at MACE, only ischemic events, and if that non-inferiority endpoint was reached, we looked at superiority for the abbreviated arm on BARC 2, 3, and 5. So the unique features of the master DAPT trial is that it's the only true all-comer HBI hybrid risk patient trial, and no exclusion based on presenting syndrome or complexity. So STEMI patients could be included, also triple vessel disease patients, and bifurcation stenting with 2 or more stents technique. And the experimental arm is contemporary. It does not impose the type of APT during or after the APT phase, and the control arm reflects current practice. Of course, it does not reflect the very current practice on oral anticoagulation anymore, because those guidelines have recently been changed from 3 months triple therapy to 1 month and even 1 week triple therapy. So in that reflect, it's not the current practice anymore. But if we do a kind of an inventory, in which we investigate how often people are still using triple therapy up to 1 month or even beyond 1 month, it's quite big that quite a big of centers and investigators are still doing that. Furthermore, on the master DAPT trial is that the experimental arm investigates not only 1 month DAPT, but also looks at the safety of dropping concomitant APT in OAC patients at 6 months after PCI. As already mentioned, that is only level C in the guidelines, and this is actually the first trial ever that is going to look at whether it is beneficial and safe to stop the antiplatelet therapy 6 months in OAC patients. And randomization that takes place when the treatment arms and the medication starts, the difference in medication starts, that will avoid noise and will help us to get a good and solid evidence on the non-inferiority margins. And it is also one of the largest trials, 4,700 patients. So unfortunately, I cannot show you the results yet. That will come later. But I would like to stress that the optimal DAPT duration in high bleeding risk patients, specifically in patients on OAC, is not yet determined. Stopping DAPT within 1 month post-PCI in patients on OAC might increase in ischemic events, myocardial infarction, stent thrombosis. There is a signal, and stopping APT after 6 months in OAC population is based on expert opinion. And Master DAPT trial is the largest trial investigating abbreviated APT and platelet therapy duration in high bleeding risk patients. The results will be presented and published at online, will be available online at the ESC meeting end of this month. The overall trial results will be presented at the late-breaking trial session on the 28th of August, and the OAC, non-OAC subgroup population will be also presented at the late-breaking trial session on 29th of August. So I hopefully I have teased your interest for having a close look at the Master DAPT trial end of this month. And these are all the participants that have been very instrumental on the executive and steering committee for doing this trial. And on the lower right, on the lower bottom, you can see Alfredo Rodriguez, who has been really the country PI for Argentina and very instrumental for helping us doing this trial for the South American centers. And of course, I'd like to thank also the data monitoring committee and the clinical event committee and the sponsor and the CROs. Well, this is my presentation. I'm happy to receive any questions if you have.
So thank you, Peter. It was great to hear from you. We have several panelists here and experts that I would like just to briefly introduce them. We have Antonio Pocovi, Valeria Curoto, Ruben Piraino, Ricardo Iglesias, Pablo Stutzbach, Omar Santaera, and Carolina Salvatore. I cannot see her here, maybe. So if there, maybe you can take 1 or 2 questions for the panelists for you. Is there any question for you? From the panelists, please feel free to just make a short question. Valeria, do you have a short question?
First of all, congratulations for this excellent study. It will be light for the problem of the anticoagulate patients or the high risk bleeding patients. That was a question for us. And it's a lot. We have a lot of patients with this high risk bleeding risk, and this study will give us important information about these patients and how short can we the DAPT will be in these patients with the security of non-have stent thrombosis or myocardial infarction, and it will be very important for us. So we expect the results with anxiety, and it will be very important for our clinical practice. It is very important for us, and it's an important study for all of us, because we have a lot of patients in these conditions of high bleeding risk. My congratulations for this study.
Okay, thank you. Is there any other point? Peter would like to make a comment about this?
No, I thank you very much, Valeria, for your nice words. And indeed, we felt that it was necessary to do this kind of DAPT duration studies compared to all the other studies that only looking at comparative of stents or single arm registries. So this is going to be an important.
Okay. Pedro, is there any question from the audience?
Not yet, Fausto, but can I ask something for Peter?
Yes, sure.
Yeah. So Peter, well, again, congratulations on your study. It's always high level what's coming from you. Let me ask you something. Your study was conducted during the COVID era. Do you think that this is going to somehow change the results that you will present in the Congress next month?
A very nice question, Pedro. Indeed, it was conducted during the start of the event van Epidemie. Of course, we encountered some patients that died of COVID, but that was equally present in both arms, in the abbreviated and non-abbreviated. As usually you will see in large randomized trials that it's equally divided. So it did not have any impact on our outcomes, I can tell already.
Okay, so Peter, thank you very much for interrupting your vacation and give to us a very nice presentation. Thank you. Have a nice vacation.
Very well. Thank you. Thank you very much. Bye-bye.
And go Verstappen. Okay.
Yeah, that's good.
Okay.
Thanks very much. Yeah.
John, if you agree, we can go to the next presentation. And I'm pleased to introduce Ernesto Duranto, who is the Chief of Coronary Unit at the Favaloro Foundation. Welcome, Ernesto, to this SOLACI meeting. And you are going to talk to us about the rationality of long-term DAPT in chronic stable angina. Please.
Gracias por la invitación, Fausto. Gracias a todos los presentes. Bueno, si me permiten compartir pantalla.
Thanks, thanks everybody for this opportunity. I'd like to share my screen now. So thanks to the scientific community for inviting me for this presentation in this session that is full of experts in DAPT. I'm going to talk about the long-term DAPT therapy in chronic stable patients. These are my disclosures. The first thing we have to see is which patients are we treating. The spectrum of angina is very wide. I can have a patient that had ACS and he's asymptomatic, and that is a stable patient already. A patient that has had asymptomatic 1 year after revascularization, and that's a stable 2, or asymptomatic subjects in whom CAD is detected at screening, and also patients, but all of them are considered stable. At the same time, I have to ask myself, why do we physicians use DAPT? And we have two main reasons: to prevent ischemic events in patients with documented CAD, visualized in the angiography, or to prevent stent thrombosis after a PCI. Those are the two main reasons. Now, if you take really patients that have a chronic disease, chronic coronary syndromes, the annual rate of death is pretty low. Also, the infarction, myocardial infarction, non-fatal, is also very low. But DAPT then makes sense when the events are low, the event rates are low. And this is because we already know from from Levy's publications that they have non-vulnerable calcified plaques that sometimes they're ruptured compared to those with PCI. And of course, the double therapy would not be effective or efficient. And if we think about the second reason, which is to prevent stent thrombosis, we have to see that in this trial, meta-analysis with 49 trials and more than 50,000 patients, where they compared the cobalt stent versus the metal stent, the stent thrombosis has been reduced significantly. We have better angioplasties, better stents, so stent thrombosis prevention is not as significant or prevalent as it was in the past. And a proof of that is this recent trial presented in ESC 21. After 12 months of dual therapy, the stent thrombosis, the 2 years after, is only 0.4% with therapy with clopidogrel and aspirin. So the event rate is really low. we have a lot of evidence that comes from multiple studies of DAPT, many studies that were done in chronic illness patients, chronic disease patients. And the first thing we need to know is that we need to consider many variables before we know the duration of the DAPT therapy. And they are the influence if we continue with the therapy or not, despite the length. What imaging do we have? IVUS or last generation stent? What is the atherosclerotic burden? So we maybe the aortic plaques, maybe they can continue with DAPT, the type of stent we use, of course, the bleeding risk in the patient, and the type of antiplatelet, how powerful it is. So those are all the things that you need to check in order to know whether you're going to do a long-term or a short-term DAPT. And in that sense, there were many publications in patients with chronic PCI and 3, 6 months, a year, and a longer than a year trial. So we'll see what those patients show. On the left, these are the main trials. If you take a look, they're all analyzing this meta-analysis by Palmerini with more than 11,000 patients. They talk about non-inferiority, short therapy, 6 to 12 months, or 6 to 24 months in patients with severe coronary disease. And if we think about those patients and we analyze them particularly, we see that cardiac death and thrombosis, stent thrombosis is not being reduced as it does happen in ACS. And they increase bleeding, extending the therapy up to a year with regards to patients that end between 3 to 6 months. And we already know this from this publication by Costa. There is clear interaction between the clinical presentation of the patient and the bleeding risk, considering the short antiplatelet therapy versus the 24 months therapy. Look at the curves, how they split. And there is an increase in bleeding in patients that continue the therapy after 6 months. Finally, in this last publication by Palmerini, also there is a meta-analysis, now with a more important number of patients, 21,000, out of which 41,000 patients had stable coronary disease, heart disease, and in this case, death, MI, stroke, is not being reduced as it is reduced in other patients as that have ACS. And then when we analyze the stent thrombosis in this same meta-analysis, we prevent it in patients that have ACS, and we don't have any effect on patients that have chronic heart disease. So if we have all this in mind, when we do a long-term DAPT therapy with a number of patients that is pretty low, 59 patients, but if you use it in a SIHD patient, the benefit is much lower and the number to treat is much higher. So the interaction is significant between the clinical presentation and the double therapy duration. So you also know that there were many trials that were extended over a year with a modern stent, with a DAPT therapy, 12 months, 24 months, the most famous ones, the DAPT and the Pegasus, that included more than 20,000 patients. And in these trials, there were stents that still had sirolimus or paclitaxel, and there were many patients that had no stent, and also many patients who had ACS. Between 40 and 50%, they were chronic patients. And what did these studies tell us? That we were able to identify variables to see which patient we are going to administer the long-term duration of DAPT therapy. Most of them are very simple to see: ACS presentation, diabetes mellitus, a long stent in a 3 millimeter diameter, to have left ventricular ejection fraction, smaller, bigger than 30%. And now we'll see the score, whether it is to find out whether the patient needed more double therapy, double DAPT therapy for an extended period of time. So here we're going to see the angioplasty. These are 884 patients with complex PCI. Look at the complex angioplasty. One of them, you don't have to place more than 3 stents. You treat bifurcations more than 60 millimeters, chronic occlusions. When you add up all of these variables and you have more than one variable in complex angioplastic or more than 3, clearly the double therapy is favored when you extend the period of time than those 3 to 6 months. That means that coronary angioplastic is something that we need to take into account when we decide a long-term DAPT therapy. And that has been recently published in Neurointervention. This is Simarino's trial. Roxana Meran, part of this panel, is a part of. They talked about how to treat patients that have PCI on coronary bifurcations when they had a stable CAD. When you place 2 stents or when you do bailout technique, the patient has low bleeding risk. So the duration, the length is usually of therapy is 12 months, very different from the short-term therapy that you have to do when you only place 1 stent or when you add IVUS to see the stent placing. So angioplasty is definitely a variable in the decision of the length of the DAPT therapy. So we have scores. The scores include the angioplasty characteristics. This one, for instance, includes stent diameter, the use of first-generation stent, and the precise DAPT score talk about the hemorrhagic, the bleeding risk, and you add up more than 25 points, then you should treat patients in a short period of time, between 3 to 6 months, and no more than that.
And this is what the guidelines say. This is just a summary of the European and American guidelines in patients with stable CAD. They use this score, and the suggested therapy is only 3 months, not 6 months. And if the patient does not have any high-risk bleeding, then it's treated for 6 months. Both guidelines agree, and these are the decisions to treat these patients who are treated with clopidogrel mainly. This is highlighted in both guidelines. But there's something that is more recent and probably more appealing for cardiologists, which is single therapy. We know that dual therapy has been very beneficial with acute coronary syndrome and stents, patients with stents. Single therapy decreases MACE, but there's an increase in bleeding. So the question is whether aspirin is still useful when we have more potent agents, and if it is useful, how long? And this has to do, this is pretty current, and there are 5 studies that were published with over 30,000 patients in this meta-analysis. Global Leaders, Smart Choice, Stop DAPT, or Twilight, Dr. Roxana Meran. These are studies comparing dual therapy short-term, 1 to 3 months, and then single therapies with a potent agent. Always the primary endpoint is bleeding, and secondary endpoints thrombotic events. If we look at these meta-analysis results, we'll see that over 32,000 patients, half of them were stable, administering dual therapy for more than 3 months, then there's an increase in bleeding. 40% increase of bleeding in patients that extend the therapy beyond 3 months. So we could continue with a P2Y12, and with that we wouldn't be increasing thrombotic events. Death, MI, stroke do not change. So bleeding is reduced by 40%. And I think this is an appealing option when treating high-risk patients. There's one more question to answer. I think we are on the way. When the patient completes the guideline times, single therapy should be done with aspirin or a more potent agent like Completo or other P2Y12 inhibitors. The first question, which is not definite, but first question was in the American Cardiologist Congress. After the recommended month of dual therapy, that is 6 to 18 months, patients were randomized to continue with aspirin, as we do on daily routine, or continue with clopidogrel as a single therapy, discontinuing aspirin, and continue for 24 months. The primary outcome, thrombotic and bleeding, was reduced by 20% when you treat patients with clopidogrel instead of treating with aspirin after dual therapy is completed. And if you look at secondary thrombotic events, not only bleeding is reduced by death, IM, and MI and stroke and bleeding. So we need to treat 50 patients in order to avoid major event when you use single therapy with clopidogrel beyond the dual therapy time. So, my friends, conclusion, with the development of new generation DS, we have significantly reduced the rate of stent thrombosis, so patients can be treated in a shortened therapies. Chronic patients are patients with high risk of bleeding, just as acute patients, and have low rate of cardiovascular events. So probably in these patients, we should shorten DAPT and give clopidogrel, which is the most used drug. This is what the American European guidelines state, to shorten DAPT. And they base this on studies are up to now the only thing we have available. We could say that we could use a more prolonged DATP beyond the 6 months set by the guidelines in those patients that do not have high risk of bleeding or that would have, a very complex PCIs. And finally, single therapy with P2Y12 inhibitors is a very appealing therapy for more complex CPIs. Is a therapy that we should consider when deciding to continue with a single APT. Thank you, Ernesto, for your presentation. Excellent presentation. The way you approached the topic. We'll continue. We have some time later for discussions. Now I'd like to introduce the next speaker, Dr. Alfredo Rodriguez, Director of Intervention Cardiologist of Buenos Aires and Director of the Training Program for Fellows in Cardiology in the same hospital, and Editor-in-Chief of the Argentine Cardiologist Journal, Dr. Alfredo Rodriguez, also a scientific director of SOLACI-CACI Congress, will be addressing selection of the best P2Y12 in patients with acute coronary syndrome and STEMI, evidence from registries.
Gracias, José. ¿Están viendo la pantalla?
Sí, Alfredo, muy bien.
Perfecto. Bueno, vamos a tratar en estos 12-15 minutos de ver cuál podría ser la mejor estrategia de P2Y12 en
In the next 12 minutes, we're going to see what would be the best selection, what would be the selection of the best P2Y12 in patients with ACS and STEMI. We know that there are some randomized trials that are very important today, but that is going to be discussed by Hernan Katsaris. So I'm just going to talk about the evidence that comes from the registries. I have no disclosures for this talk. In 2018, we published this review in Pharmacology, Clinical Pharmacology magazine, and I had up to then I didn't exactly know what was the best P2Y12 to use in patients with PCI and ACS, MI, sorry. And we learned a lot after this, and I had things much clearer. If you go back in time, the first comparison between prasugrel and clopidogrel, it lowers in combined events of death, infarction, and stroke, significantly lower to prasugrel, but it had more bleeding incident, especially less infarction but more bleeding in patients above 75 years old, and in those that had that weighted less than 60 kilograms. So there was a warning that those patients that had prior strokes, it was not recommendable, contraindication. So this one was published in Plateau trial, the Plateau trial in the Journal of Medicine, London Journal of Medicine, and it was head-to-head, both clopidogrel and ticagrelor. It's a reduction of combined events. In this case, they also showed a reduction of a severe infarction with no increase in the bleeding, so the ideal situation. However, when you start going deeper in this topic, you find other analysis, other publications like this one, where they discriminated a very detailed discrimination because Plateau trial was multinational, and they describe in detail the MACE by country included in that trial. Look at the majority of the benefits in this trial of ticagrelor over clopidogrel was in 2 countries where they decided that it was not independent and it belonged to the trial sponsor. In all the other countries, there was a great range of efficiency. In Argentina, actually, there were no differences in the MACE between the 2 treatments, and in the US, 1,400 patients, 700 in each arm, the final result was not different, even though it was much higher in the ticagrelor group. All the numbers are not different. Simultaneously to this trial, to this Plateau trial, they did the Philo trial that covered Japan, South Korea, and Taiwan. And it also compared ticagrelor with the clopidogrel, and it was a smaller trial. It was published several years later, only in 2015 this was published, and as opposed to the other trial, the Plateau trial, clopidogrel here had less bleeding, significantly less bleeding, as we can see on this slide, significantly less bleeding in clopidogrel. No differences in the combined points, 9% in ticagrelor and 6.3. So it was not significant, even though in numbers, in pure numbers, it was smaller in the Philo study with clopidogrel than ticagrelor. So what is the last information that we collected regarding this topic? Coming from the registries, the large registries and meta-analysis. This was a registry that for me, it was really impacting. It was the first one I read. It was by John Petrobreck. It's a registry of the Catheter Association published in the CCI in 2015. 14,000 patients, 15,000 patients included the unmatched population, but the unmatched is 2,600 patients in each group. And if we take a look, 30 to 90-day results, the composite and endpoint of MACE was significantly lower in this trial with prasugrel and ticagrelor MACE was significantly lower and no differences in bleeding. Let's take into account that we're talking about infarction with STEMI. Another paper that was really valuable in this is this network meta-analysis that we all know that it was done in the US. It was published in the JACC intervention. And we all know the mistakes that the network meta-analysis have. The meta-analysis may have a lot of mistakes. This is a network meta-analysis because the sample size of the studies that are compared, of the trials compared, can be different. But there are 88,000 patients that were collected in 22 trials. This is the MACE after 30 days, and 1 year after it was a lower MACE with prasugrel compared to ticagrelor and clopidogrel. The mortality was lower with prasugrel compared to ticagrelor and clopidogrel, with no differences once again in bleeding between prasugrel and ticagrelor. This meta-analysis was published in 2016 in JACC interventions. By that time, when we had to review and publish that review, we did bullet data of several meta-analyses that had been done in Europe. Registries that have been done in Europe by that time. And they were 84,000 patients were analyzed, but bullet data only. As you can see here, prasugrel in red is in blue, ticagrelor in red, and clopidogrel in green. No differences in the bleeding among them, and there is a differences in the in-hospital overall death and the 1 year overall death between clopidogrel and ticagrelor. This is in patients with ACS submitted to PCI. Let's not get confused. In that review, we concluded that despite the fact that all the registries that we had reviewed, they favored prasugrel, but there were not randomized trials, and if there were not randomized trials, you cannot be so definite about one thing or the other. Therefore, we left it to the operator or the clinician to choose when they had an ACS patient what type of P2Y12 they were going to administer. So from 2018 up to now, I think there is a lot more information. I was very much impressed by this registry from from Great Britain, that was published in Heart. 89,000, more than 89,000 patients. We compare results between prasugrel, clopidogrel, and ticagrelor. In the first panel, first is clopidogrel, second is prasugrel and ticagrelor, and the arms had no differences in the bleeding. And once again, MACE mortality after 30 days to a year is lower, significantly lower in prasugrel than in ticagrelor and in clopidogrel. When they had 89,000, since they had 89,000 patients, they might have multivariate logistic regression models. And there we see that prasugrel with ticagrelor don't have a lot of differences in bleeding and has lower mortality, 30 days, and 1 year mortality also lower. I think that's very important in a registry with 89,000 patients that comes from the Catheterism Society from England, from the UK. This study, we have no time to read all this, but we are going to talk about the conclusions. The conclusions that they say, the author says, in a cohort of just over 89,000 patients undergoing primary PCI for STEMI, in the UK, prasugrel is associated with a lower 30-day and 1 year mortality than the other two, P2Y12, and the authors also say that taking into account that it's pretty unlikely that a randomized trial will be undertaken with a power similar to this one, to compare them in the future, these data may have implications for routine clinical care, which I adhere to. I completely agree. This is 2018. And after that, we have early studies, a registry, a Swedish registry, but here this is not STEMI, this is NSTEMI. We know that the registries in Switzerland, in Sweden, they always do it with very, very high quality. In this registry, they find non-STEMI and STEMI more bleeding with ticagrelor compared to clopidogrel, and the incidence of mortality in this registry, in this Swedish registry, was 0. No difference in the mortality rates. And what they conclude when they talk about the clinical perspective, they say that this Swedish registry has a lot to do with what was recently published in this, the Popular A trial, which tried to compare Popular H, clopidogrel versus the mix between prasugrel and ticagrelor in patients that were 70 years old or older, but since finally 95% of the patients in the arm that they were going to compare, they used ticagrelor and not prasugrel, the comparison was direct, ticagrelor versus clopidogrel, and that gave us the results that older patients, 70 years old or older, those patients treated with ticagrelor bleeded more and had the same incidence of events than those treated with clopidogrel. And what they say that adds value to this study, well, they say that it was the first randomized trial to investigate clopidogrel versus ticagrelor on patients older than 70 years old, that they didn't have a non-ST elevation acute coronary syndrome, and clopidogrel could be an alternative, a favorable alternative to ticagrelor in patients that are older because they have less bleeding, but it increased the combined endpoints of all-cause death, myocardial infarction, and stroke. So we'll see what happens in our country. This is a registry that was presented in TCT 3 years ago. It's a registry to assess MACE in patients with new stent designs, new generation stents. 15 centers in Argentina. In Colorado, in red it's prasugrel, blue clopidogrel, red prasugrel, and ticagrelor is in green. The purpose of this registry was not to see differences in the event, but it showed first that in Argentina, despite what the guidelines say, the P2Y12 that is most frequently used is still clopidogrel. There was no difference in bleeding between prasugrel and clopidogrel, but there was difference between prasugrel and ticagrelor, and there was more mortality incidence between prasugrel and ticagrelor. That doesn't mean absolutely anything. It's not the purpose of this study, but it's just to show that this registry that we did here in Argentina with 2 new generation stents gave us the same results that we see in the other registries. And to end, a question that we ask ourselves is why there was so much bleeding difference between the original studies of Completo and Trident, which was what led all the treatment guidelines. When we analyzed it in Plato, they were patients that were intended to treat with conservative strategy. We did an angioplasty in Plato, more angioplasties in Plato, in Trident 61%, and that's the most important thing. The biggest number of patients that had bleeding issues it was because they used abscisimac during the angioplastic. A lot less frequently, it was used in Plato, 26% versus 54% in Trident, and there were bleeding differences. The bleeding in clopidogrel was 2% in Trident, 2%, and in Plato it was 11% of bleeding complications. And as a conclusion, and summing up, it is my knowledge that I did not find in the literature any registry that say that in the case of ACS, especially including STEMI, ticagrelor is better than prasugrel in terms of reducing adverse cardiac events. Much to the contrary, almost most of them reported lower MACE, lower NACE, lower mortality, and similar bleeding incidents. These findings should be added, I think, to current RCT data, randomized trials, of course, including the most important one, the one that is going to be presented now by Hernán Castreto, which is the ISAR REACT. And ticagrelor and clopidogrel should be used balancing patients' risk-benefit of each of them at the time of the procedure, as suggested by the Swedish registry and the Popular Age registry that was recently published. Last but not least, this picture that I really loved. We have Messi, we have the Brazilian fan, who's great, and a Uruguayan player. The three of them are very good friends. Neymar is very good friends with Messi. They can all be very good, maybe individually, but without a doubt, they're much better when they get together. Our countries are much better when we get together, and very beautiful things can come out, such as SOLACI-CACI. Thank you very much for your attention.
Thank you.
Presentation and a beautiful picture, a very beautiful picture. You're absolutely right. You need to be together always. We can do much better if we are together. And congratulations to this very important meeting you helped enable in all the organizing committee to organize. So it's my pleasure to introduce now Dr. Roxana Meran from Mount Sinai Hospital and Mount Sinai School of Medicine in New York. Her lecture was recorded. I would ask the organizers just to put there on screen.
Hello, I'm really thrilled to be here at SOLACI-CACI 2021 with my dear friends in Argentina and to talk to you about current indications of ticagrelor. These are my important disclosures specifically to the Twilight trial, which I led through a grant from AstraZeneca, but sponsored by the ICANN School of Medicine at Mount Sinai. What is ticagrelor? It's a P2Y12 inhibitor that is reversible, unlike clopidogrel, prasugrel. There is no need for bioactivation. The dosing is about 180 milligrams loading dose, 90 milligrams or 60 milligrams BID you have to give to him. It's important to note that it's a rapid onset of action of a half an hour to 2 hours, but the offset effects can go on for 3 to 4 days. And how long you have to wait before you send a patient to surgery if you give ticagrelor is about 5 days. There's no need for dose adjustments in kidney disease, and there's very limited data on dialysis patients undergoing PCI. This is very different than the other P2Y12 inhibitors that are out there, especially the thienopyridines, clopidogrel, and prasugrel. Both are irreversible, clopidogrel and prasugrel being prodrugs. and of course, prasugrel being once a day, and the onset of action at about half an hour to 4 hours, and the offset up to 10 days. And I think it's important to note those. And of course, canrelor being an adenosine triphosphate analog, a reversible, quick on, quick off, and no delay with very limited data on dialysis patients is something for us to think about. The very first study that really, I think, solidified the use of ticagrelor in patients with acute coronary syndromes was the Plato trial. And I think it was a very well conducted study in all comers acute coronary syndromes with or without STEMI. And the patients could be on clopidogrel treated or naive. They were randomized within 24 hours of the index event. At the first medical contact, they received either clopidogrel or ticagrelor. So it wasn't just PCI like it was in prasugrel study, TIMI 38, and they had 6 to 12 months exposure with a primary endpoint of cardiovascular death, MI, and stroke. And unquestionable that ticagrelor was associated with a reduction in the primary efficacy endpoint of cardiovascular death, MI, and stroke, with no difference between their major bleeding, but this was Plato major bleeding. If you looked at TIMI, CABG, non-CABG related bleeds, it was absolutely increased. It's an important notification that when you give a more potent agent, you will have more bleeding, and indeed there is more bleeding with ticagrelor compared to clopidogrel. We also have a very, very important study that is part of the outcomes trials that AstraZeneca has performed in looking at the efficacy of ticagrelor in different patient populations. Here are patients who are who have stable with a history of myocardial infarction or other additional atherothrombosis risk factors. The Pegasus TIMI 54 study looked at 2 different dosing of ticagrelor in these high-risk patients versus placebo with a background of aspirin, and followed these patients out for a good long period of time, up to like 3 years. And you can see here that the treatment with either dosing of 90 or 60 milligrams of ticagrelor was associated with a reduction in cardiovascular death, MI, and stroke in these high-risk patient populations. And I think this is a very, very important study to tell us that long-term use of ticagrelor in these patients could be beneficial. But there was a price to pay. When you reduce ischemic events with ticagrelor versus placebo, you will increase bleeding. And certainly this was the case. There were more bleeds, but intracranial and fatal bleeds were no different. But there were TIMI major bleeds were significantly higher with either dosing, less so with 60 milligrams compared to 90 milligrams. And as a result, if you look at the focused update on the duration of DAPT, you're seeing class 1 indication for ACS up to 12 months, pretty much for everyone, whether you're receiving medical management or STEMI. And you can see that ticagrelor is listed there for both medical management as well as in PCI patients. For prolongation beyond 12 months, even with Pegasus available, this was a 2B recommendation. And you can see that here, again, once again listed, a class 1 in the patients who are managed with medical therapy alone, without revascularization, treatment with clopidogrel or ticagrelor continued for 12 months. In patients, of course, daily aspirin being low dose, and then in patients with non-STEMI ACS, again, a 2A recommendation for ticagrelor over clopidogrel, and I think that's important to note. The other recommendations in terms of prolongation and for how long, in ACS 12 months, and clopidogrel, prasugrel, and ticagrelor are both listed. And then, of course, in ACS patients, for preference over clopidogrel of ticagrelor is a 2A recommendation. And then, of course, the 2017 ESC focused update on duration of DAPT. You can see that they shortened it in a lot of the patients, but once again, you can see that ticagrelor, being T in blue, is present pretty much in for PCI patients with an acute coronary syndrome of no high bleeding risk up to 12 months, high bleeding risk at least 6 months, and then beyond that, a 2B recommendation. Also, it's important that we look at the 2019 guidelines for the management of chronic coronary syndromes, where prasugrel and ticagrelor are given a 2B recommendation. So not a class 1 for chronic coronary syndromes, because we just don't have any data available there. Now, in THEMIS, which was a study completely devoted to diabetic patients, and THEMIS was a very, very good study, and if there was a history of PCI in the THEMIS, the overall THEMIS study did show a reduction of death, MI, and stroke in patients who received ticagrelor versus placebo with diabetes. But actually, if you look at those who had a history of PCI, those were much, much better results. There was a major interaction with a big effect in patients who had prior PCI, as you would imagine. The global leaders investigators also looked at ticagrelor monotherapy after a month of aspirin and ticagrelor in an experimental strategy with a primary endpoint of looking for superiority in reducing all-cause mortality and Q-wave MI. They just missed that endpoint, but very important is to note that there was no signal of harm, and ticagrelor seemed to be, monotherapy seemed to be just totally fine compared to the standard of care. And we actually performed a double-blind, placebo-controlled clinical trial of over 7,000 patients, 7,119 patients randomized to ticagrelor plus aspirin versus ticagrelor plus placebo, and we showed a definitive reduction in BARC 2, 3, and 5 bleeds, which was our primary endpoint. With the key secondary endpoint, we showed non-inferiority, no signal of harm, very similar outcomes of the hard endpoint of death, MI, and stroke. So nothing to pay back, just reduce bleeding when you drop aspirin. I think it's a very, very important study that should help. And then our Korean investigators followed soon thereafter with the TICO randomized trial, which focused on the acute coronary syndrome patients. These were STEMI and non-STEMI. We did not include STEMI patients in Twilight. Here they showed a reduction in the composite of death, MI, stent thrombosis, stroke, TVR, or TIMI major bleeds at 12 months with a ticagrelor monotherapy after 3 months of aspirin and ticagrelor compared to a ticagrelor-based 12-month DAPT. All of this reduction was mainly driven by reducing bleeding complications and no change at all in the ischemic complications, so very similar to what Twilight. But I think the very important, I told you all these great studies for ticagrelor, but there is a study that we should not oversee. We should talk about it. The ISAR REACT study, REACT 5, very, very well conducted study by our colleagues in Germany, where they looked at STEMI and non-STEMI patients. They had different randomization protocols for ticagrelor versus prasugrel, especially in the non-STEMI patient population. But the idea was to see the differential effect of prasugrel versus ticagrelor. They were really going for a reduction and a superiority of ticagrelor over prasugrel with the primary endpoint of death, MI, and stroke. And they found the exact opposite, in fact, much worse ticagrelor having higher rates of death, MI, and stroke, and no difference in bleeding complications, which left one to say, wow, what does this mean? Do we change everything and just go to prasugrel? And I would say that when you see a trial that has some questions, for example, you reduce these very, very important hard endpoints significantly by an order of with a harm of 36%, but you have no difference in bleeding, it just doesn't fit. And also, when you see something like this, you would like to see a definitive second study to actually to actually corroborate with this evidence, and also noting that in the randomization, about 20% of the patients did not get the assigned therapy that they were supposed to get. That's in the New England Journal article. The authors were very open about that. And I think those are important things that should be corroborated. Nonetheless, we have to look at these data as well. And if you look at the guidelines of the 2020 ESC guidelines, they did give prasugrel over ticagrelor for ACS patients, but they also gave a 2A recommendation for ticagrelor monotherapy in line with what has been done before, which I think is extremely important. They've also said that, as I said, that prasugrel should be considered in preference of ticagrelor for non-STEMI who undergo PCI. That's based on the ISAR React 5. And I think it's important to note that in all ACS, no matter what the treatment strategy is, ticagrelor is really preferred. Thank you so much for your attention. I hope that this covered all the data that we currently have in indications for ticagrelor in PCI. Thank you again. Gracias.
Muy bien. Excelente.
Excellent presentation by Roxana. I would like to ask the panelists.
Now it's my pleasure to introduce the last speaker. This section is it's a very well-known Dr. Adnan Kastrat from Germany, from the Heart Central Institute in Munich, Germany. Dr. Adnan is going to tell us about prasugrel or ticagrelor in acute coronary syndromes. This is our REACT trial, a very important trial. Please, Dr. Adnan, feel free to make your presentation. It's a pleasure to have you with us.
Yeah, thank you very much, Jose, for your nice introduction, Fausto. And also, I would like to thank Alfredo for the nice invitation to be with you today. So after hearing the excellent presentation of Alfredo, and I thought, is there any need to show the data of ISAR-REACT 5? But after that, it was a criticism of Roxana. So you have on one side, you have the data shown by Alfredo. You have also the skepticism of the English colleagues. They thought at the time they published a big registry that probably there would not be a randomized trial comparing ticagrelor with prasugrel. On the other side, Roxana said that there is a need for a second study just to convince people about the advantages of prasugrel. So I think that there is a need to show the data of ISAR-REACT 5 trial, although they have been published and they have been also published in several subgroups. So this was the rationale of performing this trial. So we had at the time, we initiated the trial, the results of the Triton TB38, and prasugrel was compared in that ACS population, non-STEMI and STEMI patient population with clopidogrel, and prasugrel was associated with the reduction of 19% in the primary endpoint of cardiovascular death, myocardial infarction, and stroke. And also there was an increase in bleeding, but this was not that much. And prasugrel was at the time the first drug to be recommended for acute coronary syndrome patients. A little bit later came the Plato trial. Plato trial was a trial of ticagrelor versus clopidogrel in patients with acute coronary syndromes. And you see also here that there was a 16% reduction in the primary endpoint, which was a little bit, it was the same as in the Triton TB38 trial. That is the combination of cardiovascular death, myocardial infarction, and stroke. Even in this trial, there was a decrease in bleeding if you consider the non-CABG related bleeding. So after these two randomized trials, you see the recommendation of guidelines, European Society of Cardiology guidelines on myocardial revascularization 2018. And in these guidelines, both prasugrade and ticagrelor, they get a class 1 recommendation with the level of evidence B. In the STEMI guidelines, you see that the recommendation is class 1, but with level of evidence A, based on the same studies. And these were the guidelines of 2017. What is the difference between in the recommendation? You see here a very clever recommendation for the pretreatment. The guidelines of non-ST segment acute coronary syndrome 2015 or 18 for revascularization, they don't say explicitly that you need pretreatment, but they say that if you are going to pretreat patients, you have to pretreat them with ticagrelor. And they give a recommendation class 2A. Only those patients who are not able to get ticagrelor, the guidelines recommend giving clopidogrel. On the other side, if you look at the other recommendation regarding prasugrade, they don't recommend prasugrade as a pretreatment. The reason for that is the AGOST trial, which didn't show any benefit with giving prasugrade as a pretreatment as compared with giving it in the Cath lab. And on the other side, on the contrary, there was an increase in bleeding complications with the pretreatment of prasugrade. That's why this is the reason for giving a class 3 recommendation for prasugrade. So the difference in the, if you look at the design here, there is a difference in the design. Ticagrelor was given before angiography in Plato, and in the Triton, prasugrade was given after angiography. And that's why the Triton TV38 was not able to establish the value of pretreatment of prasugrade. We have had one dedicated trial, the Prague 18, to the comparison between prasugrade to ticagrelor in patients with STEMI. And you see here the primary results of the trial up to 7 days. The combined rate of death, brain function, usual target vessel revascularization, stroke, or serious bleeding in this patient population here was not different between prasugrade and ticagrelor. But you have to consider here that the Prague trial had only STEMI patients. Planned, there were 2,500 patients, but it was prematurely stopped after enrollment of less than 50% of the number needed of patients. And the primary endpoint was at 7 days, at hospital discharge, approximately because the cost issues compelled frequent switching to clopidogrel after that. That's why this was the background of initiating the ISA-REACT-5 trial. Prague trial was actually completed after we started the ISA-REACT-5 trial. The aim was the head-to-head comparison of ticagrelor versus prasugrade-based strategy in acute coronary syndromes. The design was an investigator-initiated, randomized, multi-center, open-label trial. The hypothesis, as also highlighted by Roxana, was ticagrelor was superior to prasugrade in these patients, while we had waited or expected the superiority of ticagrelor because we always have belief in the value of pretreatment in patients undergoing coronary stenting. The trial was conducted in Germany and in Italy in 23 centers, and we were able to include 4,080 patients. Major inclusion criteria were hospitalization for acute coronary syndromes with planned invasive strategy, and major exclusion criteria were active bleeding, need for oral anticoagulation, history of stroke or TIA, renal insufficiency requiring dialysis, and moderate or severe hepatic dysfunction. And this is the study design graphically. You see the difference in the administration of ticagrelor and prasugrade for patients with non-ST segment acute coronary syndromes. We gave ticagrelor after randomization, but prasugrade, the loading dose of prasugrade was given after coronary angiography established the need for an intervention. In STEMI patients, as also recommended by the guidelines of STEMI, both ticagrelor and prasugrel were given after randomization. You see also some specific features of the trial. Prasugrel was given in a maintenance dose of either 10 or 5 milligrams for those underweight or older than 75 years. These are the main characteristics of the patient. 65 years old, women were 24% of the patients, and what was most important is the diagnosis and condition. About 40% for both STEMI and non-STEMI. Coronary angiography was practically done in all patients, and the treatment strategy is shown here. PCI, more than 84% of the patients. CABG in only 2% of the patients. Conservatively were treated only 14% of the patients. These are the main results, the primary endpoint. In difference with Triton and Plato, we took all-cause death, not only cardiovascular death, because this is much better suited due to the possibility that also bleeding may cause death. And you see here the difference in the curves between prasugrel 6.9% at 1 year and ticagrelor 9.3%, which means a reduction of 26% in the risk of the primary endpoint by prasugrel. You see also the components of the endpoint here. All of the components are in favor of prasugrel. It's sure the trial was not powered for mortality or for stroke or definite or probable stent thrombosis, but you see that the trend was there for all the components with significance achieved by myocardial infarction. Bar type 3 to 5 was the main safety endpoint, and you see no significant difference between ticagrelor and prasugrel up to 1 year for this safety endpoint. The advantage of prasugrel also extended beyond 30 days, and you see patients with STEMI, patients with non-ST segment elevation, acute coronary syndrome, both you see more, the difference is more evident after 30 days than at the beginning. What is the mechanism that may explain the efficacy or superior efficacy of prasugrel? We have done also a platelet function study in almost 600 patients. This is the largest platelet function study comparing prasugrel and ticagrelor. If you put together all the studies done so far, they have less than 600 patients. And you see here the main results of this sub-study. At baseline, there was no difference in the ADP-induced platelet aggregation measured by multiplate method. But after the intervention, you see the difference here with the ticagrelor, which is significantly lower, and also in the second measurement here, 24 to 48 hours. So prasugrel was able to achieve more platelet inhibition as compared to ticagrelor. Even in this small sub-study with 600 patients, we were able to show a correlation between the degree of platelet inhibition and the outcomes at 12 months. You see that those with more inhibition, they had the best results at 1 year. So you heard also about from Roxana that some people are surprised to see a reduction of ischemic complications, but not an increase in bleeding complications. And I would say some of the reasons for that are loading as pre-treatment in non-ST segment acute coronary syndrome patients was done with ticagrelor, but not in the prasugrel. And large proportion of bleeding is peri-procedural. Pre-treatment increases bleeding, and this was not the case with prasugrel. Another reason for not having an increased bleeding with prasugrel as compared to ticagrelor is the adaptive dose of prasugrel in patients older than 75 years or less than 60 kilograms. On the other side, ticagrelor was given in a full dose in these patients. We have published data specifically for this, and you see that for elderly or low weight group, the prasugrel has a lower bleeding rate as compared to ticagrelor, and for the other patients, neither elderly nor low weight group, you see that prasugrel has a higher rate. That means that we have prevented the increased risk of bleeding with both this avoidance of pretreatment with prasugrel and also adaptation of the dose in these high-risk patients for bleeding. What are the limitations of these REACT-5? You hear many times, there have been also publications. The results are valid only for patients planned for invasive management. Patients in the ISA-REACT-5 trial had 100% coronary angiography, and it was 81% in the Plato. 84% had PCI, 61% only in Plato. And you see that exactly in patients who got PCI, there was more disadvantages with ticagrelor as compared to prasugrel. If you compare the main results with 1.36 for ticagrelor versus prasugrel, in the PCI group there was 1.41. Let's look at some details from the Plato trial. This is the main result in the Plato trial, comparing ticagrelor to clopidogrel, 0.84. But if you divide the population in those with angioplasty and those with medical treatment, you see that the benefit of ticagrelor was mostly seen in patients treated medically. There are other limitations. It is an open-label, industry-independent trial, but you know that manufacture of placebo pills for drugs under patent protection, as they were both in the time we initiated trials, is almost impossible without involvement of industry, which was not interested in the study. Several recent drug trials with important impact have also been open-label. Remember, Pioneer, Redual, Trust. For only 4,018 patients. For sure, 40,000 would have been better, but trial impact on the practice is not necessarily dependent on sample size. With only 500 patients and 1,653 patients, both ESA and STARS trials changed the practice of antithrombotic therapy after stenting. And you know also all these trials, Pioneer, Redual, Augustus, Trust, they have also 1,500 patients to 4,600 patients in total. 30% of the patients, it was also mentioned by Oksana, of patients prematurely discontinued the study drug, more often ticagrelor. 23% discontinued ticagrelor in Plato, but it's not a big difference between them. In ISA-REACT-5, 10% of the patients had no obstructive coronary artery disease, and we don't know the exact number in Plato. But more frequent discontinuation of ticagrelor due to dyspnea is a limitation of the drug and not of the study. So what to do with comparing two new drugs? You can follow two ways. First, you can apply the transitive law or make a direct head-to-head comparison. What is this transitive law? And it was also very often used by those who are who don't like the results of the ISA-REACT-5 trial. So they say in the Triton Kimi 38, it was a 90% reduction in the primary endpoint with prasugrel versus clopidogrel. In the Plato, it was a 16% reduction with ticagrelor. And they follow this logic here. If therapy A and therapy B show comparable advantage over therapy C, as is in the case of clopidogrel here in several studies, then therapy A is equivalent to therapy D. But there are differences, big difference between Triton and Plato. They were also mentioned by Alfredo in his talk. Prior clopidogrel was not used in Triton. 46% of patients in Plato had prior clopidogrel. PCI was used in almost all patients in the Triton, 61% in the Plato. Cabbage was used more frequently in Plato. And the start of the study drug in patients with non-ST segment acute coronary syndromes was up to 1 hour after PCI in Triton and up to 74 hours before PCI in FLAT. So we have seen this the failure of the positive law also in BEST trial. We know that sirolimus eluting stents was associated with 75% reduction in target tissue vascularization as compared with bare metal stents. In the Taxus, it was 73% with paclitaxel eluting stent. So you may think here sirolimus eluting stent is equal to paclitaxel eluting stent due to the similar difference against the bare metal stent, but in reality, the sirolimus eluting stent was associated in direct comparisons with 24% reduction in target lesion vascularization as compared to paclitaxel eluting stent. And you know that the standard drug now for drug-eluting stents are those of the Demos category. The guidelines, the new guidelines of the ACS, they have been also mentioned by Roxana. Prasugrel should be considered in preference to ticagrelor with the class recommendation 2A and evidence of B based on the ISREF 5 trial. But you see that this has also an impact. In April, you may read in the TCT-MD website that ticagrelor's dominance over clopidogrel is again questioned, and this was also the study mentioned by Alfredo. And the authors here, they are saying in the interview with TCT-MD that hospitals in the Camden region, is this region around Liverpool here, in Northwest England, are moving back to clopidogrel as first-line therapy, particularly for medically treated ACS. But for patients who undergo PCI, they say that they are moving to prasugrel based on the results of the ISREF 5 trial. Thank you very much for your attention.
Okay, thank you, Dr. Adnan Kastrat, for your presentation. Always a nice presentation. We are a little bit late on time, so yo me gustaría nestes últimos minutos, tenemos 3 minutos.
We have 3 minutes for some questions, but I'd like to know, to listen to Ricardo Iglesias, to just an overview of the presentations, some specific point that you'd like to address. Well, it's a comment. Well, first of all, SOLACI-CACI is, the organization is perfect. So 2 things I like to say. I think that interventional cardiologist has made so much progress. I mean, today, thrombosis, early thrombosis, recurrent anginas. I mean, a lot has been done with DAPT, but now we have an interesting challenge, which is how to reduce bleeding. That is a crucial question to ask. And thanks to the new stents, we can, and as a cardiologist, as a clinical cardiologist, is to understand the patient, because after a month or 2 months, it is the general cardiologist, the one that will see the patient. So we need to understand who are the eligible candidates or patients that we need to aim at. And high risk, ischemic risk can actually not benefit from this. But as a clinical cardiologist, and this is thanks to the new stents that are less thrombotics, and this gives us a lot of benefits. Thank you for the invitation.
En estos últimos minutos,
The next few minutes, I would also like to listen to Pablo Subak. I agree with what Ricardo said. The question is, how do we put this into practice, and the quality of the procedures? I mean, when we see the evidence, there's a lot of IVUS and OCT particularly for very complex CPIs. In Argentina, complex procedures, not in every place. We have IVUS or OCT for a proper placement of the stent or proper positioning. When we speak about technological breakthroughs, I agree with Ricardo, but in Argentina, this difficulty we have, quality control of procedures and the DAPT. Isn't this sort of something that conditions us? And then it is clear that Prasugrel has become important. I remember the article published in Circulation that warned us about, that told us about its efficacy and that how we could attenuate bleeding and its strategies. And I believe that clinical cardiologists should know much more about the procedure that was conducted on the patient, how stents are positioned, the clinical variables, and we have to get involved in the follow-up in terms of the procedure. This is why I insist on safety and quality of the procedure, particularly complex PCIs. Very important, Pablo. In this particular point, the use of IVUS, the use of OCT in procedures. Omar Santaera, what's the role of this technology to provide safety of the therapy for DATP? Omar, just a brief comment. Thank you and congratulations. We all know, and all of these studies have shown that using intravascular imaging simplify the deployment of stents and improve results. And the better results we get, then better evolution in the long term, and the antiplatelet therapy, either single, dual, or triple, will have better results. But we need to know that all of these studies are related to imaging. On a daily routine, images are used very little, particularly in our country due to many reasons, mainly financial reasons, because it's not possible to use them. So we need to try to get the best result possible from the angiographic point of view with the best devices available, because we need to consider that all of these studies are related to a particular type of stent. So I'd like to ask Dr. Rodriguez or Castrati whether, these good results in single, double, or triple therapy are admitted for all of the stents in the market, because it is quite heterogeneous, the systems that are used. Thank you. We don't have time, Alfredo. I am so sorry, but I have to wrap up. So, two things I'd like to say, two invitations. The Microport today at 7:45, there's a symposium, and then the closing ceremony of SOLACI-CACI, also in the main arena at 8:45 Argentine time. So now I'd like to thank you all for your participation, Fausto Freires and all of the panelists and the speakers. Wonderful presentations. Congratulations. Let's continue now with the next sessions. Thank you. Thank you all.
Buenas tardes a todos.
Good afternoon, everyone, and welcome to this new session, last day, SOLACI-CACI Congress Day. We'll continue with the scientific program. This session is on a global concerning issue regarding the pandemics, and the title of this session is Cardiovascular Disease Management and Cath Lab Management during COVID-19 pandemic. I'll be moderating this session together with Dr. Alfredo Rodriguez. The digital moderator is Raúl Solerno. I'd like to remind the audience that you can contact the digital moderator to send questions, and there's also an interpretation icon from Spanish into English and vice versa. Without further ado, I'd like to give the floor to Alfredo so he can introduce our first speaker. Thank you very much, Aníbal. This session will deal with cardiovascular disease management during COVID-19 and the experience with colchicine that will be discussed by Dr. Rafael Diaz. The first talk, well, I introduce Dr. Giuseppe De Luca, who carried out a huge prospective registry of acute myocardial infarction in the primary PC in COVID-19 era, where we can see the differences that took place along the pandemics. How do we treat and manage cardiovascular disease? So it's an honor to introduce Giuseppe De Luca. Giuseppe, the floor is yours.
With pleasure and honor. Can you see the screen?
We are see you.
Yeah. Okay, sorry.
I see you very well. You are in summer. Nice weather.
Sorry, let me see, because I have problems in sharing the screen. I'm a guest I'm in the office. I was on holiday. I'm in an office of a friend of mine. He has the Mac, and I'm not very practical with the Mac, so I'm trying to.
Yeah, with the Mac.
Sorry to.
No, it's okay. Después de la charla del doctor Giuseppe.
After Giuseppe De Luca's talk, we're going to have several complication cases, thromboembolic complications due to COVID, that have been selected by the scientific committee.
Screen, because this is a Mac. I'm not used to it. So please go ahead. I will try. I will ask somebody to help me. Sorry for the.
Nosotros vamos a
So I'd like to invite the second speaker, Dr. Jose Cereceto from Argentina. He's going to talk about thromboembolic complications in COVID-19, and then we will get back to Giuseppe De Luca. Dr. Cereceto, are you ready? All right. Thank you very much for the invitation.
Vamos a hablar. Acá estamos. Perfecto. Ahí se debe ver bien.
Now you should be able to see. We should talk about one of the most interesting areas within this COVID world, because of what we're going to talk about is the thromboembolic disease within the disease due to coronavirus and the coagulopathy that happens in these type of patients. The reality is that the pandemic due to COVID, we just discussed that, has changed the history of humankind and the way we relate with one another. What something seemed to be a simple flu and a severe pneumonia, in fact, it's pretty different from that. And probably a visionary of this was Sir William Osler, when in 1904, when we didn't understand anything about physiopathology. He, in beautiful quote, said, "Except in few occasions, patients appear to die as a response of their body to the infection more than the infection itself." And that is exactly what's happening in these patients that have pneumonia due to COVID-19. In fact, it stopped being an infectious problem. The antivirals are not very efficient, and the key word here is the thromboinflammation, and this has to do with the fact that there is not only fibrini macrophagotes and other infection elements, but there is a pro-inflammatory frame, which was called cytokine storm, activation of the macrophage, the endothelium, the tissue factor, the coagulation factors, they free microvesicles, particles, and all of that activate coagulation, activate the endothelium, the platelets, and the mitosis and DNA of neutrophils, and that's also a prothrombotic factor, and all that activate their antiphospholipid elements, and that's the perfect storm for this type of thromboinflammation. And there are hypothrenolitis due to PAI1, and this perfect storm, what happens is that it produces thrombosis, microvascular thrombosis, and that explains the very high level that appear in the patients, and we couldn't understand why there were so many values. In the first pathological anatomy reports in China, we saw that there were not only superficial thrombosis, but microthrombosis. And in other studies with autopsies, we were able to prove that the arteries in the lungs and other nervous system, like in the kidney, in the heart, they also have these microthrombosis factors. And when you compare the pathological anatomy between autopsies done in patients with COVID or due to a pneumonia, due to N1H1, there were nine times more thrombosis. So we start to explain this phenomenon of the double hit in the lung, double damage, not only in pneumocida due to the pneumonia, but also in the microvascular environment with microthrombosis in the endothelium. And that's why tissues do not get enough oxygen in these patients. So the most recent definition is that it would be a microvascular COVID-19 lung vessel obstructive inflammatory syndrome. So that would be a microvascular thrombosis that happens in these patients. When you start reviewing the incidence, what is the frequency of thrombosis, especially in vein thromboembolic disease and lung thrombosis, the early studies talked about the 12% thrombosis in the QI report of 2020, but the Chinese did not do thromboprophylaxis. So we blamed, okay, if they don't do prophylaxis, of course, they're going to have thrombosis, a patient that has a lot of risk factors. In Europe, they started to have new studies started to show up, one in Italy, where there was a higher incidence of thrombosis, 16 and up to 21% of thrombotic events. And the Dutch did a very interesting report about there was a 49% accumulative in the clock report in research of venous thromboembolic episodes, especially when you screen the patient with echo-Doppler, serious echo-Doppler. And then another one from the Netherlands, another trial with 198 patients that were in therapy, they also had a very high incidence. When we review the meta-analysis, 89 studies, 66, the NOP or Fontalop, what we find is that there are between 25 and 28% of thrombosis, of vein thrombosis in these patients, and also artery thrombosis, and up to 8% in hospital. But 19% of the patients are symptomatic, and 5% in the emergency room and 5% in the regular rooms. The recent study with SATI-COVID was very interesting. It's Estensoro Lancet Respiratory Medicine of July 2021. Only 9% had thrombosis of those who were in therapy with a respirator, but they never looked for or researched in an adequate way the thrombosis disease. And in up to 70 to 90% of the cases, when we do the autopsies, they find thrombosis. When you find it systematically with the angiography in intensive care units, 25% thrombosis. That is much more than you should expect for patients who are in intensive care units, compared to the epidemics of N1H1 when we didn't have these high numbers. Therefore, what you can say is, okay, we are having a lot more thrombosis than expected, both in the artery level and in the vein level, up to 5% of stroke, 15% of ACS, in ECMO patients, more than 20% of embolism. So the risk factors are varied. As we said, the hypercoagulation is key. There are other factors like age and rest, hospitalization in the intensive care unit, infection, sepsis, main arteries, and all of that makes a Padua score that is pretty high in most of half of the patients. The diagnosis of thromboembolism is pretty complex as well, because this is what happens with the vein thromboembolic disease and ETP. In fact, most of the current guidelines, this review of CHEST in December 2020, there is a high clinical suspicion that patients get worse when they saturate oxygen, asymmetry, tachypnea, inexplicable increase, and hemodynamic instability. And we can do treatment even when we don't have the thromboembolism confirmed in the lung. We always need to use the PERP committee for these patients. In conclusion, the infection due to COVID is a micro and macrovascular thrombosis in the lung with coagulopathy that is induced by COVID, and all patients have a lot of risk of vein thrombosis and lung thromboembolism and artery thrombosis, not only for the clinical risk factors, but also due to this thromboinflammation. We proved, for example, in a paper that was awarded in the Thrombosis Congress, that they had 50% of those patients had LAC positive, and that's another thrombophilia that is acquired. And the more we look for it, the more we're going to find it. Let's remember that the diagnosis is particularly difficult. The DNRD is not, it doesn't work because it's too elevated. The clinical score, Wells clinical score, it is not useful either. The patient cannot refer its symptoms, especially if if it's intubated. And moving translation is complicated due to the contagion. And the treatment is complex due to the heparin use. Heparin in COVID has several aspects. There are some researchers that are looking for the treatment with anticoagulation in these patients may improve the infectability and the death due to COVID, regardless of whether they have thrombosis or not. This is a different chapter, but heparin can prevent the access of coronavirus in the endothelium, and in the membranes, and this is a protective mechanism of heparin. We know already the mandatory prophylaxis for all patients. Even they have proposed and they have published recently intermediate doses and anticoagulant doses for those patients due to the anti-inflammatory effect and immunomodulator of the heparin. Sodic heparin is a little bit more complicated to deal with in the anticoagulant treatment of these patients with COVID, but for 3 reasons. The first, heparin is very difficult to monitor with the APTT or KTT because the patient is already activated in the coagulation with a fibrinogen factor very, very high, and that makes the KTT not to move. They are refractory to the heparin. So those who have positive LAC, in general, there are many patients, like between 30 and 50% of the patients have a prolonged due to the heparin, and that makes it very difficult to monitor. And this publication that came out this year shows why the sodic heparin is very difficult to manage. Positive cases of COVID had 10% less in the range of those who were COVID negative, and these patients had 3 times more bleeding and 4 times more clinical bleeding. So sodic heparin is a lot more complex in these patients with COVID infection. Heparin of low HBPM as an anticoagulant treatment should be the first line of treatment. In Argentina, we use enoxaparin 1 milligram per kilogram every 12 hours, but we could use any of the heparin. Sodic heparin only in special populations, the ones that are in ECMO or they're unstable hemodynamically or who have a clearance between 15 and 30 millimeters per minute. Not using direct anticoagulants in these critical patients, not at least at the beginning. Maybe when they're discharged, we could administer the direct ones. But this makes very difficult to manage the patient due to the monitoring that anticoagulants required. Thrombolytic are useful. In some reports, they have even used as part of the basic treatment. I don't need to confirm diagnosis with the imaging. And thrombophlebitis, superficial thrombophlebitis, has to be treated as a VPT, and there are 3 months of anticoagulation associated to COVID because it's a transitory risk factor. This patient does not need to be anticoagulated all their lives. So we continue with the anticoagulant, and 3 months after, it disappears in most of the patients. There is lots of evidence, new evidence that is being published all the time. In fact, without going too far away, 3 days ago, the Actic-4 and ATTACK and REMACAP trials were published, where they tried the heparin of low weight in patients that were in their regular rooms and the ones who were in the intensive care unit. And this was done by Tenkate, a Dutch person. The patients who received doses, prophylaxis doses, used intermediate doses. Then we don't know really well how efficient that was. And clearly, patients who are in regular hospital rooms, they benefited from the anticoagulant doses, but patients that were already in the intensive care units, they were not benefited by that. And I always end with some sort of story. With COVID, you cannot play possum. I lived in the world very happy. I got together, I hugged people all the time. I had all my congresses ready, my conferences and my speeches. But one day, COVID came from China. This pandemic, this quarantine is crazy. The virus that joins the angiostensin, cytokine, leukin, you will find all that up to the roof. Everybody says it's a ICD that is coming towards us. All of them have a thromboembolia, but the clinic do not accompany that. We have to be wide awake in therapy, and if we have questions, we have to anticoagulate anyway. They say, "What do you think?" I say, "Okay, look at Padua when they are admitted, and look at the disaster they can cause. Don't forget that the old heparin and enoxid right on time can help, and always think that the KPTT does not work. XA if you have to anticoagulate." Finally, pandemic will pass. This is new in thromboinflammations. I go back to the hospital. I'm really happy. La 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 la. Thank you very much. And I don't know if there are any questions about my presentation. I'm eager to hear. Thank you, Doctor. Really nice summary. We're going to first go to Giuseppe De Luca's presentation, if he is already. He's already? I am not sharing anymore. And then we'll go back with 5 minutes for discussions and questions for both talks.
Can you hear me? No sé si está presente, Giuseppe, el doctor Di Luca.
Dr. De Luca, are you ready? So probably he's in the other room, so I can introduce the panelists. So while Dr. De Luca logs in again, let me introduce expert panelists. So we can start with the first discussion. Dr. Sandoval from Chile, Dr. Marcelo Lac, César Hernández, Pedro Hidalgo, Ricardo Luberas, Dr. Gigal Piñarreina, and Luz Urna. If you'd like to start with comments and questions, go ahead. I'd like to ask Dr. Cerezeto, with the pandemics and coagulated patients, we've seen an epidemics of bleeding, and you talked about how difficult it is to control patients. What's your view on bleeding, and how do you control other parameters such as ACT, other markers that could actually help us, particularly with these specific groups of patients? I'm not on camera, but okay. So bleeding is relevant, of course. In all of these studies, so all of these studies have had bleeding. In fact, The studies I just mentioned from the New England of Journal 3 days ago, the major bleeding was twice as much, patients under coagulation, no coagulation. Monitoring coagulation is quite complex. We use perinemia. ACT is also very difficult to manage because it has the KPTT type of component, and in these patients having so many cytokines and 8 factor levels and very high levels, it is difficult to traditionally monitor heparin. So the international recommendations and what we do is to measure anti-tensed perinemia for these patients. But bleeding is an issue, that's true. It is not that clear that we need to anticoagulate all patients having a COVID infection. In fact, this publication in New England says that therapy patients do not benefit from heparin anticoagulants, and probably at an early stage, once the patient is in the room, then the patient could benefit with an intermediate dose, but we don't know that yet. As I said, there are 24 ongoing studies, a lot of them randomized and prospective, to assess the role of heparin in the management of this thromboapathy that is acquired as a result of COVID infection.
Giuseppe, I think he's ready. Are you ready, Giuseppe?
Absolutely. Thank you,
Okay.
Alfredo. We are just, we had a
Go
problem.
ahead.
I had to send the presentation because probably there was a conflict between my Gmail account and the computer where I'm now. Okay. Can you show the presentation? Okay. Can you hear
Yes.
from me?
Yes, I hear
Okay.
you
Okay.
here,
Great.
and the slides, we are seeing very well.
Yeah, thank you very much, Alfredo. It's a great honor for me to be speaker at your meeting. I'm an Italian, so there is a big Italian community in Argentina. So for me, it's I'm very proud and to be speaker today. Next, please. Go with next. Oh, thank you. Okay, I'm sorry because there are some slides. I had to send the presentation to your technician, and there are the slides that does not seem perfect now. We know that the pandemic, COVID-19 pandemic, started was declared at the end of January. From then, we had more than 200 million cases in the world and 4 million deaths. And now we are, next please, we are now with the fourth wave, at least in Europe, we are facing the fourth wave. Next, please. Okay, next, thank you. Please go before.
Go back, vayan atrás,
Go back,
uno
please.
más atrás.
The previous one, please go back. Okay. When the pandemic started, what were the expected issue in the management of STEMI patients? First of all, we expected the high incidence of STEMI, and especially due to COVID-related thrombotic complications. Next, we know the interaction between the SARS coronavirus 2 and the several pathways of thrombosis, and especially the interaction with endothelial cells, with platelets, and coagulation factors. Next. And other problems expected were the longer ischemia time due to the emergency system. Especially the first wave, there were a lot of cases, and the emergency systems was extremely busy in taking care of patients affected by COVID. So we expected a longer ischemia time, so delay to treatment. The other problem was an interaction with the ACE inhibitors. We know that ACE is one important receptor used by the virus to enter in the cells. So in the beginning, there was a big fear for an interaction between RASI and ACE inhibitors and the risk of COVID. And finally, the risk of infection during the pandemic. Next, and all these factors could have, in the beginning, we expected an increased mortality rate during the pandemic in patients with ST elevation MI. Next. Next. This is one of the first study done was the beginning of April, was published in 2020 on European Heart Journal. This is a registry done in Italy. The limitation was the small sample size, less than 1,000 people, and the collection was 1 week in March. Next, and they found a significant, important, relevant reduction. Next, please. Reduction you can see in the rate of STEMI and especially STEMI and non-STEMI, and you can see the impact of the pandemic on mortality. You can see that especially in STEMI patients there was a 3 times higher mortality rate. Next. And that's why we started. I launched this project. This is an international registry. In the beginning, this registry was confined to Europe, and we included in the first phase of the registry 77 centers from Europe. And the aim of the registry was to monitor to provide a picture of STEMI management by primary PCI. In Europe, we included patients from 1st of March until 30 April 2019 and 2020. Next. And we had 77 centers across Europe, distributed from the eastern part, west part, and from the northern part and the southern part of Europe. So almost all European countries were represented. Next. And this is the data of the first publication on the first phase of the registry. We found a significant reduction, 90% reduction in the number of primary PCI in 2020 as compared to 2019. Next, please. And this reduction, what we found is an extreme variability across centers. And next, this was not related to the rate of local COVID cases. Next, was not related to the national number of COVID cases. Next, was not related to the number of the rate of COVID deaths at the local level. Next, or at national level. So we did not find any relationship between the reduction in STEMI cases and let's say, parameters of the pandemic in terms of numbers of COVID positive patients and number of deaths. Next. And this, we divided Europe in 5 regions. These are data from Italy. You can see Iberian Peninsula, Central Europe, Balkans, and Northeast Europe. In almost all the cases, there was a significant reduction in the number of cases. Next. The largest reduction was observed, especially in the Balkans. Next. And we found, we also looked at subgroups, and we found a quite significant positive interaction was 0.095 for age. It was no different for gender. Next. And we found a significant interaction for hypertension. So the reduction was more significant in patients with hypertension. You can see was a 23% reduction versus 14% reduction in patients without hypertension. We obtained this data due to the fear that there was in the beginning, the concerns about the risk in patients taking ACE inhibitors, and the fact that patients suffering from hypertension were most often those who died for COVID. Next. And probably this caused a sort of fear to patients with hypertension to show to the hospital despite the symptoms. We found a significant increase in the rate of total ischemia time. This is a representation of patients coming later than 12 hours. There was a significantly significant increase in door to balloon time. Next. There was a significantly higher mortality rate in this is the adjusted p-value in 2020 as compared to 2019. There was a 30% relative risk reduction increase in mortality, and this was confirmed even after the exclusion of patients with affected by COVID. And this is the right columns here. Next. And we focus in these other analysis recently published on atherosclerosis in patients affected by COVID positive patients. We took the 62 COVID positive or positive patients and were randomly matched with the population of patients who were negative to coronavirus. So 62 patients and 310 patients. Next. Confirming a previous registry done in UK, a smaller registry, we found that there are significant increased mortality. You can see that it is quite 6 times higher in patients with STEMI and SARS COVID-19 positive coronavirus 2. And you can see the clear impact on mortality. And in this slide, you see the population divided according to thrombectomy. In our study, we found a significantly higher use of 2B3 inhibitors and thrombectomy in patients affected with positive to coronavirus. This data suggested the larger thrombus burden in this population. When we analyze the data about according to the use of thrombectomy, you can see the clear impact. These are patients without, to the left, patients, negative patients, and to the right, there are patients with positive to coronavirus. And you can see the clear impact of use of thrombectomy on mortality. Next. We found also a significantly higher rate of stent thrombosis, and you can see to the right also the impact of thrombectomy, especially in patients positive to coronavirus. Next. So we launched, I'm sorry, but the slide does not seem very good. And I'm sorry for that. We launched the second phase, so we decided in June 2020 to extend the number of centers. So we moved to other countries. We extended to Latin America, and I would like to thank Alfredo and Pablo Lamelas for supporting in searching centers from Latin America. We had also 2 centers from North Africa and about 10 centers from East Asia. And we extended from March to June 2019 and 2020. Next. This is the study organization. Again, I would like to thank Alfredo and Pablo Lamelas for supporting me in searching new centers from Latin America. Next. And we had a total of 109 centers with a total population of more than 60,000 patients, 9,000 patients in 2019, and more than 7,000 patients in 2020. Most of the centers were from Europe. We had 10 centers from Latin America, 7 centers from South Asia, and 2 centers from North Africa. Next. These are baseline characteristics. We had a slightly statistically significant difference in terms of age. There were some baseline characteristics, differences in baseline characteristics. You can see there were less smokers in 2020. There were differences in, especially in total ischemic time and in door to balloon time. Next. There was more radial access in 2020. There was more use in drug-eluting stents in 2020 as compared to 2019. And there was even a more complete, a larger use of mechanical support in 2020 and more complete revascularization in 2020 as compared to 2019. Next, please. These are the data of the phase 2, so the world registry. And you can see the significant reduction. There was overall 16% reduction in the number of primary PCI between 2019 and 2020. Again, we found a significant heterogeneity among centers. Next. Next, please. We try to estimate the impact of COVID pandemic and the rate of, this is the number of local national COVID cases, and there was no impact on the heterogeneity among the centers. Next. There was no relationship between the number, this is the number of, the national number of COVID related deaths. This was not associated to the reduction per each centers in terms of number of primary PCI. Next. And we did also in the subgroup analysis, we divided the population. You can see to the left, it's the March-April period. To the right, we have May-June period. There was, in May-June, there was a smaller reduction. There was a 14% reduction. The largest reduction was observed in the first 2 months of the first wave. In March and April, you can see about 18% reduction. Next. And we divided these data, and sorry that you cannot see, these are data according to the continent. The first two bars are from Europe, but the second 2 bars are from Latin America, the third bars from Southeast Asia, and the last 4 bars are from Africa. Next, there was, the largest reduction, sorry, go back. The largest reduction was in North Africa. This is Europe. In Latin America and Southeast Asia, the reduction was a little bit smaller, especially in Latin America, probably because it was not, in Latin America, we had just the first wave was a little bit delayed as compared to Europe. Next. And this is the subgroup analysis. You can see according to gender and diabetes, there was no interaction. Next. And there was, you can see here, this is, we found a significant, sorry, the previous one was diabetes and hypertension. And during in the second part of the registry, including the March-June patients, hypertension was not statistically significant. So we found no heterogeneity between patients with and without hypertension. So hypertension did not emerge as a significant factor impacting on the presentation for primary PCI. On the other side, we found a significant interaction according to age. So there was the reduction was was stronger and higher in patients, in elderly patients, with 20% versus 15% in younger patients. Next. We analyzed the impact of the pandemic on total ischemia time, door to balloon, and in hospital and 30-day mortality. As you can see in the first graph, there is an impact on total ischemic time. It was observed in both March, April, and May, June. There was in the lower graph, there is an impact on door to balloon time that was overall significant, much more during the first part of the pandemic in March, April. The difference was not statistically significant anymore in May and June. There was, you can see, a significant impact on mortality. The impact on mortality was in hospital mortality was mostly observed during the first 2 months of the pandemic, whereas in May, June, there was a trend in reduction in mortality. However, the difference in mortality became significant at 30 days, even in May and June. You can see the adjusted p-value. This is the last graph on 30-day mortality. And you can see how the impact on COVID had a significant impact on mortality in both March, April, and May and June, even though the largest impact was observed during the first part of the first wave. Next. And these are Kaplan-Meier curves showing the impact of a COVID pandemic on 30-day mortality. You can see how the survival rate was much lower in patients in 2020 as compared to 2019. Next. And now we moved to the phase 3. So we are we are extending the analysis to 2021. From March to June. It was quite in the middle of the third wave of the pandemic, and we wanted to also to evaluate the impact and the effect of vaccination on mortality among STEMI and on the rate of presentation for primary PCI. Next. So in conclusion, data from DSAX STEMI COVID-19 is the worldwide largest STEMI registry during the COVID pandemic, confirmed the significant impact of the pandemic on the management of STEMI patients' management and outcome. There was a significant decline in the number of STEMI. We found a larger decline, especially in the early phase. So in March and April, there was a significant heterogeneity across centers that was not related to COVID, let's say, COVID parameters, the number of cases and the number of deaths above the local and the national level. We found a longer delay to treatment, and we found an higher mortality, and the larger mortality was especially observed during the first wave of the pandemic. We found also among the patients positive to coronavirus, striking higher mortality rate and higher rate of in-stent thrombosis. This data may also be due to the potential larger thrombus burden. They are reflected by the higher use of thrombectomy and 2-PTH inhibitors that we found in this population. Thank you very much for your attention. I'm sorry for the technical issue I had to, but I'm not used with the Mac, and probably there was a conflict between my Gmail account and the account of the colleague who let me use the computer. Thank you very much for your attention. And thank you, Alfredo, again for the invitation.
Very glad to be with us. I would like to invite the panelists to have some comments and questions about the talk of Dr. De Luca, the experience of of course, the largest registry in STEMI during the pandemic.
Marcelo. Sí.
Marcelo.
Sí. Excelente presentación, doctor De Luca.
Excellent presentation, Dr. De Luca. Honestly, thank you very much for sharing with us all this information. Yeah, sorry, but he's frozen. Marcelo, can you hear us? Because you are frozen. Like you're having some technical issues. Hello? Yes. I'm sorry. It happens. Technology, you know. The hospital signal here is not that good, but I want to be very, I want to congratulate you again. Excellent presentation. There are many issues related to the first call time, first call to consultation, door to balloon, many conditions that you can understand. But I wanted to ask you, what do you think about some reports?
I understand many topics that we can consider related to, for instance, the time for the first consultation of the patient, time door to balloon, a lot of issues that are strictly related to the COVID and the reluctance from patients to assist to a hospital. But perhaps my main concern is that we have observed that this particular topic is also translated in the delay in the Cath lab. I mean, the decision-making moment, it's delayed in these patients. There are several reports. I remember one from Hong Kong that has shown that there is a delay in the decision to apply for a stent, a simple stent for primary PCI. What are your comments about our delay in the Cath lab?
Yeah, absolutely. In the beginning, when we had to face the pandemic, it was also our fault. I mean, we were not fully ready to face the pandemic, especially in the Cath lab. There were more delays in hospital. We had a lot of papers from EAPCI concerning how to manage patients in the cath lab. And we decided after the beginning of the pandemic to go to treat all STEMI patients as they were COVID positive. And this was important in order to fasten the treatment to the cath lab and to at least we are lucky because we have a very good coronary care unit, so we are single rooms for patients. And for us it was easy to keep isolated the patients after the procedure. So this let us, because the problem was also to manage the patients after the procedure. In the beginning, it was not easy to isolate all the patients. So this was the problem also of the delay to the cath lab. At least in our hospital, we decided to treat all STEMI patients as COVID positive. And so this led us to make the process much faster. So we had a specific track for acute patients and considering all of them as a positive, and also keeping them isolated in the cath lab, because in the beginning we had a bad experience with fast examinations and we had a lot of false negative patients, and so we decided to also to repeat the examination in search of the coronavirus days after the procedure. So we used to keep isolated the patients for days after the procedure in order to avoid the spread. But at least in our case, we were lucky because our coronary care unit had already single rooms. So it was easy to take all patients isolated, but I can understand it's not, when you have a huge flow of patients, it's not easy to isolate the patients after the procedure. And this can make problems in the management. Because when the patients come, you have to think already how to place the patients after the procedure. And this probably in some cases may be a problem of delay. But I think nowadays the track is much faster in almost all the hospitals. So, and this will certainly reduce the delay to treatment. In the beginning, I agree with you, there was a delay due to, or even in hospital delay due to the management of these patients. But nowadays I think the door to balloon is quite similar to that in the pre-pandemic era.
Okay, we have one more question for the panel, otherwise we will have to move forward. Another question for the panelists? Aníbal, do you have any comments?
No, I just want to thank Dr. Giuseppe Di Luca for sharing with us this very important information regarding the management of STEMI patients during the COVID era and the impact of the COVID pandemic regarding STEMI patients management. So I don't have a question, just to thank him again. Alfredo, si te parece bien y no hay otra pregunta, podemos...
Alfredo, if you agree, we can move forward with the next presentation. Perfect.
An honor for me. Thank you.
Thank you, Dr. De Luca.
And now to continue with the agenda of this session, I'd like to present to you and invite Dr. Viviana Rodriguez to share her screen. She's the Chief of Infectology of the German Hospital, Department of the German Hospital. She will talk about infectious disease care in endovascular surgery and interventions during the pandemic. Doctor, thank you for being here, having accepted the invitation to participate in this Congress. Thank you for inviting me. I'm going to share my screen. It's a pleasure to share this panel with so many experts and people who are so involved in the issue. I'll discuss now this topic about infectious disease care in endovascular surgery and mostly prevention associated to healthcare to manage cardiovascular diseases. COVID, the pandemic, has put us in a situation that is very special, historical for all of us, and we need to get used to the fact that it has changed the way we work. So it's a challenge in terms of prevention and also for emergency management. The vascular disease, as they mentioned before in the previous presentation, is historically known as disease managed by emergency doctors, and it requires a channel in most of the hospitals, a special channel. And unfortunately, apart from needing the urgency, we now have the combination of COVID-19. In hospitals, we need to have these safe pathways to care and to manage the patients, for the personnel, but also for the patients and their families. All that in less than a year and a half in a context of continuous learning and having discovered a new virus, a new illness, just in December 2019, and putting in place new procedures in many hospitals where there was not even infectious disease controls, at least not in place. In many hospitals where we did have them, we had to adapt all of our healthcare systems, especially in the emergency unit. And we also had to get used to this situation of pandemic. Now we know that we have 1, 2, 3, 4 waves that we've already undergone, and we have, or that we have ahead, and we are used to watching the movie the way you see it in the graphs, blue, red, and gray, the number of patients that come into the hospital, that are admitted in our hospital. COVID-19 disease produces this vasculitis, cardiomyopathy, hypercoagulability condition, endothelial dysfusion, coronary syndrome, stroke. So we have these emergency tracks managed by a multidisciplinary team that had to adapt itself to these new rules, as most emergencies, right? Screening and first response screening is key, or was key, and honestly it took a long time in most of the emergency systems to be implemented. But it's important to know if the patient has the breathing systems, the respirators, if he had close contact with a positive case, if he traveled or she traveled or not. In the emergency department, we still have to have an emergency triage earlier than we had it before in the hospitals, and to take precautions in terms of gout, contacts, sprays, especially very complex, especially in acute diseases. In prevention and infectious control, we also were tested in terms of risk assessment of the whole institution, in terms of infrastructure. I'll talk about it later a little bit more. Antigens or PCRs, the different diagnostic methods that we could use, managing the resources very carefully, precautions, and protecting the airways and mechanical ventilation that also required the use of filtering devices for the mechanical ventilators, that in many institutions they had to buy them because they didn't have them. And finally, the team that works with stroke, we had to have special precautions in environments where the images are done and where the procedures are carried out. We started in the German hospital. Sorry. In the German hospital, we started very optimistically. We thought this was going to last very little time. Therefore, we put something temporary so that it was more comfortable for patients. But then we realized that this was here to stay, or at least for a long time. And we had to install a COVID-19 unit prior to the emergency room for triage and suspicion of this type of disease. The new challenges of this disease regarding the infectious disease control had to do with the overload of the processes, the fear of people, personnel, and patients, and uncertainty. And that was a risk factor because it made all the processes very slow for the patients, for the personnel. The consultations were delayed. A lot of uncertainty, as I said, in terms of the use restrictions, the use of procedures, not only emergency procedures, but also those that are planned, endovascular surgery, all the reprogramming of the daily surgeries, the new healthcare guidelines that alert all the people or makes everybody to get new training. The uncertainty in terms of the death rate, you know, of patients and people who get hospitalization, and also the need to have protected staff during the work time periods. We had to change the work periods. In some moments, they were different from the ones we used to work on. There were different stages. We started using masks that were very simple. Then we went to the N95. We went to the FFP2. And this protection was at the beginning very much welcomed, but then not so much as the vaccines appeared and patients or people that were exposed and recovered. The N95 was not much appreciated mask, but now we still need to use this type of healthcare protections. In the hospital, we talked about this with the crisis committee. It's a multidisciplinary committee that make decisions every day about structures, operations, prevention. Every day we meet, and then they had activities throughout the year as we started undergoing the different waves. We also based ourselves in communications among the people that work in the hospital and reporting the number of patients, taking precautions. We try to do teamwork with everybody involved. We standardize processes. We try to simplify the way we provided the healthcare to patients and simplifying spaces, equipment, material, and these new and old risks, right? I mean, the combination of risks in the control and prevention of infectious diseases that have to do with the prevention of the surgical, in-hospital surgical problems, plus COVID-19 preventions. You know that infectious diseases associated to healthcare and endovascular procedures are the first ones that we need to pay attention to. In our country, there are events that multiply times 5 compared to countries that are more developed. The endovascular procedures have a lower percentage, and that up to 6%. But we need to pay attention to that number anyways. In order to have prevention for COVID and prevention for associated diseases to these devices, endovascular procedures and surgical procedures, we need to instrument plans, analyze information, return information, and interventions that are rather complex in an environment in which the difficulty of continuous improvement is not that common. And this speeded up our rhythm, you know, from the one we planned ahead. Personal protection elements for the staff evolved, but we always had this direct communication with all the people all the time. And we try to comply with all this consistently. The solutions and perspectives for improvement still have to do with a series of elements that we have to abide by. It's complex because we need to make it permanent and more than the type of prevention. You'll see that we'll have to do, it has to do with antibiotics, normothermia, glycemic control, oxygen availability, fluids, skincare. Many of these elements fail during the prevention stages, from the moment they is admitted to the hospital until they are hospitalized, has to do with the fact that we need to do teamwork. And pandemic tested us in terms of how fast we can work as a team, and we found many failures associated to adverse events, and we have to continue correcting those. In the case of endovascular surgery, as most of the others, we had the need to readapt ourselves in terms of spaces, methodologies to prevent the spread, and the management of time.
And the need that we all contribute to patient prevention and healthcare professionals.
We can no longer hear the speaker.
And so we'll have to continue fighting and working with resilience and uncertainty to be able to move forward in the next waves. And as my previous colleague said before, this disease and infection prevention has changed the way we work and will leave us with a set of protocols and ways of working that will stay with us. This is what happened with HIV and biosafety. This will leave us with new EPPs and new protocols. Thank you very much for your attention and your time. I'll be available then for questions and answers. Thank you very much, Dr. Very interesting presentation. Let's move on with the agenda, please. Dr. Alfredo Rodriguez had to leave the room due to an emergency at the clinic. So I will now ask
We'll resume the interpretation as
technical
soon as we
department
fix the
to continue with the next presentation. So we're going to leave the discussion for the end. And Dr. Diaz's presentation is on the role of colchicine for COVID-19 prevention. Good morning, everyone. First of all, I'd like to thank SOLACI-CACI authorities, specifically Dr. Alfredo Rodriguez and Aníbal Damonte, for inviting me to participate in this session. To all of you, thank you very much. This is Friday midday, listening to medical issues. Congratulations. Today I'm going to discuss a topic that is not so much connected to cardiologists, the role of colchicine in the prevention of COVID-19. I have no conflict of interest regarding this topic, and I'd like to begin with a short overview, a brief overview. This is August, and this was put together before, but anyway, I think it's important to have a look at the pharmacological treatment.
And I think we cannot stop highlighting the activity of the recovery group. And the activity of the recovery group was translated in a key paper that was published in July 2020, where they proved that the early administration of intravenous doses of dexamethasone reduces bigger mortality rates and about 16-17%. I think that's the most important result. Look at the Kaplan and Mayer results. Results are being seen on day 2 or 3, and they continue during the time. This is very consistent. The number of patients is pretty significant. So this result is a definite result. And after that, dexamethasone in all over the world was usual treatment for severe COVID patients.
At the end of last year and before the beginning of 2021, there weren't evidence or control trials assessing serious events with colchicine. There were 2 trials published. The Greco study, that is very small trial that showed some evidence in terms of mechanism that could have been interest, particularly inflammatory markers. A second study published between December, that was the pre-release, Dr. Lopez, with a group of patients from the mechanical point of view, appeared to be promising and beneficial in terms of giving colchicine for acute COVID-19 cases. And there were 7 events deaths. So both studies combined gave us 7 deaths, and 5 were in the control group and 2 colchicine, but 7 events in total. So we didn't have any conclusions. Mechanically, some inflammatory markers and other benefits such as hospital stay could be beneficial in terms of early colchicine administration. And there were four other studies that were being concluded. So we're all running the race, basically. Corona, ours, PHPR, the recovery colchicine trial. Corona began in March together with ours. We began on March 20th, and Corona started on March 2. Recovery began in August. This is interesting. So they never thought colchicine could be an important player. And after seeing that, I mean, there were two groups working on colchicine, then recovery began with the colchicine arm, and finally ACT-PHRI colchicine trial that began in December 2020, when some of the arms of the groups were not efficient, and they began with an anticoagulation option. So this is the final scenario, and this is what we're going to look into today. Finally, Tardif publishes a pre-release and to our and interrupts the study. This was planned to cover 6,000 disease patients, and Corona is in non-hospitalized patients not requiring hospitalization, and the primary endpoint is hospitalization requirement. And the interruption is with 4,000 patients. The study was interrupted on a Friday, and then there's a press release at Friday evening. They just show a subgroup analysis, but probably Corona would be 104 disease patients with a primary composite endpoint, 131 in the placebo group with colchicines, and the odds ratio is 21, and the p-value is 0.008. So we could say that there's a favorable trend in terms of colchicine with in patients that are not severely diseased or hospitalized. And so this is the actual result of Corona. Immediately after this, a small meta-analysis is published. When you consider all of the small studies, this is Greco 1, 2, Lopez. So when you look at mortality alone, look at the benefit considering all of the number of patients is 40%. So these are all of the studies except for Corona that has 5 and 9 deaths. So 40% benefiting colchicine. So if you look at what happens with patients between mechanical ventilation, only mechanical ventilation, the result is not that significant, 25%. So there seems to be an association between mortality and mechanical ventilation, regardless of the... And then we have 159 versus 55 events. So all of these small studies tell us that there is a probable trend which is more connected to mortality rather than mechanical ventilation. And before we ended the study, recovery came up. Recovery I mean, we never thought what could happen with recovery. So the recovery randomizes these number of patients, almost 1,200. 1.1, there's no mortality difference. The confidence gap is 1.5. It's a convincing study. 1.1, neutral, absolutely neutral effect. And then the confidence level, 0.93, could be less than 10 or more than 10, but it's quite narrow, so it's not that reliable. So is this the final Colchicine result? We could say a couple of things about recovery. They used a treatment regimen that is quite different from the other studies. In this particular case, recovery used half of the doses, and also disease patients' follow-up time is different. The events we looked for are practically the same because we looked at mortality and mechanical ventilation. And this is the result. We thought colchicine would have an intermediate value. This is the recovery curve. I will just not get into detail. And let me tell you what we did with our patients. We randomized 1,279 patients. Two withdrew consentment, and there were 31 patients that did not receive colchicine in the colchicine group, and 5 patients that received colchicine. So 640 were included. And these are the baseline characteristics. 36%, 1/3 of the population were women, mean age 60 actually, and very important, 80% have an oxygen desaturation, and they require mechanical ventilation, either invasive or non-invasive. This is a high risk, an important high risk population. We were concerned because a lot of the patients came in late and only 25% come 3 days later. So 70% of the patients come in three days later after the first symptoms, and 90% have a positive PCR. 90% of the population received corticoids. So the benefit of colchicines above an anti-inflammatory that has been given is how good is that? This is the question. Anticoagulants, 1/3 of the population, and Hermantine, 5%. And these are the curves, and this is what you're interested in. This is the intubation and death curve. This is the mortality curve, 28 days. We cannot show you this is the control groups, right? These are not the colchicine groups. You'll be able to see this August 29th, 8 a.m. Paris time. My conclusions: promising results from small mechanistic trials, no doubt. Recovery trial, totally neutral. Now we have to see whether recovery will actually reflect the reality of colchicine or not. It's very difficult to fight against 11,000 patients and many, many events in those 11,000 patients, like 1,000 events approximately. So it's very difficult. Regardless of the loading dose, recovery is a trial which is called anti-platform. I mean, there's a control group and several concomitant or subsequent treatments. So recovery studied a control group, and out of this control group, they studied, for example, plasma, tocilizumab, and this other group studied colchicine. So what we need to see, that could be actually a recovery weakness, whether the control group actually reflects the colchicine group. So if there's a mismatch between the control group and the colchicine, and so recovery is still not published. The only thing they have published is a preprint. So there's no a reprint that is assessed by peers. So there's no peer review. And this is August, and recovery was submitted at the end of December. So the pre-release and the preprint are available, but not the final publication, which is the peer review. If the recovery control group does not temporarily match with the colchicine group, the control group may not reflect the colchicine group, and this could be a weakness. This is a weakness of platform studies. Corona shows a trend in outpatients, an interesting trend, 23%, with a almost significant P. And this study, you'll see them on August 29th at the ESC session. And finally, there's a trial ongoing, which is the ACT PHRI colchicine trial that will cover 3,000, almost 3,000 patients. Between ECLA and ACT, there will be about 4,000, 5,000 patients. So I would say that personally, colchicine in COVID is not closed, regardless of recovery results. And we're expecting our publication and ACT's publication. So I think that the question about colchicine is still open. There's an outpatient component which will consolidate this result. I mean, if if it was just a trend, and there's inpatient that will actually add up to our study. What do we know? What don't we know? Colchicine, all of the studies should be conducted to assess mortality and major adverse events. I think this is a great contribution from Argentina to the pandemics. At least in a group, we randomized 6,500 patients in 3 different studies. Next week we'll have the results of the last 2 studies, and we'll be introducing or presenting colchicine in August. We're very happy with our job and very happy to have participated in this Congress. Thank you very much.
Desde acá no estoy en Argentina en este momento.
Currently in Argentina, but I will be in Argentina next Friday. Muy importante.
Bueno, muy bien, excelente presentación.
Wonderful presentation, as usual, Dr. Diaz. Such a clear presentation. As I said before, We'll leave questions for the end. Let's have a look at the first clinical case by Dr. Allende. Gustavo, the floor is yours. I'd like to thank the organizing committee, SOLACI-CACI, for this invitation with these outstanding speakers. I'd like to share two cases from last year: cardiac rupture, unusual presentations, and which were recently published. First one is a 70-year-old female patient with history of hypertension and hypothyroidism. She had a medical checkup 3 months before admission. Normal EKG was attended in the emergency department because of palpitation and dyspnea. Physical examination showed inspiratory crackles over the inferior half of the lung fields. Blood pressure was 140/80, heart rate 120 beats per minute, and respiratory rate 25 breaths per minute. She has QS. And this was confirmed by the troponin, which was negative in several occasions, CK normal. So we believe that that infection had been there for 10 years. In the questionnaire, when we questioned the patient, she said that 45 days prior to the consultation, she had some pain on the left arm, and then 2 syncopal episodes. She did not go to the consultation because she was afraid of COVID-19. In the EKG, you can see a pseudo aneurysm with a tissue flap that forms a sort of a wall where you see an intercommunication of the ventricles. This orifice allows for a flow. The next days, we have this pseudo aneurysm, and the patient was sent to surgery. The surgery team required ECMO, so we needed to transfer the patient. There, the patient was stable, and they decided not to touch her and to medically treat her. This is the echo and the MRI, and look at how interesting the tissue flap in the left ventricle separating disappeared, and now they are communicated. So the pseudoaneurysm functionally today is a large apical aneurysm.
When we measure the distal side up to the tip of the apical tip, the aneurysm did not reabsorb, but it introduced volume to the left ventricle, and it worked as a big cavity. After a year, we still do follow-up in this patient. She's stable with only drug administrations. The next one is a 61-year-old male with a history of diabetes, hypertension, and cigarette and smoker. He came with chest pain, and he says that for the past 3 years, days, he's had that, and he didn't say anything because he was afraid of getting COVID. He had cold extremities, tachypnea, tachycardia, blood pressure, high blood pressure. We studied him at the first hours, and we find there is an occlusion of the LAD, and we decided to canalize cannulate, we found this huge ventricle space, which is a intramyocardiac hematoma. This is a very weird presentation of the cardiac rupture, in which instead of opening it sideways to outwards, the rupture is inwards. This was confirmed by the MRI, as you can see on the right. That was done when the patient was stable and was transferred for surgery. We can see in the pictures with the fibrosis around the hematoma, indicating that it was inside, the hematoma was within the tissue. So we found that this patient was too risky to do the surgery, and we treated with medication, and he responded very well. These are the follow-up images. This is after 20 days, that shows that the thickness of the intramyocardial hematoma is less, and more, even more so. 45 days later, there is an organization of the different spaces, like the ventricles. The common pathophysiologic pathway of mechanical complications in AMI is the absence of a timely and effective reperfusion of the IRA. Patients who have it, there is less incidence in patients that reach TIMI-3 with angioplasty. And even though mechanical complications were more frequent before the repercussion area back in the 80s, when with the phenolic era, they went down, and then the primary PCI era, it made it increase a little bit, but then systems of care for STEMI and shock era made it decrease once again. But what happened? Then pandemic hit, and because this is the same publication, lower coronary angioplasties, lower hospitalizations, and collateral damages due to pandemic. In conclusion, in the context of COVID-19 pandemic, acute coronary syndromes arrive later. There is more delay to open the artery, and that could be the consequence of the increase in the mechanical complications that we are observing. The inadequate control and treatment of cardiovascular disease may increase morbidity and mortality of this pathology. And it could be an example of the collateral damage that COVID-19 is producing. That's why in health and medicine, sometimes the clinical observation shows that the results are different from what we expect. Thank you, Gustavo. Excellent presentation. And thanks so much for respecting the time. Now, to continue with the agenda, I'd like to invite Maximiliano Rossi, intervention doctor in Rosario, for the clinical case presentation.
Bueno, muchas gracias, Aníbal.
Thank you, Aníbal, for the presentation, and thanks, SOLACI, for inviting me. The clinical case I'm going to present is myocardial infarction and COVID. This is a patient that was admitted to the Sanatorio Parque in May this year, 49 years old, male, no coronary risk factors, no cardiovascular background, and as a non-cardiovascular background, he was ongoing COVID-19 with the symptoms of the 8th day, myalgias, and for the past 48 hours, the symptoms were receding. And from the beginning of the COVID, he took 600 milligrams ibuprofen according to the appearance of the symptoms. So he comes to the ward of our institution, 7 hours of evolution. It started when he was at rest in the center of the thorax of the chest, no radiation, And the patient who was a little overweight, the body mass index was 31. He came with a KKA, heart frequency was 55, 98% saturation, air saturation. The EKG shows that he had an infarction in D2, D3, AVF, and V7, V8, and a little minimum thing in V6. So, to summarize, this is a patient that is 49, undergoing COVID, mild COVID-19, no cardiovascular background, typical precordial pain, 7 hours. We do the EKG, and we send him to do an angiogram. This is the coronography. So this is the first coronography. We see the circumflex artery that when we go to the apical section, there is a lesion also in the main and the LAD. And we find an intermediate lesion with a distal MI1, and we don't see a distal lesion at the LAD level or the circumflex. The same image, spider image with there's a blood clotting, the dominant circumflex and the right dominant without significant stenosis. At the moment, we said, okay, many things, right? I mean, the hemodynamic expert said, what could we do? Let's have a discussion. But due to the time, we are going to, if someone wants to tell me what you would do, we can do it at the end. The patient, he had still chest pain, but from a 10, it went down to a 4. And we decide not to do any intervention in the hemodynamic room and to do systemic fibrinolytic treatment. We do RTPA with the usual doses. A year and a half after he received the RTPA, the chest pain was reduced. The lab test results showed that he had a mild increase in the white cells. Troponin TT was 68, and there were no alterations of the previous oximetry. This is the electrocardiogram post fibrinolytic, AVF, initial Q, and we refer the patient again, and we decided to do a new echocardiogram. And we find that now in the right oblique, it disappeared completely. There is a thrombosis that disappears completely in the left crown. We see that the artery walls are plain. There was no plaque accident. There is no residual plaque. And as we see in the other projections, the spider, the endocranial, both in the LAD and towards the circumflex artery. After the coronography, the patient remained 96 hours under observations without complications, and we discharge him with aspirin once a day, dabigatran 150 milligrams every 12 hours, rosuvastatin 40 milligrams a day, and the gastrointestinal protection. He had apical hyperkinetic, and well, that is the result of the case. Thank you very much, Maximiliano, for your presentation and also for sticking to the time. I'm going to present the last case. Dr. Juan, if you want to share your screen so you have a chance to have 5 minutes for discussions, please. Dr. Mieres, you are on mute. I'm here. I'm trying to share my screen. Can you see my screen? Yes, go ahead, Juan. Can you hear me? Yes. And we can see your presentation on the screen. Okay, great. We're going to go very quickly due to time restraints. This is a young patient, 31 years old, with thrombotic complications, multiple thrombotic complications, and a coronary anomaly in the angiography. Thanks so much for the invitation. I think the Congress was fabulous so far, so I have no disclosures. This pandemic has really been terrible for all of us from the very beginning. We have seen multiple trials where hypercoagulability has been one of the factors, main factors in this disease. We've seen the incidence of thrombotic events and complications, artery complications as well, even ACS. In this paper, many of the patients, up to 60% more, did not have coronary disease prior to the pandemic. There is one case with multiple thrombosis, and most recently, it was published to explain what were the thrombotic factors, especially the LDH, lymphopenia, and the idea is to present this young patient, 31 years old, with obesity, body mass index 35 kilograms per square meter. He was taking ibuprofen before he was admitted, and he comes with 4 hours of chest pain with changes in the ECG that are compatible with an injury, lateral injury in D1 and VL. We do a coronary angiography. In the first image, we see that the LAD and this branch that we don't know whether it's an intermediate branch or the circumflex were born from the coronary sinus, the right coronary trunk. The LAD is completely visual now, but what got my attention when I was doing the angiography is that the right coronary artery was very small. So I suspected that he had another vessel. So after looking for it and changing catheters, I put an amplex catheter, and I was able to reach the other sinus and to see that it had a short stem and the circumflex. Another LAD, because here we see septal branches and a branch that was occluded. So I put a coronary wire. I didn't have flow, so I thromboaspirated. I put 2 conventional stents. After that, we restored the flow partially. He had an ostial lesion, so I added a 3rd stent, and I was able to restore the flow completely for that intermediate branch. This is the post-procedural ECG, lateral side decrease of the SET. 24 hours after that, he starts with a fever. He gets tested for COVID. He is COVID positive. So the lab at the beginning was high ferritin, C-reactive protein pretty high too. 4 days after, the patient
Juan, te hemos perdido, no sé si es la conexión a internet tuya. Mientras tanto, mientras el doctor Mieres vuelve a conectarse, lo que voy a invitar es a los panelistas que todavía no tuvieron oportunidad de hacer algún comentario o pregunta.
So while we recovered Juan Mieres' audio, let's have a moment for questions or comments about one of the presentations, since we are not going to have time to answer questions because of the scientific agenda. I wanted to congratulate Maximiliano for that interesting case he presented of intracoronary thrombosis in the COVID era. That case could be treated in different ways. It's important to know whether there is plaque or no plaque, underlying plaque. If there's a fracture, maybe that formed the thrombosis with such a thrombotic burden. Sometimes we intracoronary thrombolytic, and it's worse. And we have huge hematomas, intramural hematomas through dissection that complicate the case, and there is distal embolism, and distal embolism is quite difficult in ACS. Other people would do, for instance, distal filter projection, or they could do mechanical extraction of the thrombo. This mechanical extraction of the thrombus cannot be positioned in the wider spectrum of indications, but patients with ACS and high thrombotic burden, the results were quite positive. Of course, there is the fact of the risk of a stroke, which increases death rates by 10 times. And then administer glycoprotein B2,3A intracoronary proteins. That's another point. There are so many strategies that we could have used. So congratulations, Maximiliano. It was an extraordinarily interesting case and really very educational. Thank you for your comment. Let's see, Dr. Schubert, any comment that you would like to make? Yes, thank you, Aníbal. Congratulations to all the speakers. Continuing with what Pedro said, an option was to leave heparin only and see the evolution, because this patient had good flow. So it was very interesting. And the other thing globally, regarding the case presentations, the question is whether these cases had or not to do the reaction with COVID. I mean, these cases could be spontaneous, young people, thrombotic burden. We saw that before COVID with cardiac rupture, a few symptoms before, no background of coronary disease. We saw that before COVID too. So the question one asks is, does that have to do with COVID-19? Maybe not. That's my question. I can answer that in my cases. I would ask, there was more time in one of the presentation. Let's finish with the comments, because we are way over time and we need to respect the first conference from Israel from Dr. Lotam. So I apologize, Gustavo, but no time to answer. There were some excess time before. Dr. Luis Urna, any comment or question? Yes, thank you. Congratulations to everyone. And I'd like to say what Juvera said. I had a similar case, 41-year-old patient with COVID 1 week before, and he comes with an infection. He's referred from another department in Bolivia, In the catheter, he had high thrombotic burden in all the LDA, LAD, and part of the diagonal, but since he had evolved, he had a good flow. The patient was asymptomatic at the time, and since we didn't have 3A and 2V, we decided to use anticoagulants, and we reassessed a few days later. The thrombotic burden decreased, but he still had some clots. We did thromboaspirations, and then we saw the rupture of the plaque, and we decided to place a stent. So very interesting case. So, and then the previous talk, because they didn't use heparin, they used rivaroxaban, and how they linked all the topics today. Thank you very much. Thank you, Luis. Dr. Gigalpiña, please, any comment about the presentations? Yes, thank you. Excellent cases. And just a quick comment for Dr. De Luca, because the amount of information that he has shown is incredible. But the next question would be if he had the chance to transform that information in health policies. If he were in politics, then he could make that. How he transform all that information he has into good health policies for cardiovascular pathology management, especially with this COVID-19 situation that is not going to leave us anytime soon. Thank you. Dr. Giuseppe.
You're mute.
If I understood correctly, because I try to understand Spanish, the question is how our data from our registry can in some way impact on the, may have effects on the healthcare system. I think this data provided a quite real picture of what's going on in the world. And I think we found that the most important thing that there was a significant heterogeneity between centers. So we believe that absolutely one of the factors what affected the number of primary PCI was not the number of local COVID cases or local or national number of deaths, but there was an heterogeneity. We believe that this was, especially during the first wave, was due to the trustiness of patients to the hospital. We probably believe that there were problems about, let's say, newspapers giving the idea that the situation in our hospital was very bad. And this probably caused a sort of a fear to our patients. The message is absolutely patients do not need to have a fear for COVID, because otherwise the mortality rate can be even higher due to delay to the hospitalization rather than a direct invasion from COVID. And there were a lot of public campaigns also in Italy about that, especially after the first publication done about our National Society of Cardiology, even though the study was small. But I believe that there must be public campaigns, absolutely, because the problem is not only cardiology, but even for other diseases. There was a problem of no show to the hospital. So I think there must be public campaigns in order to reinforce the concept that acute myocardial infarction can be a dramatic disease. You can die, so you need to go to activate the emergency system, and you need to trust the emergency system and the healthcare system.
Gracias, Giuseppe. Gracias, Gigal, por la pregunta. Y por último,
Giuseppe, and thank you. Dr. Cesar Hernandez, a brief comment. Two things I'd like to say, because Maximiliano's case I think is very interesting, because this is an alternative. COVID-19 patients having thrombosis in many territories are using. And in those cases, evolution is quite favorable. So we didn't have this before. And having these kind of therapies is very useful to manage patients. This is an alternative we have. Secondly, there is a great deal of information regarding anticoagulation with COVID-19 patients based on the disease stages, because if the disease is very advanced, such as intensive care unit patients with minor thrombosis, then anticoagulation does not work. But if the patient is in the room without thrombocytopenia, and so the patient is not critical, then anticoagulation may work. So I think it's important to learn on the go. But these two aspects, I think I wanted to highlight. Thank you, Cesar, and thank you all. Unfortunately, we're running out of time. We need to continue with our session. There are some colleagues of ours that are waiting. I think we have fully met the objectives of this session. I'd like to thank you all, speakers and panelists. I would really like to apologize if I interrupted you, but we need to respect the next session. Thank you for participating, SOLACI-CACI 2021. Thank you. Good afternoon and welcome to this first session on innovation in intervention cardiovascular and endovascular medicine in alliance with ICI from Israel and the Cardiovascular Research Foundation. Paraphrasing Plateau, we say that the need is the mother of invention. Because of need, we cross limits. This is what we're adding. There's no greater encouragement for knowledge that a certain amount of change and innovation is the DNA of interventional cardiology. Permanent innovation in our field successfully expands intervention. There is a trilogy of Argentinians that have revolutionized cardiology. Two of them are here. René Faloro is always in our memory, and we would like to pay tribute to him in this session. We would like to introduce INGLÉS in SOLACI. This has been a decision by the association to develop a technological department or arm. INGLÉS is the department at CACI, which is the Argentine Association of Cardiology. This initiative is a platform oriented to innovation and technological development in the field of intervention cardiovascular and endovascular medicine. We are aiming at change, continuous improvement, and at the same time, we are committed to the values of our organization and its people. In this session, we'll discuss the latest innovation and technological breakthroughs, technologies, treatments, and state of the industry centered or oriented or based on interventional medicine. We'll discuss artificial intelligence, robotics, automated smart processes, structural and valve innovations, hemodynamic support, CRIPS intelligent digital revolution. I would like to introduce the innovators we have selected who are at the forefront. They are the ones that know exactly where we're heading. Their concepts and theories, despite the years, are still crucial. They are the ones that had decisive ideas and created technologies that forecasted the future. They've been pioneers, and they made technologies accessible to the large number of people. I mean, Julio Palmas, Juan Granada, Hamilton, and Juan Parodi. The panel that will be with us today, Alexandra Abisaid, Nora Bar, the scientific journalist Alejandro Cerro, Marcela Rizzo. We have the honor to have them in this session of SOLACI-CACI. Dr. Alberto Hendler and Jose Pons will be moderating with myself this session. Please, Alberto, the floor is yours.
Okay. Okay. Let's switch to English because I am the privilege and the honor to present Professor Jaime Lotan. Is a good friend and colleague. Professor Lotan doesn't need any presentation. He's international well known, and the founder and director of the ICI, the most important congress in the world, worldwide, in the most important congress in innovation. And the subject of Jaime Lotan, Professor Lotan, will be digital health era. So Jaime, the stage is yours.
Thank you, Alberto, and I would like to thank all the organizing committee for this kind invitation and everyone for listening. I hope that you can see my screen. Is it okay?
No, not yet. You have to minimize your screen and put the presentation. Yeah. Okay.
Okay. Okay. Can you see it now?
Yes, perfectly.
Okay. Thank you for everything, and thanks especially for the invitation. The issue of my talk is the digital revolution, or some people call it evolution in cardiology, because we are really facing a new era. We always have been seeing that, we have changed the world very quickly, and this is how the world looked 50 years ago, and this is how the world is looking today, totally different world. And even the babies in the womb are born with a way that they have already a way to use this. So the question is, can digital health help to solve the healthcare challenges? And the main question is, what is digital health? Everyone is using it, but it's really the convergence of a lot of technologies with healthcare, living society to enhance the efficiency of healthcare delivery. It's disciplines that involve the use of information and communication technologies, and these technologies include both hardware and software solutions. And it includes telemedicine, web-based analysis, email, mobile, text messages, wearables, and everything. I'm talking about several topics. First of all, why are we here? What is the changing in the ecosystem? I will talk about the three important P's. It's the patient, the physician, and also the payers. We'll talk about remote monitoring, which is becoming very important, the needs in cardiovascular, especially the cyber, and where are we going in the future. So we all see the revolution with connected health that happens in the last few years, and this is the connection. I have a slide from Peter Fitzgerald that showed us that almost 90% of the world is connected to some kind of mobile, where only 40% have a toothbrush. So you can see that wherever we are connected already. And not also the regular companies are connected, but also the big pharma, and especially the big Google is
becoming the biggest digital, and today IT meets empty, where the IT companies are meeting the medical technology companies and merging together. And you can see that most of the big companies like Samsung, Philips, even Alibaba, all of them are moving into the digital ecosystem of health. And the experience is mainly during application, which with the application, and we'll see it, it appeals very much. You have an immediate reaction, you can recommend to friend, it's usable, and slowly, it's becoming very effective. So definitely the ecosystem around us is changing very quick. Now let's talk a little bit about the patient, physician, and payers. And we can see that the mHealth medicine is actually good for everyone. For the patient, it's simply to use, and it gives them confidence. For the professional, it's easy to monitor outcomes, to get in touch with the patients and efficacy. But also the payers, it's cost saving, and it's a nice model. So all the three P's are merging together, which brings us to the question is, how is medicine going to be in the mid-century? In 10, 20 years, is it going to be this kind of physician, or this is going to be the future physician? And I have the feeling that we will be as physician replaced. And Vinod Khosla, who is one of the imaginaries, said that in few years, technology will replace 80% of the physician. And the question is, what will be our role in the new era of medicine? Another question is, what is the use of remote monitoring? And we can see that this is the age of replication. If you look into Samsung or iPhone, you have today more than 300,000 different apps on medicine. It can be tracking, it can be training, it can be nutrition, it can be anything. So today is the era of application, but not only there. We have an epidemic of wearable. You have all the kits with Apple, you have all the wearables, you have the Fitbits with the ring, you have the eyes, you have the SIM bands. And if you just take a very quick look, you have an explosion of connected health technology. And this is going to help us to have the patient 24/7. And another thing is the biosensors. The biosensors are getting very small. If you look at this have 1 billion biosensor on 1 square centimeter. In amazing. You can look at this, a small thing on your hand. It can have always a 1 billion monitors, can give you real time and can send with an RF all the information that you want. And I believe that this will be in the future, and you can see a trillion sensor on the skin. You're talking about now Tokyo 2020. Everything today is being done by sensor. You have wearable sensor on the athletes, and every movement, every muscle is monitored by the sensors. And this is from Time Magazine, which says that in the future, we will never be offline. 24/7, everything will be monitored. Heart rate variability, blood pressure, saturation, respiratory rate, ECG, arrhythmia, and everything. So we are going into an age where all the information will be available in the cloud 24/7. Now, what's the application in cardiology? And the needs in cardiology are still very big. You know, 1 of 3 deaths are due to heart disease or stroke. 7 million people die from heart disease every year. 3 million people in China. 7,000 in China. I just gave a lecture in China. During my lecture, I told them 50 patients died just during a very short lecture. So every 30 minutes, also in the United States. And if you look at this, Valvular heart disease is still a big problem, and we'll see that digital has to do a lot with that. Sudden cardiac death, hypertension, heart failure, diabetes, digital health, and especially the COVID, and we'll talk a little bit about the COVID. We realize that the population is aging. They want to live better and longer, and part of it will be through the digital health. Let's take, for example, heart failure monitoring. You know, it's one of the biggest problems. 25% of the recurrent admission is due to heart failure, but patients will have all the sensors to deliver all the information to the physician, heart rate variability, stroke, respiratory rate, and everything. So the patient will be monitored and will be able to prevent this rehospitalization and prevent the acute exacerbation while getting all the information online: ECG, arrhythmia, heart rate, oxygen, respiratory rate, temperature, and everything. And I can tell you that at least in Israel, and we'll show it in the ICI, there are already companies that can give you all the information 24/7. Another big issue that arising from that, and a side issue of the digital, is the cybersecurity. And this is a main issue because we see more and more cyber attacks on the national heart system. And the question is, why are the hackers going after the healthcare data? Because really, healthcare is a very important thing. The data that you have in your health files are very important and very costly. And not only that, you can actually hack things. And if you have a pacemaker or a CRT or CRTD, you can definitely reprogram and kill patients remotely. And I don't know if you know, but Dick Cheney was the vice president of US during the Obama, had to replace of his CRT because the CIA was afraid that he's going to be hacked and shocked with the defibrillator. So in shortly, where is the future of connected health, digital health reforms? So we are moving more and more into what I call the digital doctor. The role will be is that we have all the information that is there, and the book that was several years ago, question mark, the digital doctor, hope, myth, and harm, is really becoming a truth, because people believe that in few years we'll have a health spot in our kitchen or shower room, and in the morning we'll be happy to talk to the doctor, check ourselves, the ears and everything, and we'll have the regular checkup at home. The doctor will be able to control the patient and check for non-adherence, will be able to know exactly is the patient taking the medication or not, will have smart pill and smart pill boxes, will have alert whether the patient is getting the medication and not getting the medication, will have ability to have what we call big data and analytics, taking into the cloud million patients, and sophisticated algorithm will be able to know what's happening with the patient and know in advance in epidemiology, in big drug trial, and also, especially in personalized care, will be able to say, based on your genome, based on the information, you have to go, you don't have to go to a checkup, etc., etc. There are a lot of companies that are working now on very smart, very small sensors. So the devices in the future, let's say take TAVI, will not be just a valve, it will be a smart valve, which will have a sensor for flow, a sensor for saturation, and we will be able to know in advance whether you're getting restenosis, whether you're getting incompetence, and the flow will go to the physician without having the patient go anything. So the whole health cycle will change. We have here the patient. The patient will be monitored. Part of the information will go directly to his smartphone, and from his smartphone can go either to the physician or go directly to the cloud. From the physician, it can go also to the cloud, but the physician can prescribe drugs. It will go to the healthcare provider, send the drug to the patient. So the whole healthcare cycle will be totally changed. The COVID revolution brought us to different things, with some good things and some bad things. On the one hand, we can see that the world is totally changes, and we have discussed it because we are all under the COVID era, and we don't know how it's going to last and how long. But we do know that a lot of changes, the genetic changes, vaccination, are going to change the medicine. The good things regarding the digital is that we have acceleration of technology absorption. You can see that both Amazon, Facebook, Microsoft have changed significantly. Zoom, as you can see, has changed our life. Instead of having a face-to-face meeting, we are all far away. But if you take Amazon, for example, they have to hire 100,000 people to meet the demand. So definitely the COVID is changing the world, also the digital world. Digital health is very much affected by the corona pandemic, all the way from the prevention, diagnosis, triage and testing, tracking the patients, and treatment. We have the treatment in the quarantine patients, we have the treatment in the hospital management, and now we have the post-care patients with what we call the post-COVID, and a lot of this is being done by medical technology and digital technology. So COVID is enhancing the thing, and this is bringing us to the fact of investor expectation, and we can see a huge surge in investment that started in 2020 in telemedicine, remote monitor, symptom checking, digital therapy. So in 2021 and 2022, we have seen that the number of new companies in regular device companies is going down, while the digital companies is going up. And I can tell you, only in a small country like Israel, we have close to 1,000 digital new companies in the last several years. We also have some bad effect of the COVID, and we all know it, the pericarditis, the myocarditis, I'm not going to discuss, but definitely for cardiology, COVID has also changed a lot. So in summary, the digital revolution is here, and the 21st century is the century of the digital revolution, where we are going to see a lot of change, and maybe the big pharma company today will be Google and other companies, and not the Medtronics or the regular pharma company. So in summary, I think in the next few years, we're going to see a totally different future, where the biotechnology, artificial intelligence, virtual reality, where we see it growing very nicely, especially the telecommunication that we can see growing very quickly. And of course, the robotics, which is enhanced a lot by digital technology, and the 5 giga new networks are going to change totally the future and the way we are practicing medicine. So where are we? We are now kind of in the middle. We don't see the revolution, we don't feel the revolution, but we are in the middle of a big revolution, maybe one of the biggest revolution in medicine. And like, you know, sorry, the last slide is a quote for Stephen Jones that says, right now, one of those moments that you are influencing the future, and I feel that you and all of us are in the middle of a revolution that is going to change entirely the field of medicine. So with this, I would like to thank you very much and invite all of you for ICI 2021, which I still have a lot of hope that we can have face-to-face in Tel Aviv in the first week of December. Thank you very much.
Okay, thank you very much, Chaim. It was an amazing overview, and I don't know if there are any questions, any discussion from the moderators. So I think that I can tell you that here in Tel Aviv we are facing a very hard summer now, and I think that we have to go on with the next presentations. So I don't know if there are any questions, any discussion, David.
If you let me, because
Si se puede hacer una pregunta.
yes,
Yes.
Alejandro, I want.
El profesor Lotán.
Yes.
Of course.
Yo quisiera preguntarle, no sé si en español o en inglés.
I'd like to ask you, Professor,
Biology. Do you believe that maybe it's possible to put both together?
Well, you know, sometimes the technology is faster, sometimes the biology is not faster. I think that the corona boosted very much all of them. The world understood that biology is very important, and now the merge of biology and technology is going to change medicine. I think that only, let's say, 2030, medicine will be totally different. We are in the middle of it, and a lot of startup companies started a year ago, 2 years ago, but I think in 5 years ago, medicine will be totally different.
And what is the future of doctors? Doctors gonna be replaced by machines, or what's gonna happen with medical students?
I think that it's going to be a big change in the role of doctor. I showed you the robots. Robotic surgery is going to advance. I can tell you that we have 2 companies, for example, in Israel, which are working on the catheterization with Sony PlayStation, where you can stay now in Argentina or Brazil and catheterize in India. And that will be in 5 years. So it's very difficult for us to understand, but medicine is going to change very much. I told my son to go and practice psychiatry. I know that Juan Granada's wife is a psychiatrist. Maybe with psychiatrists we'll have more work.
Very good.
May I ask something?
Yes, go ahead, please go.
And you know, doctors themselves exert some sort of placebo effect on their patients. Will that be lost? And the omnipresence of technology?
I think that part of it will be lost, definitely, because, you know, we have the personal touch. It's not only placebo effect, it's the personal touch. But unfortunately, this is part of the price that we'll have to pay with modern medicine. On the other hand, you'll be able to speak with your patient, see your patient, get all the information 24/7. So, you know, in the future medicine, there will be good things and bad things, but definitely it's a revolution that we cannot stop. And that's why I said it's evolution or both of them. We are in the middle and we cannot stop it.
Do you think the pandemic accelerated the approval of telemedicine?
Definitely, yes. I can see the number of companies, you know, just few years ago, most of the money went to devices. Today, I see more and more VC put big money on digital. And if they put the big money on digital, that will be the future.
Thank you.
Quick question to Chaim. I'm sorry. Can I ask a quick question, David?
Hi, regarding the regulatory approach to access patients' data, do you think this is going to be a big issue? Most of the patients are not going to be signing consent to use their data, or this is going to be something that's going to happen electronically as well?
Well, I can tell you that the entire cyber, I just touched it, on patient data and everything is a big problem. I know that the FDA, I was engaged with a cyber company in Israel. I know that the FDA is aware and changing the regulation. There are new white papers from the FDA regarding the patient's protection and everything. And cyber definitely is running very quickly in medicine. You know, in the past, the big cyber companies were mainly in the fintech, in the business, in the banking and everything. Today, there are a lot of new cyber companies in medicine because they understand the importance of that. But you can actually have the patient without having his personal data, so it will be just the data, but without the ability to identify the specific patient. So the new companies are going to a way where you have all the data, but you cannot identify specifically the patient.
And I think that the issue of the cybersecurity is very important because the cyber threats in healthcare are very breached. It's a very breached field now, and it was very impressive about the cybersecurity that to emphasize now in the presentation.
Yeah, you know, I emphasize it because I just realized there are a few cybersecurity companies in Israel. Until 2 years ago, there was no one. And now several companies started because they realized that this is going to be a huge growing market, digital health. And when you have such a big market, definitely cyber will be a very important part.
Yeah. Okay, I think that
Me preocupa que cierto.
I'm concerned that certain countries, especially emerging countries, are going to be laid back, way behind.
Wish you a successful meeting and wish everyone to stay safe. Thank you.
Nice to see you.
Thank you.
Vamos a continuar con el.
Let's continue now with the next speaker. I have an echo. Can you hear me well? We're going to continue with the next speaker. You have an echo, David. Yes.
Bueno,
Hola.
Se escucha bien.
Now we can hear you well. The next speaker is Juan Granada. He is the Executive Director and Director of Innovation of the Cardiovascular Research Foundation, Skewell Center for Innovation in New York. It's an innovative center, excellence center that we have recently visited. Juan, the floor is yours, so you can begin your presentation. Thank you, David. And I'd like to thank everybody for this kind invitation. And the truth is, it's something very important that we're having these innovation sessions in this type of congresses in Latin America. I'm going to switch now into English.
Thank you again for the invitation. And what I'm going to do in this presentation is to kind of give an overview of the most impactful technological trends and opportunities in medical technology innovation. No, one of the things is, looking at the people that we have in this panel, looking at the history of our field. Our field has been always, full of a lot of people with a lot of ideas that actually have been implemented throughout the years to really get us where we are right now. Even though everybody references Andreas Gronsek as the pioneer of our field because, he was the one who pushed the first coronary angioplasty in humans. If we actually go back and see the history of our field, is really rich of stories of innovation, new technologies, new techniques, new procedures, new devices that continue to push and propel the field forward until the place that we are today. You can actually go back to the 1929 with Werner Forsman when he did the first human catheterization, actually proved that a gate to the heart, could be accessed, to the stories of Mason Sons doing the first selective coronary angiography on the RCA, Daughter on the first peripheral PTA in '64. Again, Judkins, that was a pioneer in catheter development. And it was the first coronary angioplasty in 1977, which essentially created a new field that did not really exist. And it's just because the development of this technique and procedure that we are where we are at the present time. So we have to be very grateful, to all the pioneers in the past that have really made a lot of contributions to our field and have, really taken us where we are at the present time. A second important component of our field in innovation is being science. And I don't really think that there is a field in medicine that has really combined scientific developments with technological developments with research and data dissemination. And I really think it's because the aggressive research and science that is being done in our field related to all these inventions that we have been able to move the field forward. And it's really amazing for the ones who really like the history of innovation and devices. When you just go back, you really read about, how devices were developed were actually based in a lot of these lessons that we learned throughout the years of mechanisms of device success and failure. These are 4 beautiful papers that essentially documented the effect of balloon angioplasty in vascular injury and healing, and essentially were the foundation of the invention of the stent. And it's a big honor for me, to have, Dr. Julio Palmas here, with us. And I have told him this many, many times. For me, the invention of the stent is perhaps the most important invention in our field, and I actually would say medicine in general, because the stent is in a way the mother of all inventions that we have right now. If you look around, all the inventions after the invention of the stent were derived for a new field, not only on the medical side of things, but on the technological side of things, that created the foundation for development of balloons, of wires, of new alloys, of new metals, of new polymers, and all these inventions, so all these processes and methodologies and materials have been used right now to develop new technologies, even in different fields of medicine. So this has actually been one of the most impactful, inventions in our field. And you can actually see here, Julio with the team in Brazil, in Dr. Souza's department at the time when the first stent was deployed. And again, it's science that actually helped us to refine the stent in terms of characteristics, in terms of flexibility, architecture, vascular healing, thrombogenicity, and so forth, and essentially get us to where we are today. Again, science helped us to improve these technologies and really document the mechanisms of success, but most importantly, again, failure. And that's the reason why drug-eluting stents, were developed and again, validated in the first implants. Here you can see by Alex Abizides group in Brazil. So it has been this combination of, ingenuity and ideas and technology and amazing clinicians that have really taken, this field where we are at right now. One of the biggest impact that the invention of the stent had was in the treatment of acute coronary syndromes and acute myocardial infarction. And right now, it's amazing really to see the impact in clinical outcomes that the invention of the stent had and the simplification of the procedure, which, in 1955 was limited to aspirin, heparin, EKG, and oxygen. And I really think this has been one of the most impactful therapies improving clinical outcomes in patients with acute coronary events. The impact in mortality before the invention of stent has been significant, and people actually claim that it's been a more than 80% mortality reduction over time by the introduction of primary PCI, which is being greatly facilitated by percutaneous techniques. One of the things is technologies get developed, they get refined, and eventually they plateau. And now drug-eluting stents, I really thank God, to the maximal point of sophistication. And people actually have tried to modify the stent by essentially minimizing the amount of injury during time of implantation, modifying the stent surface, adding polymers to the surface for drugs for biocompatibility, developing polymer-free systems, and actually even fully bioresorbable scaffolds. But we got to the point in which, on my point of view, to be able to really disrupt the coronary field, a most disruptive out-of-the-box technology will be needed, because the stents got to the point in which they're just too good to be able to beat up in any clinical trial. But innovation has evolved since the introduction of the stent, and at the earliest stages of our field, mechanical solutions to later stage diseases, were the prevalent rule. For example, a stent to treat an obstruction. And that was kind of like the core of the need of invention in our field. Then in the mid-1980s, there was an introduction of biological solutions to early stage diseases, the prevention of diseases such as the introduction of statins and the big development in pharma to be able to prevent, chronic conditions. In the 1990s, there started a big boom in simplification of surgical procedures and pretty much actually going into the minimal invasive role. For example, with the introduction of TAVR and other technologies in different fields, trying to simplify the surgical procedures into simpler and actually less invasive forms. And as actually Chaim essentially showed us in his presentation, now we are in a new era of simplification of patient care through the use of digital technology. So one of the things is we really need to adapt the innovation model, the way devices are invented, and the goal of these devices according to how the innovation field is evolving as well. So we're facing now a current technological paradox, because technology validation requires a rigorous process. It's very expensive to develop. And I have to tell you, for devices right now, the rule is approximately $1 billion before they make it to the market. And there is a large disparity gap in technology access worldwide. New innovation drives actually are now prevalent. And a lot of people are talking about the good enough technology concept, in which we develop technologies that are really not that sophisticated, but just good enough to be validated and essentially help a larger number of patients. Now we're talking about technologies that not only treat the patient, but add, as Chaim was talking about, an additional benefit, especially quality of life. We're talking a lot about saving costs through avoiding other procedures and being cost effective. And there is a big incentive for outpatient management. So these are actually new drivers for innovation that we didn't have actually before in the 80s and the 90s that we need to take into consideration as well. So what are the main drivers, the big changes that actually I see for the future? I think the first one is on cardiac imaging. And I really think in the future, diagnosis of cardiac and vascular diseases will move completely to the outpatient setting, decreasing the need of invasive diagnostic procedures. This is what I call prescriptive diagnosis. With the evolution of CT and MRI, I really think that the number of diagnostic catheterizations will eventually decrease. And with the quality improves, we're going to be able, with the introduction of FFR use by CT, to pretty much have the patient that comes already with a clear picture and the intervention go to the cath lab just for the interventional phase. One important trend, as you can actually see here, is in the use of intravascular imaging. I mean, I think we have enough data now to show that improved clinical outcomes in complex PCI, but it's still the penetration and the use is actually very low. One of the main limitations is the use of, obviously, hardware like pressure wire, plus the time, plus the use of expensive drugs like adenosine. And nowadays, we see that everything is being eliminated by the use of simplified forms, which essentially are pressure wire-free, drug-free FFR that is actually used only with the use of coronary angiography. This is one of the examples that essentially shows how essentially doing the same thing, but with actually less cost, could potentially disrupt the market. But now new non-invasive imaging tools can't really do everything we do in the cath lab, and the technology is getting better and better and better with a high definition 3D computational models and CT angiograms that actually can do FFRs and give essentially the entire picture of what the patient is going to need in the cath lab. This is actually the way that the future is going to look, especially if it's integrated with myocardial perfusion. And there's a lot of advances and a lot of work in these areas as well. Another thing, an important limitation, is the use of skilled technicians and operators to be able to do advanced imaging in patients. This is an example of the Shark Tank winner last year, in which this is an automated software that essentially tells anybody without training how to actually obtain a high quality echo. The only thing you need to do is put the probe in the chest, and essentially the software is going to tell you exactly where to put the probe, where to move the probe to be able to get a high quality imaging. This is very important, especially in centers that do not have the expertise. They don't have the skilled people to do ultrasound, remote areas, and actually any other areas in the cath lab as well. Another important change that I see in the future is procedural planning that will also be based in non-invasive tools, allowing the personalized treatment of specific disease conditions. Right now, we do, 2D reconstruction, look at CTs for interventional procedures, but images in the future are going to look like the ones that we see in these pictures that are actually human-like. They're more like the atlas-like. And instead of spending time trying to reconstruct these 2D images, we're going to be able to look at the images in a way that now the treatment will be personalized according to the anatomical abnormalities or changes that you see in those images. There's a lot of work on integration of multiple modalities for the cath lab, for example, echofusion with CT and fluoroscopy, a lot of work in fusion of imaging and physiology, and personalized interventions using 3D printing to be able to do procedures based on the patient's anatomy. And we are doing this right now in complex structural procedures in which essentially we print the 3D heart and do the intervention according to the patient's needs. Peripheral vascular disease is really growing exponentially, and I really think in the next 10 years, technologies to treat BTK disease will be validated, will improve clinical outcomes, and will take a central role in the interventional field. I really think this is one of the most, up and coming and promising areas of innovation. We're seeing now an increase in development and non-stent local drug delivery solutions using nanoparticle with sirolimus to treat this disease. Very exotic ways to actually do natural bypasses in patients with little options. So doing a percutaneous bypass using the veins, and a big push to go now after the venous system in patients with thromboembolic disease or venous insufficiency as well. Work in pulmonary embolism right now is really picking up, and we have at least 3-4 big technologies being developed to treat pulmonary embolism in a percutaneous way by the use of extracting devices or lytic delivery devices. Another important point, and is perhaps, as Chaim said, perhaps the fastest growing area, is the progression in minimal invasive interventions, especially because it can have an important impact in outcomes in healthcare cost. Right now, multiple annuloplasty devices for mitral and tricuspid are continue to make a lot of progress clinically. I think now the replacement of valves is percutaneous valve, mitral and tricuspid has become a reality. This is still, in early validation phases, but to be able to really get to this point in which we can put a catheter through the septum and deliver a valve percutaneously is really an amazing achievement that can really disrupt the surgical field as well. At TCT, we presented, at TVT, we presented a phenomenal intrepid case in the mitral position. And we also continue to make a lot of progress with the percutaneous devices to treat mitral regurgitation and stenosis. And now the full replacement of these valves is now possible. Still early stages, but you can really see where the field can really go, especially in development of minimally invasive tools. The same thing is happening on the tricuspid side. And right now we have at least 3 or 4 technologies developing dedicated devices to percutaneously treat the tricuspid valve. And right now these trials are in a very advanced stage of development. And replacing the tricuspid valve right now percutaneously is something that we are doing in centers that are doing this type of research, becoming really common, almost a standard of care. Heart failure is perhaps one of the biggest areas of growth in interventional innovation, and emerging technological advances will allow the multimodality treatment of heart failure, especially in combination with the structural heart technologies. And there is a lot of push, a lot of work for development of devices that can really provide hemodynamic support, still being minimally invasive, and decrease the morbidity related to implantable devices in these patients. And this is a field that continues to grow with multiple hemodynamic support devices, internal, external, right now under development. And actually the field continued to expand to different horizons. And now we're talking about a new field called metabolic neuromodulation therapies that could be transformative to the treatment of metabolic and chronic diseases. This is one example of those in which hepatic nerve denervation is being proposed to be able to treat diabetes and metabolic syndrome. It's a very interesting approach with very interesting early data in animals and humans, or the percutaneous treatment of pulmonary hypertension by inducing pulmonary artery denervation. And there are at least 3 technologies trying to achieve that with very intriguing results. Digital healthcare, without any doubt, will revolutionize the way healthcare and medical education will be delivered. And one of the first changes that actually are occurring right now is the simplification of complex wired technologies. You see an example here of a sleep study, electronics, how it being simplified to a very simple, flexible electronic patch that can be put in the chest of a patient. And as actually Chaim was talking about, a lot of work on monitoring, and this has been simplified to the point that really using a single ring can really get a lot of biometrics in a patient and being stored almost in real time and monitor things like atrial fibrillation, temperature, respiratory rate, and can have a significant impact in chronic diseases, especially heart failure. Chaim talked about this. This is actually something that has been going on for quite some time. We had the privilege to do the first in-human study with a robotic angioplasty system in Colombia in 2010. The technology continues to move, and as Jaime said, it's still a ways to go, but mainly, for example, for the treatment of a stroke in areas in which people don't have neurointerventionalists, this can really be very interesting. And now there are reports of remote angioplasty by using the system, kilometers away from where the equipment actually is, which can have a phenomenal impact in healthcare, especially in underserved populations and areas. One of the big issues we have right now is, and I talked about this in one of the opening sessions earlier, is the rapid introduction of actually data that is outpacing the capacity to process information and training. We're getting all these technologies, and soon enough, we're going to have the need to really train and produce advanced skills for all these people. We're actually forcing new interventionalists to interpret complex 3D anatomical abnormalities, adapting to techniques, not learning the interventional training, and navigating catheters in unknown anatomical spaces to be able to really increase the possibility of use of these technologies and help patients. We're going to have to really make significant changes in the way we teach people. And we started to see now very innovative ways to essentially train people with virtual reality and other imaging tools, and in that way remotely being able to train a large amount of people in this type of technologies. There are also reports of the use of this type of technologies for interventional procedures, and this is a group very close to us, from Poland, that they're using VR and AR to do a puncture of getting vascular access using this type of techniques, using the patient's anatomy, improving actually the safety and personalized use of these devices in these patients. So the field is actually, in the way that I see it, is still fully charged with opportunities and fully charged with innovative solutions. The amount of skills that will be needed to really do these procedures in the future will be significant. I really think physicians are going to have to specialize in different areas because there is just too much to do. But I think it's exciting for the new generations. I think it's exciting for the field. It's exciting for the patient. But one of the important things is we're going to have to find, a way to be able to give access, equal access to all the populations around the world, because we know right now the lack of equity and disparity that exists in the access to technologies in all the patients around the world. So thank you again for the invitation, and I really hope this was a helpful talk to all of you. Thank you again.
Okay, thank you very much, Juan. It was amazing, also an amazing overview. I have a question about the issue of the financial adoption of these new technologies, because here in Israel, we have a little bit problems with the reimbursement, even with the CT scan of the coronary arteries. Could you expand about this issue, this problem?
But I wish actually I had an intelligent answer to this important question. Disparity is really unbelievable, especially in Latin America. I mean, if you see even TAVR, that is now labeled as a mature technology with very well recognized health economics models, is poorly reimbursed, and the penetration is still very low in Latin America. So as I said, I mean, I really hope at some point we find a way to balance technology development with access to patients. And I have to tell you, it has to work. I mean, I'm not really the type of a person that looks into the future and I'm crazy about everything that I see. It has to work. It has to work for the patient. It has to work for the health system. It has to work from the health economics point of view, and it has to be safe and have good clinical outcomes, because otherwise it's not really going to work. But there are a lot of technologies out there that do not really make it to patients. And just because inequity that is related mainly to the capacity of countries to pay for the technology, and it's actually sad. It's really, really sad. The disparity is very, very sad.
Thank you.
Nora Bar, ¿quieres hacer una pregunta. Sí.
I would like to know if you are thinking to develop a fully functioning and autonomous artificial heart, and how long would it take?
Boy, you know, Julio would like to get his opinion as well. I came from a center that did a lot of work, trained, you know, DeBakey Heart Center, where they really, Dr. DeBakey was pretty much his ultimate dream. And they got, you know, close to have prototypes that were used, a lot of them in animal models. There are a lot of issues, a lot of complexities. One of the things is transplant is becoming more efficient. Hemodynamic support devices that are less invasive, and they're like a partial replacements, are also getting better, simpler, smaller, and allowing patients to actually move, you know, around, as I showed with a generator. So the thing is, some of simpler technologies have outpaced the need of actually having a full artificial heart. But I really think that's the ultimate dream, to develop a technology that can either, you know, partially or completely replace the heart with biological or mechanical ways.
Alex, ¿quieres hacer alguna pregunta?
Alex, I think, would you like to make a question?
The sound is not so bad. Microphone open. They have to close the microphone. So, a quick question to Juan. Juan, I think that we really conquered the aortic space in terms of structural heart intervention. And I know you mentioned in your lecture, and it's, of course, a long answer, but quickly, what do you think is going to be the future for mitral insufficiency? Do you think that replacement or any kind of annuloplasty? What do you think that we should bet our eggs, put our eggs in which basket?
Look, I am, one of the things with catheter-based technologies is that what the surgeons do in mitral intervention is more of an art than science. I mean, these guys, they really know how to repair a valve because they see it and they put the stitches where they know they're actually needed. This is something difficult to reproduce in a standardized way with a catheter technology. I'm making this introduction because I really think replacement is more practical, is actually easier, and is more reproducible than repair. Not because I really think is superior than repair, but because I really think is simpler, faster, and more reproducible when it comes down to training people to do. So if you ask me, I really think in the future for mitral, and that is happening already in both mitral and tricuspid, the replacement field is moving faster than repair. And I really think it's got the potential to get there, you know, before any repair technology can really make it to the same point.
Alejandro.
Ya me contestó la pregunta recién que le hizo Alex.
Perfecto.
Gracias.
Bueno, vamos a seguir con la próxima ponencia.
So we'll move on to the next talk. Dr. Julio Palmas. He was born in La Plata, Argentina, honorary member of CACI. We all know his invention. He was a pioneer of interventional cardiology, developing stent as a new way. He identified a need, and from there, the idea of a stent. This was a creative event, a synthesis between Julio Palmas and Andreas Grützing. No one would have thought, except for some, how far the advances of this methodological approach would be. And today we cannot see how far it will go with these new technologies, but we can anticipate this progress. Julio? Thank you, David and Juan, for the introduction. I will talk about I need to analyze the relative value of regenerative versus prosthetic medicine, which is the dominant tool these days. I will continue in English because the slides are in English.
As I said, I'm going to compare the relative merits of the two main developing innovation avenues, which I think today in the cardiovascular area is regenerative, which we don't hear much about, and prosthetic. So let me see if I can advance. So, yeah, I'm having difficulty here advancing. Okay. So, essentially, to talk about regenerative medicine, it is important to distinguish it from organ and tissue transplants, which are largely exemplified by bone marrow, blood transfusion, and heart-lung transplants, and animal tissue transplants, most commonly represented by surgical or transluminal cardiac valves. So we are going to leave it at that. The regenerative medicine approach can be best exemplified by genes encoding signaling factors and by the use of engrafted progenitor cells. Those are the two main avenues. Prosthetic approaches, well known to all interventionalists, involves the use of synthetic constructs or essentially class 3 implantable devices. So currently, cardiovascular devices represent a real thriving technology with a steady stream of new devices expecting high likelihood of eventual approval. So essentially the industry and private groups and institutions are essentially moving this machine forward. Regenerative medicine is a younger discipline yet to be successful with a lower expectation for breakthrough developments. Right now, there are 1,200 clinical trials for regenerative medicine in progress, but there's no single FDA-approved therapy in this area. So regenerative approaches like, for example, multiple sclerosis, Crohn's, Parkinson's, muscular dystrophy, sickle cell anemia, and so forth, have no practical therapeutic solutions, and therefore they are amply justified for an early trial, and the regulations regarding human experimentation should be facilitated as they are. However, mainstream pathologies like cardiovascular and stroke, for example, which is the area of interest here, have well-developed therapeutic approaches and options, and experimental use of regenerative medicine should be investigated under the same stringent parameters used for other novel therapies. So in the cardiovascular area, the main approaches of regenerative medicine have been the use of gene therapy and the introduction of progenitor cells by direct intracardiac injection or coronary artery infusion. The bioresorbable stent should be considered, in my opinion, a regenerative approach, insofar the expectations behind its use relative to reestablishment of vessel motion and vessel remodeling, but we're going to leave it at that. This paper summarizes, and I apologize, a little bit busy, but summarizes almost 20 years of experience with gene therapy in the coronary and in the peripheral circulation. In the coronary arterial disease, I'm sorry, let me see, I think I advanced this. In coronary arterial disease, the edited genes used encoded most often growth factors such as fibroblast and endothelial growth factor, FGF and VEGF. The vectors most commonly used were plasmids or adenoviruses, so there were no retroviruses in this series. In peripheral arterial disease, the commonly used genes were also VEGF and FGF, and also hepatic growth factor. When you look at all this and you see the arrows here pointing to whether the trials meet primary objectives or not, the end results were a mixed bag, with most of the main endpoints missed in clinical trials. However, a significant number of secondary endpoints were positive. And that is something that is a takeaway point. Okay, the trials of myocardial cell therapy are analyzed in this recent paper comparing supportive versus contradictory clinical evidence. 9 out of 10 reports published in the last 2 years, 2018 and 19, were not supported. This is in stark contrast with the previous 17 years, which showed predominantly supportive literature. Here, I encourage you to follow this article. It's actually published in Circulation in 2020. The subject whether the heart muscle can or cannot regenerate has been extensively debated. An important paper against this notion used carbon-14 to establish heart muscle cell turnover. It showed that past age 10, the heart practically does not regenerate, with myocytes regenerated at a measly rate of 0.3% per year after age 60. And the same with cardiac endothelial and mesenchymal cells. It is a very nice article written by Marvan, who is chief cardiology at Mount Sinai in Los Angeles, and it was published in JACC last year. Settles the issue by accepting that myoblasts introduced by direct injection or coronary infusion in the heart engraft very little, if anything at all. In fact, 6 months after the procedure, you can hardly see any myoblasts in the target. However, many beneficial factors, mainly subjective, can be explained by the action of myoblast exosomal particles carrying many helpful signaling molecules like a small RNA. But there is a large amount of small molecules via exosomal secretion, and in fact, there are thousands of them, and that actually is stimulating a very novel, interesting area of therapy. So based on this background, I apologize that I had to go through things that had been already essentially written, but I would like to propose 2 potential future avenues for cardiovascular therapy. One is implantable cell colony organoids, and the other is phase structural nanomolecular buildings. Of course, these are my proposed designations. So the first concept is a combination of genetically modified stem cells capable to produce useful factors, but are enclosed in a confined environment for mutual protection of the cell colony for one part and the host on the other. The biomolecules produced will aim at selected targets on the genome and the epigenome. This concept pursues a defined therapeutic target, a steady delivery with potential feedback and addressable possibilities. And this is essentially going back to Chaim's presentation. So all this, eventually all these organoids could be essentially addressable and be connected to the external environment. So, but this would essentially provide you with a magic bullet concept. To illustrate this point, this possibility, is one example out of the many small interfering RNA biomolecules that are being developed today. So this siRNAs, a good example is olpasiran, or AMG 890, which interferes with the RNA encoded by the LP(a) gene, blocking liver production of the molecule. Conceivably, this essentially is an antisense molecule. Conceivably, this siRNA could be produced by a captive cell colony in a semi-synthetic implantable organoid, instead of having to be introduced parenterally. The theoretical advantage of using organoids are obvious as seen above. You know, I don't have the time here to explain, but everybody is aware of the dangerous in vivo vector, particularly retroviruses. You know, as we pursue more aggressive vectors, then we have to deal with the issues of essentially untoward reactions. Avoidance of unwanted host genome modifications, and these are permanent modifications. Control of inefficiency in the target cell colony transfection. All these vectors actually have big differences in the effectiveness, and from a few percent to, you know, to a significant percentage. And that is the motivation behind more and more powerful vectors. Avoidance of inheritable germline modification, which is a dreadful thing, that any modification we do by genetic engineering can actually be inherited. The other is the possibility of off-target effects and the possibility of oncogenicity, creation of tumors, you know, storm immunological reactions. And one advantage is that these organoids could be removable, renewable, modular, and as you know, Hein mentioned, the possibility that can be addressable. So the biological components of the organoid is now relatively accessible through the use of CRISPR-Cas9. So essentially the biological part, the cell colony engineering, is actually relatively, I wouldn't say simple, but it's very accessible. And this is because of this revolutionary and widely used molecular machine that can edit targeted genes for replacement, addition, or deletion, or better known as knock-ins and knockouts and knockdowns of DNA sequences. So the CRISPR-Cas, this magnificent discovery that deserved the Nobel Prize already, it stands for cluster regularly interspaced short palindromic repeats. Both the equipment, the supplies, and the education to use them are widely available. In such a case that there are many training and certifying courses being offered today, and you can go to the internet and you see all kinds of different courses, actually some of them promising certification with just 70 or 100 hours of education. So this is, you know, a mature technology that is being used widely. Now, the synthetic component is a little bit more tricky, but it's technically feasible, and that's the area that I am more familiar with. So consider this as a real estate for cells, essentially. The technology to do it is somewhat related to microelectronics. I'm not going to get into the details of manufacturing, but it's essentially microelectronic manufacturing with nanomolecular definition. And of course, we can use some special surface properties which we have learned and we developed to help cell guidance and cell adhesion, like microgrooves and microdots, and apply them to the cell habitats so that the cells can be engineered to be able to live in these environments, and the environment, or what I call the prosthetic extracellular matrix, can be engineered to have this long term. All right, the second concept is the phase structure nanomolecular building. Actually, is the creation of devices partly in vivo, in vitro, and partly in vivo. And that, I'm not going to go too much into it, but suffice to say that the whole thing started with essentially the publication of self-assembly monolayers, which was the first time that you could actually create geometrical growth of particulate material by using selective adhesion. And so the self-assembly monolayers of gold particles essentially show symmetrically placed complementary reactive groups to yield geometric constructs. But I think that gold particles obviously will not have a role in the future. I think carbon-60, the nanospheres of any size, actually, not just 60, is the potential basic tool of the nano engineer. The number 60 denotes the number of carbon atoms in the sphere, so that smaller and larger spheres are easily available. And just to give you an idea, dimensionally, carbon-60 is 1.1 nanometers in diameter. It's extremely non-toxic, robust, and magnificent new material for the semi-synthetic creations. So I would call the first step the so-called the structural nanoblock. And its design needs to accommodate secondary builds of increasing complexity. And the tools for sequential building may be depending on the binding of complementary sites triggered by chemical or biological reactions. And these need to be robust chemical reactions. But we don't have a basic nanoblock today, but consider it like a Lego for the biological systems. And eventually that would probably be the first step of the in vitro portion of the procedure. So essentially, to build a structure in vivo, the critical steps will first of all design and have a nanomolecular building block that actually can be modular through the use of different reactants. Create, first of all, an active functionalized site in the treatment, maybe by one moiety of a very reactive pair of molecules like biotin and streptavidin. So the biotinylation will essentially be like the creation of the active site, say whether that is a vessel or is the annulus of a disease valve. Then insert the blocks that will search and recognize the site, and in this particular case could be tagged by streptavidin. But I don't think this is going to be the future because there is a size incompatibility. I think the structures it could be used by using first a direct covalent reaction, but I think essentially the complementary attachment of these nanoblocks will be by short range force or intermolecular building by steric effects, pretty much the way the proteins of the ribosome factory turn into secondary, tertiary, and quaternary structures, essentially by the application of short forces, short range forces. Or I think a more reasonable will be to use RNA sequences to orient correct bindings by complementary attachment of antisense oligonucleotides, probably using RNA and anti-RNA and oligonucleotides, or using codons and modified amino acid sequences, which is another possibility. All this is very available, very actually conceivable, and it would be one way that you would have an enormous amount of possibilities for three-dimensional reconstructions. So the fabrication sequencing is not too difficult to imagine. The ex vivo or invisible phase will be used by using massive parallel assembly, like PCR technology, for example, but the in vivo phases will be by serial assembly as we reach microscopic and visible dimensions. So the big unknown is the time factor, as it is dependent on the affinity and specificity of the reacting groups. But if we use essentially RNA technology, probably that will be relatively short times because of the high specificity and speed that these reactants function at. So again, just to close the subject, assuming that we get there, we could have progressed from mere mechanical support that we have today and be an arrow way to tissue engineering. That would be the next step. And further on in cell receptor interaction, which I would call this solid state pharmacology, and probably, it could be a replacement of pharma as we know it today. A wild guess is that we will eventually be able to create synthetic organelles like ribosomes, mitochondria, and the Golgi, and who knows, we could also create a fully synthetic cell. All right, thank you very much.
Muchas gracias, Julio. Vamos a continuar entonces con el programa porque estamos retrasados.
All right, we're going to continue because we are so behind. We still have one more talk. It is an honor for me to present Dr. Juan Carlos Parodi. Juan Carlos Parodi is
who introduced the minimally invasive endovascular aneurysm repair of an abdominal aortic aneurysm. And I think that the first was in 1919 in Buenos Aires. And he's a well-known serial innovator, and I think that I wrote that he's a good golfer. So, Dr. Parodi, please, it's your stage.
You want me to speak in Spanish or English?
Up to you. If you will Spanish, English, no problem.
Okay. Yeah, I'm very proud of things I have done in my life. And one of them last year in April gave me a big satisfaction when the American Surgical Association called me telling me that the case 1 million of endovascular treatment of an aneurysm was completed in the world. And that is a long story that started in 1976 when I was a resident at the Cleveland Clinic, vascular surgery. And the Cleveland Clinic was and still is one of the best places in the world. And they were receiving very difficult cases, the complicated cases from all over the world. And what I was learning is that to treat aneurysm was not an easy task. Sometimes you have to do thoracoabdominal incision, abdominal incision, and interrupt the flow. And most of the patients are old patients, and many patients had surgery before. So even at the Cleveland Clinic, the morbidity and mortality was significant. That was in 1976. So you can imagine the evolution of the postoperative care is completely different. But even at that time, the Cleveland Clinic was a very good place. One day we had 2 consecutive patients with bad outcome. And I remember telling Al Humphreys, was the chief, Al, I think we are doing too much to these very fragile patients, and we need to come with something simpler, less aggressive. And at that time, I was learning how to do the Seldinger technique. And I thought perhaps we can build a sheep into a bottle, and we can build a new artery inside the aneurysm. And so that was in 1976. So you can imagine the face of this guy when he paid attention to what I said. And he said, good luck, guy. And in a few days, I was in the research department working with stainless steel metal and elastic stainless steel. And I remember I learned how to weld, and I built what I call a cage. There were 2 rings, elastic rings, of stainless steel welded, and 2 bridges joining those 2 rings. And I covered that with Dacron, and I put that inside the Teflon sheet. And I was working with dogs. At that time, we were not using pigs. And so I did the first experiment in 1976 from the groin, placing this small tube of Teflon in which I put a Fogarty catheter at the end to have a nose cone to be able to penetrate the artery through a small incision in the groin. So I did that experiment, and it was amazing because sometimes you're not lucky and the first experiments are not good. But in my case, the first experiment was really, really exciting because when I opened the abdomen, this cage covered with Dacron was in perfect position. And I thought to myself, if I can take my time and develop this could make a big change in the history of this treatment. A few months afterwards, I was helping an operation for a type B aneurysm. They were resecting the segment and placing an endograft, and that patient ended with paraplegia. And I remember telling Toby Cosgrove, who was then the president of the Cleveland Clinic, Toby, I am working with a small cage covered with Dacron, and I think if we can put this cage inside the aorta and cover the entry site, perhaps we can take care of this problem of dissection. That was in 1976. So as you can imagine, that was not the right time to start with these new ideas. In any event, in 1979, I went back to Argentina, and the idea kept working on me, and I was chasing dogs in the streets and doing experiments in the hospital. And one day, many years afterwards, I had switched the self-expandable system with the balloon expandable system when I saw a presentation of Farmacy in Georgetown University, I remember, in Washington. And so I was mixing one cases with self-expandable, one with balloon expandable. And finally, in September 1990, the president of Argentina called me, and something is open there. He called me telling me that one of his relatives had a big aneurysm and couldn't have surgery. So that was the first case I did in September 1990 under local anesthesia. And I invited Julio Palmas to be present in that case. Fortunately, that patient did very well and lived for 17 years afterwards. And at that time, we were doing just the aortic replacement. Then we learned that the distal neck was very unusually present and very short. So we went to the iliacs. And we started to do many cases, even in Europe, urouniiliac, fem-fem bypasses. And we had patients living for 17, 18 years without any problems. And at that time, other companies in America started with the self-expandable, and they were seeing dilatation and migration. And we compare what happened with the balloon expandable and self-expandable. When you place a self-expandable, the artery keeps growing. And if the artery is big from to start with, let's say 32, 36, the tension is higher and the dilatation takes place more often. So, and with the balloon expandable, it's just the opposite, because when you place the balloon expandable, you load the elastic fibers and the collagen. And what we have seen is decrease in size of the neck instead of increase, because the formation of myointima hyperplasia covering the stent. So the problem then came with the company Johnson & Johnson, who decided not to do the trial. And in addition to that, they didn't give me the patent back, so I was not able to work with any other company. And so I was very discouraged, and I accepted an invitation from Thomas Fogarty, and we developed the Anorex in California together, and other devices with Howard Leonard. And unfortunately, the balloon expandable stent, which is the endograft, which is still very useful. I still use it sometimes, patient without any resources. I do it by myself, and it works. But, you know, unfortunately, J&J decided that this was not for clinical use, and sometimes the history is not very well understood. But in this case, was not because it doesn't work, but the fact is that the company decided to do that. In any event, I traveled from all over the world. I taught the technique with this device and other devices. And today is a treatment of choice. And the Cleveland Clinic, where I started, had a person called Roy Greenberg, who developed branches. And finally, today we can replace from the arch to the groin. And as a matter of fact, one of the world experts is my son, who had training with Roy Greenberg in Cleveland, and he's in Chapel Hill. And he's one of the 5 persons with the largest experience in the world, replacing from the arch to the groin, all the branches, and using endografts. So this was a very successful story with very negative connotations in the middle, because we couldn't do it in the way we wanted. But in any event, for me, it was a big satisfaction to be able to just help to the development of a new treatment that today is a treatment of choice for every patient with dissections, aneurysms, transections. A few months ago, I was in St. Louis, and I met one patient that I treated in 2004. He was 16, and he had a car accident and a transection of the aorta, and I treated him with an endograft, and he was still doing pretty well. So this was a big step forward, and I am very proud of it. And as I said, unfortunately, things didn't come in the way I wanted, but you know, complete happiness doesn't exist. And sometimes when you expect to have something, you are not able to get it. But at least I was promoting a technique that finally took over, and everybody is using it. And very proudly, I can say that that was born and developed in Argentina. And the first idea came when I was a resident, but the rest of the development, until I proved the principle, which was then improved by other devices with branches, and now is widespread. And there are many, many companies making millions and millions of dollars. And one of the companies has they have an airport, they have an airline just to distribute these endographs. And unfortunately, no, not unfortunately, I would say my purpose was not to make money. And I didn't make money with this, just a little bit. But in any event, I'm proud and happy of what I've done. And that's why I want to finish saying that that was a great, great step forward that started from a third world country like Argentina. Thank you.
Muchas gracias, doctor Parodi. Si me lo permite el doctor Becher y Hender, voy a tomar
Thank you, Dr. Parali. I'm going to take over because we are really way past the time. Perhaps, apart from making a direct question, I'd like to give the I'd like to give you a very specific closing. What are we taking home as a message from this excellent innovation session? Sorry. So if you want, Nora, you can take. You can be the first one to say something, and then Omar Santaera. Okay, thank you. I'm gonna speak Spanish. For me, it's easier to make an assessment, not just the questions. The perspectives that are opened are amazing. As a journalist, I wonder what are the time scales that you can expect for these ideas to reach the public? Because, for example, regenerational medicine, we've been for 20 years hearing that we have a gold mine. We're sitting on a gold mine in biology, dominated biology, but it was more difficult to put these ideas into practice than ever. Also, there are so many ethical conundrums that we have to solve before. I think if I have to make a comment, the great advances in technology, with these advances, there is great responsibility that has to do with ethics and the philosophical outlook as to where medicine is going. And how many of all these things that we can do, how much are we actually going to want to do? There will be some aspects, as in telemedicine, digitalization, in which we will have to refrain ourselves in order to keep a human dimension of that art that is the practice of medicine. Thank you, Nora. I don't know, Mari, if you want to. Thank you for everything. What Nora just said is the concern that I have. I just wrote a phrase. How do we associate these technologies that are so modern and cybernetic with the dishumanization of technology? Julio, Juan, I think they all see that. Do not separate the nanotechnology from human beings. How do we prepare ourselves as physicians so that we don't lose that noble association between medicine, conventional medicine, and human health? That's what's most concerning to me. Julio? Would you like to say something, Julio? Julio, your mic is off. Can you hear me? Yes. Sorry. The book of Archer talks about that in a very good way. Empathy between polyp patients. That cannot disappear. The physician will always have a very deep effect in the patient's condition as a patient and as a human being. If we change our tools, instead of using catheters, we use computers in the future, mostly supercomputers, in order to guide and manage systems and control systems to improve health. The important thing is that the physician continues being a physician. We can be in charge of a group of engineers, engineers in genetics, biology, physics and chemistry, but The one that is going to steer the ship is always going to be the physician, because in order to have the universal training and skills and expertise for understanding the patient in his illness or her illness, is just the patient. I don't think we'll ever lose our role. Dr. Granada, I think, as Julio said, one of the things that are the most important ones is to separate the technologies that are partially useful to the ones that can help the patient. Because I think there are many technologies that are nice to have, but there are others, and there are few, that have a deep impact in the patient's health. I think that's where everything starts, because in the clinical practice, in the medical practice, it's all about helping the patient and trying to improve their quality of life, their symptoms, their longevity. I think empathy and the human relation is something that must be linked to that. And I think that the biggest risk is to unhumanize medicine due to control technology and to put more emphasis to patient-based technology. I think that's a risk that we need to avoid, and it comes from the training point of view of the future physicians. Okay, Juan. Alejandro, yes? Can I ask a question for Juan? Right now, in percutaneous aortic implantations, we are in a point of the curve that depends on the country we're in to know which point that actually is. But my question is, when do you think that we will reach, in how many years we will reach the same point, whatever it is in each country, to do mitral valve replacement and bicuspid valve replacement? Well, the mitral part is going to take a long time, I think, because something different as to what happens to the aortic valve is that we had a population of patients, captive patients, that honestly didn't have any other option. Remember that the ACA was with balloon, and so the bar was not that high as the mitral part. There are so many therapies now that can help a patient, in even the micro implantation. So what I think is, as technology advances, for instance, now we have 3 technologies doing transsectal tests in the US. In the next 18 months, 24 months, those studies will be much more mature, and I think that in 4 or 5 years, we're going to have several therapies available to treat patients percutaneously. Now, you talk about the expansion, other countries, that will all depend on the costs, on the regulations, the approvals, but I think that in 5-7 years, we'll have the solid beginnings of mitral percutaneous implantation for all patients.
Doctor Becher, creo que quiere decirnos algo.
Está con el micrófono apagado.
Tenía una pregunta para Julio.
A question for Julio. We know that today and in the future, it is the convergence of basic science and medicine. Why not, having the prosthetic and the biological? What can actually happen from it, the convergence between the prosthetic industry and the regenerative biological industry? I believe that I think that the most revolutionary change will be in the pharmacological industry. Oral drugs, or that will kind of disappear. Without a doubt, today we depend a lot on statins, and that has been a huge change in our area from the prevention point of view, I mean both primary and secondary prevention. I think that with the advance of pharma biologics and to be able to administer them in a periodic way, that will, I would like to see the organoid sequestered cells, engineered device, designed, and without the need of having to periodically give this medication. So from the now I'm on the patient side. I'm 55 and I take some drugs, that have been taken for the past 10 years. So, of course, that has certain implications. To start with, the time that have been subjected to those drugs, either beneficial or not, the cost, and then the amount of drugs that my liver had to metabolize. So, biological therapy with implantable devices to eliminate daily intake of traditional drugs, to me, is a dream from the therapeutical point of view. And I think this will be the next revolution. So, of all the things I see today, biological drugs, I mean, small-size biological drugs, particularly small-size RNDAs, will not only have an incredible impact from the point of view of, immunization, but it'll have other deeper effects, such as, for example, the elimination of the lipoprotein, like the PCSK9. All of those fantastic drugs that are coming out, yeah. 30 seconds. You have 30 seconds. So I never thought I would be sharing such an important session at the beginning of the 20th century. The Academy of Medicine would awarded Curies with the present today. I mean, in August 6, 1945, that very same element destroyed cities such as Hiroshima, and then the 9th Nagasaki. So up to where are we getting at? I mean, I'm convinced that some of you on the panel, as panelists or speakers, you deserve that Nobel Prize, but where are we getting at with these kind of discoveries? This is just a comment and just that. Thank you, Omar. I thank you. I thank all of the doctors for your participation. I'd like to say just a few things very quickly. At the beginning, I kind of thought that medical doctors would be replaced by technologists. Then I realized that wouldn't be so. Innovation would be through, devices, regenerative therapies. These are tools that doctors are using to become more efficient and to provide effective treatments in our daily practice. So we we can actually provide better conditions to our to our patients. And Dr. Proud is when he talked about the philosophical and historical part of it. We all see that innovation is full of obstacles, but perseverance is so important because we can actually get to a place that is beneficial for everyone. With this, we're wrapping up this session. Thank you very much for this session. Again, we'll continue with the program.
Buenas tardes a todos, bienvenidos a esta sesión de presentación oral en enfermedad vascular periférica en SOLACI-CACI.
We'll begin with this oral presentation. My name is Claudio Sigaline. With me today, Ángeles Videla Lynch, Ana Mollón, Alejandro Goldsmith, Brian Donato, and Andrés Dini. So we have pre-recorded sessions, then we have some time for discussions. We have 3-minute discussion time. So let's have a look at the first study presented by Iván Gabilondo from La Plata. Transluminal rotational atherectomy in peripheral artery disease. Good afternoon. My name is Iván Gabilondo. I'm a fellow at La Plata Hospital, and this is a case of transluminal rotational atherectomy. The peripheral artery disease of the lower limbs continues increasing with a high morbidity. Despite revascularization strategies, calcified stenosis in the femoral artery represents a difficult target for endovascular treatment. There is a lot of evidence in favor of percutaneous revascularization. Rotational atherectomy can remove atherosclerotic plaques, which are classified, and optimize the endovascular treatment. This is a 78-year-old patient, male patient, hypertension, and former smoker. He has a history of stroke, and the patient is spavascular in the circumflex artery. He has a DES and also a CPI. He underwent CPI in 2018. Currently, the patient has intermittent in both thighs, and we could say that the patient was under rivaroxaban, DAPT, aspirin and Completo, celestosol, and furosemide and rovastatin. Auxiliary methods: echocardiogram, ejection fraction 54%, lab HB 10%, HDO 29.5%, and a Doppler echography of the lower limbs, severe lesion of the right superficial femoral artery. For this reason, the patient is referred to our center for an angiography of the lower limbs. We performed a radial access with with a pigtail catheter. Then we perform a selective angiography in the left lower limb. There is a severe classified lesion, and in the contralateral limb, there is also a severe lesion in the common femoral artery. So once the diagnosis was performed, we spoke with we got in contact with the physician to define the best treatment for the patient. The patient was under medical treatment. The surgical treatment was advised because this is it was not advised because he's a high surgical risk patient, is a patient that is anticoagulated, and he has aggregation therapies. So we decided to go for atherectomy. So the patient was scheduled. We performed a puncture of the right proximal superficial femoral artery. We used a 6 French introducer. We performed INGLÉS, and we confirmed what we saw in the angiography. And we use the rotational atherectomist Phoenix 2.4 millimeters. A partial angiographic result where we saw residual lesion. After that, we pre-dilated with a Kleber balloon 8x40, and after that, another dilation with excellent results. The patient is followed up. We continue with the left limb with a 7 French, same wire used, a V18. We also performed INGLÉS, and we also used the rotational atherectomist partial angiography. We dilated using an 8x40 balloon, post-dilation, and excellent angiographic result. In the final angiographic control, we saw a good result of the treated lesions, but we used contrast, and the patient did not feel any pain, but the patient had some discomfort, so we decided to perform a control angiography. The left limb, we couldn't see it, so this is why we performed the contralateral angiographic control. We used a graft stent, Advanta V12, excellent angiographic results. Then percutaneous closure with exoseal, and post-procedure patient required globular sediment unit. We did that with a coronary unit because hematocrits decreased, and he would discharge 24 hours later. Conclusions: rotational atherectomy is a useful tool for endovascular treatment, particularly in highly calcified atherosclerotic arterial diseases of lower limbs. Thank you.
Muy bien, Iván. Muy buena presentación, muy interesante el caso. Si quieren...
Thank you. Very interesting case. Who would like to make the first question? Do you suspect the high pressure balloon post dilation or was it the atherectomy? It could have been either. When we performed the traffic control, no leak. But it could have been, due to either reason. The only comment or strategy, using a retrograde rotational, I would rather avoid that because it represents more risk. I mean, if you can avoid it, I would do it at least. And I would have planned probably a stent as a first strategy. The right one, I think a better strategy, and besides the calcium component was quite larger. I mean, larger than the other one. I mean, this is what I would have chosen as strategy. We also considered another access to be able to actually access the two femoral chambers under a grade, but the patient was too tall, and I mean, we had a lot of, I mean, probably we will get with all of the material, so this is why we chose that one. But we had considered it. Embolization did not take place, but we had also taken that into account. As you consider the single access, then you avoid the complication of a second access. You were able to, I mean, each access is a possible complication, and even though the results in these cases, when you do atherectomy debulking, long-term follow-up is good, but this is a very complex territory. So when you read hysterectomy strategies, you end up stenting due to complications, and you have to have the balloons, I mean the right balloons or stents for these kind of femorals, and you need to be prepared for that. So when you don't know exactly where you're gonna add either with a balloon or a stent, so probably in your center you have many resources, but this is not the reality of all centers. It's a territory that is under discussion. I mean, we're making progress because we're having a lot of more interventions. We have a lot of literature backing us up, but it's not, but we need to be careful about that. I heard that this patient was aspirin, clopidogrel, and is that correct? That's correct. I would be more cautious. Is 3 anticoagulants, and then I think it's not really advisable. I'm more conservative in terms of combining anticoagulants. Triple therapy. Another comment is that after considering atherectomy, a DS or a BES, I believe that in the lesion area, it's not necessary to put a mimetic stent. The lesion is at the height of the bifurcation, so there was enough space to put another stent. There are many studies with conventional stents that look fine. Okay, we're going to move on to the second presentation by César Lopardo from Hospital Méndez, Buenos Aires. Retrograde access in the diabetic foot.
Diagnóstico Mediter, Dr. Julio Méndez.
I work in Julio Méndez Hospital. I'm going to present a medical case. Male patient, 65, diabetic, hypertension, dyslipemia, intermittent claudication. He has artery ulcers in the fourth toe. The patient evolves with a claudicant pain. He comes with he has a necrotic fourth toe. He evolves with an infection. The patient evolved with pain while at rest, and he comes due to ischemia, critical ischemia due to diabetes. We plan the amputation of the left foot. We get consulted to see the level of the amputation. We do the diagnosis. So we offer the possibility to try to revascularize before performing the amputation. This is the angiography infrapatellar, palatal, in the peroneal anterior bones, distal view. We see the occlusion in the third proximal and the tibial at distal level with a very thin collateral flow at foot level. We punction at femoral point on the right. We do crossover with the 6 French, and we are able to reach the infrapatella. We advance in the macro wire in a total chronic occlusion, 25 grams. We advance up to the tibial occlusion without succeeding to access to that, more than to that area. So we put a support catheter, 0.035, and a front runner to access this anterior tibial artery without success. After several attempts and not being able to advance towards this occlusion, we try to revascularize the peroneal artery without any success. Therefore, we finish the procedure and we decide to reprogram that intervention with a retrograde technique on the foot. 24 hours later, we do the procedure again. We do the punction with an echographic wire. We place a micropunction set, and we put a wire rope but through the foot artery, reaching the anterior artery, and we advance 0.14, and we advance and introduce through a vertebral catheter that we descended through the femoral artery, and that leads us to reach from the PDA to the femoral artery and to access in the femoral artery through the femoral axis on the right. We pass a balloon, a small balloon, a coronary balloon, 2.0215, because we weren't able to do it with any other type of balloon. We were able to open that sector that was giving me some resistance. After that, we do an angioplastic in a successive way in the peripheral part, 0.018, 2.25, and we ended with T0220 we are able to revascularize the anterior artery. After we open the tibial anterior artery, we do digital compression in the artery with a good distal flow. After 24 hours, the patient comes back with an ischemic pain, no pulse in the artery. So we decide to do a new intervention since we suspect that this lesion that was so difficult to treat in the angiography, we observe subocclusive lesion in the PDM, in the pituitary, and in the distal one, severe occlusion, and we reach a good diameter. Once we finish the angioplastic with DES 1.080, there was more resistance and more disease in the tibial artery, anterior tibial artery. This is the final result of the angioplastic, good flow, and we see an adequate plantar arc in the left foot. This is the initial angiography of the patient. And look at the one on the right. He evolves very favorably. He has antibiotics. We amputate the fourth for healing after only 4 weeks. No pains. And to finish, this is the first picture of the patient. We see the necrotic condition with baseline compromise due to infection. And this is the follow-up after 10 months. And this is the follow-up after 22 months. We can see the scar that is pretty correct. He wears shoes. He walks normally. And the mycosis improved very well, and he's asymptomatic since the intervention. And we did not do any other invasive tests. Thank you very much. All right, Cesar, congratulations. Thank you very much. Opening the case to discussions. Any questions, anybody? What do you think, Aníbal? Anita, sorry. Good case, well resolved. Did you do anterograde or lateral access the second time? Anterograde. Yeah, for me, it gives you a better, it's easier to manipulate the material. You wouldn't have had issues to reach the foot, but I think even it can impact on the success that you have in the crossover. So that strategy is really good. Yes, I didn't realize that I didn't show very well. In the second opportunity, the first attempt was always anterograde, and then we went to the peria the second day. But yes, we always tried first anterograde, and even with good support, we weren't able to access. I thought that the first one we did crossover. Yes, first crossover, and then the next day we tried anterograde, and then we went to the pedia, but with the right materials. Anyways, the distal access facilitates the everything, and it increases the success rates. And once in the second chance, when you had already opened the pathways, then it was easier. Sure. The key for me was the one in which you reach with the distal access. Congratulations. Really good, Cesar. What I wanted to highlight in the presentation that you did was the use of more than one projection in the infrapatella region, because it's very common that in the diagnosis procedures, sometimes they sweep and there is a lot of overlapping of the vessels, and when there is occlusion and a lot of collateral flow, we cannot distinguish it very well. So I think the strategy, the diagnostic strategy, was really good to use two projections. We can also do digital subtraction to visualize things in more detail, you know. And I also wanted to ask you a question because I know that you have a lot of available technology. In this case, did you consider the possibility to use rotablator, thinking about the extensive calcification, and that led us to use a low-profile coronary balloon? In fact, in that moment, we didn't have that into account because this was about 2 years ago, and I know that some of these devices appeared lately, so we really didn't take that into account. Nowadays, we would have more possibilities and more tools to choose, or at least to think about. But this is going to be, it's going to be 2 years since we did that, and it's what we had at the time and available at the time. But at the time, we didn't think about it. I have a question, Cesar, for you. The first anterograde approach, I think you tried to advance in an endoluminal way with a 0.35. Did you try subintimal with the support of microcatheters, 0.14, 0.12? In the retrograde. We tried with a 0.14, 25 grams, total occlusion in the periphery, and we couldn't advance. I don't know if I put it in the presentation, but we also tried with a common wire, and we couldn't pass it. And then last attempt was a 0.35, last attempt to see if I was able to push anything, and I couldn't. In general, we use infrapatellar 0.35. We don't usually use it, that's right. Maybe a more rigid, like Rubicon, for trying to advance a little bit more. There we did with the Cook catheter that gives us very good support. And I think we went with the best thing we could. But we came from a crossover that was not the best. But if it had been like Dr. Moyano, maybe things would have changed. But then we tried the next day and we couldn't either. All right. Let's go now to the next presentation. Congratulations, Cesar. Now we're going to hear from Alejandro Iorio from the Spanish and Italian Hospital from Bahía Blanca. He's going to talk about endovascular treatment of revascularization of femoral popliteus bypass with non-annulus prosthesis in a claudicant patient.
It is an honor for me to be part of this scientific session, SOLACI-CACI. So I'm very grateful for having this opportunity to share our experience on peripheral disease. I'd like to thank the organization for this opportunity. The case is revascularization and vascular treatment. My name is Alejandro Álvarez Iorio. This procedure was performed in Bahía Blanca Hospital. This is a 59-year-old male patient with multiple cardiovascular risks. In 2015, the patient begins with intermittent pain in the lower left limb. We determined that there is a partially occluded artery, so he was revascularized in 2016 with a bypass. The patient evolved positively until free of symptoms until 2019, when he begins again with intermittent symptoms, 100 millimeters, observing an occlusion of that prosthesis. So A new revascularization is scheduled with a second bypass with a ringed prosthesis. But after a week of discharge, when the patient begins to walk again, he feels again pain. So something happened with this second bypass. In 2020, he comes back and we perform an angiography, and an occlusion of the superficial femoral artery was identified, but he's ruled out for a new bypass procedure. So we performed a multi-slice CT scan in order to actually plan a proper therapeutical procedure. The native femoral artery, here we can see on this image, this is a 3D volumetric image. We developed this with our software software engineers. So the prosthesis is occluded, but these are static images where we can see that the bypass is totally occluded, but we don't see a bypass technical defect. If we look at the proximal level, the cap of the femoral is a favorable cap with an occluded bypass, but there's no technical problem. And this is the distal anastomosis with so we see the prosthesis is occluded with no technical alterations of that proximal distal. And these are the dynamic images. And we don't see torsions or collapses. So the prosthesis is okay. After that, we performed a 3D image, and these are the dynamic images. This is the prosthesis and next to the femoral, but in the joint over here, there's a radiolucency. So we see that there is an occlusion. I mean, there's a technical problem, either a twist or collapse. And in this beautiful image, dynamic image, that below that, the prosthesis, there's a twist, which actually explains what was happening with the prosthesis. So here, these are the two technical alterations of the bypass, particularly the distal twist. And we can also see it here in the dynamic images, this radiolucency, and these are the pictures from different angles of the bypass that shows exactly why it failed. And a week after the patient was discharged, the patient felt symptoms or discomfort. So the proximal femoral artery, we have the prosthesis with two technical artifacts, particularly that twist, and we selected the revascularization prosthesis with over 4 years of occlusion. So we decided to develop a contralateral access strategy and use a 9 French deflectable, and with the image convergence technology. And this was prior to the the technology that we're using now. So this is the 9-French defectable and a wire for the crossover technique. Once we approach the common or the regular femoral vein, we sized the artery, we converged images in yellow and the line that would take us to the processes. So via the 9-French JIT, a microcatheter plus a 12 gram 014 wire, we were able to bypass and we got into the processes. Here we can see that the catheter migrated distally, and then we performed this angiography so as to see where we have to re-entry via the collaterals. We began to work on the cap that was not favorable, and finally we were able to cross the cap. This distal anastomosis we checked with contrast. Then we moved forward with the microcatheter and we performed angiography to observe the vessels. Via roadmap, we placed a 0.18 wire, long wire, and after that we removed the microcatheter in order to begin with the atherothrombectomy with an 8-French Rotorect device. It's a very useful device for thromborectomies to remove all of the thrombus and fibrotic components from the bypass. We cleaned everything out. We always leave a sort of distal edge, and once we checked bypass patency, we go to the distal edge with a slow, gradual anterograde motion. Then we perform an angiography and would see that this is the lesion, and then we dilated. We used a balloon to dilate, and the fibrotic lesion in the proximal area, and then distally this lesion that could explain the bypass failure. We placed a dedicated stent, and proximally after dilating due to the coil of this fibrotic lesion at the level of the anastomosis, we placed a coated balloon, and then we see the resistance of the plaque, even though we were able to achieve very good results, and we see a slight overexpansion, but with very good results. This is the final angiograph, and we assessed the irrigation with this angiograph, so we can see proper perfusion and irrigation, and this patient evolved perfectly up to date. Again, thank you for letting me share our initial experience in bypass revascularization with this case. Thank you to the organization for the invitation. Thank you, Alejandro. Very nice case, very well presented. Would anyone like to begin with comments or questions? I have 3 questions for Alejandro. First, as Claudio said, wonderful case, very well approached, very interesting. But I have 3 questions, straightforward questions. First, why didn't you use the native vein for revascularization? And then, even though the surgeon, you said, ruled that out, but have you planned performing a bypass? And then finally, why a coated stent? Why did you choose a coated stent at the level of the bifurcation? Thank you, Alejandro. Great questions. This was the initial experience. We're now, we have 14 cases. And as regards to the natives and bypasses, because cardiologists from Bahia became very interested in this. And the surgeon is a friend of ours, so the second bypass, which is the ring prosthesis, they had some technical problems, and it was so the procedure was very complex, so we analyzed it, we reconstructed the native, and we had issues seeing the distal portion. So this is why we the surgeon proposed a third bypass regardless of short or long, but the patient said he didn't want to go through any other procedure, and the surgeon was not convinced either after failing twice. But this was a choice. It was a valid choice. But then the patient didn't want to, and the surgeon was not so convinced about it. So we removed a lot of material. It's really too bad we didn't take pictures. But we had this fibrotic lesion and the balloon, so we could have used any kind of stent, but we do a lot of peripheral IVs. It was just this feeling we would try with it because there was a lot of recall, fibrotic lesion, and just in case there is a thrombotic risk. So we considered a coated and self-expandable. I selected coated. In this particular case, how do you see these patients? Thinking about, would you have left it for a longer period of time? This patient, the patient had atrial fibrillation, so the hematologist was giving him, and then we were giving a rivaroxaban and clopidogrel, and we changed single therapy to aspirin. I have a question. How long had the bypass been occluded? 4 years. So it was quite risky. We've had 5 cases so far.
En Rotarex nos mostraban, por ejemplo, la gran utilidad que yo no me la imaginaba en restenosis intraestática.
So a tissue like in the intestinal restenosis. And now that we have began with the, I mean, 6 months ago, we've had 5 cases so far with deep restenosis and 2 acute and 3 chronic. Uh, that is because it's not recommended. I mean, 4 years. I think the criteria is good, though, because it's one more alternative, but one more option. But the thing is that it's beyond the limits. 4 years is like a lot of time. Since they said they were using for occluded bypass, I checked that and I said okay. And as you say, in veins after day 14, 20, and I realized they use it after 30 days. You go beyond the borders. These are very useful devices, but you need to be very careful, and there's always a risk. Rotoresque, I mean, has very large windows, but then you have the higher risk of, a distal embolism. When we when we were trained in my past in acute occlusion, you can do it through flushing with the flow or without flow, but you should always leave this distal edge. So if there's a lot of, you need to clear out everything. And the distal edge is also risky because you have to do it very gradually, non-stop, and being very, very cautious, very slowly. That's a key. Exactly.
Gracias, Ana.
Una última pregunta, Alejandro. Estos 14
Question. We know that bypasses break more than native veins. Did you have any perforations in these 14 cases? No. We only used them in 4 cases. When I speak with the surgeon, this is a prosthesis bypass. Your question is very good. I would be very cautious. I mean, if it were a venous bypass, because if it's counterindicated in thrombotics, I wouldn't use Asperex. I mean, for the veins, it's Asperex that damaged the vein wall because the vein aspirates and collapses and you can damage it. So if it's a venous bypass, I don't have experience. I can't say anything about that. And with prostheses, I mean, it's a little bit more relaxed. Let's continue with the same case, Alejandro. Tomás Cunio from Plaza Hospital Rosario. He will be presenting subclavian sequestration, coronary disease.
Thanks, SOLACI-CACI, for allowing us of this clinical case developed in the Plaza Hospital in Rosario by doctors Marcelo Méndez, Alejandro Lescano, and myself. I'm Tomás Cunio. The clinical case is called coronary subclavian coronary and carotid disease. She is hypertense, 64 years old, smoker, cardiovascular background. She had a carotid disease, asymptomatic, and she had bypass in the vein bridge in the right coronary. That was a recent bypass. It was moderate the patient comes to our institution with an angina episode. We do an echo Doppler with a systolic, moderate systolic depressed, and distal apical and septal severe hypokinesia, moderate mitral, but clear segmented. We do an EKG with compromise of the ostium in the LDA and the circumflex, severe lesion in the right artery, and when we do the shot that we are going to see now, we find a retrograde flow to the subclavian, left subclavian. The vein bridge in the right coronary was completely occluded, and we can see the stenosis from through the subclavian, left subclavian. We see the stenosis, the mammographic artery. We checked also, you can see in the pictures, severe lesion calcified of the common carotid. We see the picture on the left, and also an obstruction, a severe obstruction, calcified obstruction of the carotid, internal left carotid artery. The upper one is occluded, and the ones on the right, they are preserved. As we can see in the audiogram, we check the cephalic neck is okay, the severe lesion, calcified lesion, and the occlusion of the artery, the subclavian artery. On the right, the left internal carotid. The evolution, we dosed the coronary, subclavian coronary stenosis, and we decided to do an angioplastic with a stent to the occlusion of the left subclavian artery. We did a femoral access. We did a stent graft, balloon, expansible, and radial left with instructor 7 French. We advanced to the catheter, with the catheter to the occlusion level, and we were able to sort the occlusion with wire, and we dilated with balloons up to being able to implant at the origin of the left subclavian distal stent 9 V12 9/38. The area was very calcified, so that's why we decided to use this type of stent. We can see the pictures how this progressed in the angioplasty, initially with occlusion, then with the wires, it dilates until we have a free stent, the released stent, and the control through the shot. Before discharging her, we did another EKG, and we see that there is no more retrograde towards the subclavian. That's what we can see here. In the past, it was stenosis towards the mammarian artery, and the patient left on the 5th day. 6 months later, the patient comes saying that she has a weak arm and stenosis in the carotid, and it becomes, from being asymptomatic, it became symptomatic, and we decided to do an angioplasty on that same artery. So this was done through a femoral access, and under protection of spider, we tried at the carotid, internal left carotid, a self-expandable stent, 7/30 wall stent, 7/30 millimeters, and at the common carotid, we implanted post-dilation sheathed stent, V12 8/38. That's the progression of the stent once it is expanded with a contrast shot, and then the predilation of the left side. The last one on the right is an orthography shot orthographic shot, and we see the carotid on the left, and the way it looks pretty well. The stent expanded, and we can see the subclavian, left subclavian that we had done before. That's the final shot. And in the follow-up after 12 months, the patient was asymptomatic. We did a SPECT with minimum infraposterior ischemia. And in the ECG, in the Doppler ECG, she improved the systolic rhythm. And as a conclusion, this subclavian coronary stenosis is due to a severe occlusion of the stenosis of the subclavian artery. It is very important to do a correct preoperative assessment for patients that will have a bypass. Be aware of claudication symptoms, asymmetry in the branchial pulses, and pressure on both arms. The signs and symptoms that are classical to this are angina related to the activity in upper homolateral extremities, vertebral baseline insufficiencies. Be aware if there is a difference in both arms, cold lateral side of the arm. Last but not least, to say that the bypass, the subclavian stenosis was a typical treatment with mortality of 5% and morbidity of up to 25%. And well, these past years, the transluminal angioplasty percutaneous with stent has become a therapeutic alternative that is reasonable with the similar success rates, lower complications rate, and of course, hospitalization that is shorter than usual. Thank you so much for your invitation, and I hope that this was interesting for you. Thank you, Tomás. Excellent case, excellent presentation, very interesting. So let's open discussions for this case. Thank you, Claudia. I think of all of that, the most important messages to take home is the need to do a preoperative assessment for those that are going to have myocardial intervention. It's not very common to explore the subclavian territory, and we see that every day. I never saw, honestly, I loved the picture, I never saw a stenosis, subclavian coronary stenosis like the one you showed, but I've seen many patients with ischemia in the anterior subclavian, and many times it was there before the surgery. Yeah, that's what happened to us, because when she was admitted after the cardiac surgery was 8 months after surgery. So of course it was significant, the stenosis was significant, and nobody detected it. And what about the previous surgery, CRM? Sometimes we see a lot of mammograms of subclavian arteries in patients that were radiated before, and then they get surgery, and then their mammarian arteries are not useful. We have to check what they look like. Not in this case. She had an important, and her social context was pretty difficult. So she had never been submitted to radiation, at least not that she could say. And the other question for you and for everybody, if the stents for both Ortiz Ostian is mandatory here, or if you prefer to use stents in sheathed stents, or if there is a place for naked stents in these cases. Go ahead. In this case, Claudio, we decided to use sheathed stents because we thought that they were severely calcified lesions with high dissection risk, and we wanted to make sure that even though they're more expensive, we made sure that we can have a better stent expansion. We have previously used, especially in the iliac aortic artery, that they have radial positioning and they don't move. And Dr. Menendez and the whole team, it gives us certainty. They feel more secure by working with those type of stents in these type of lesions. Tomás, I think it was really good, very educational. I wanted to ask you two things. One, if you considered the angiotomography to assess the anatomy of the case for planning mostly, since it's a territory that is pretty difficult to evaluate just with an angiography. And the second question is, since these occlusions are in general very fibrous and calcified, what type of string you used in the approach, wire you used for occlusion? Well, with regards to the angiotomography, CT, we didn't think about it with the patient. We did initially the CTA, and in the images we accessed and we saw that stenosis, and we went to do a neck vessel shot, and we checked the occlusion, and we only saw the hemodynamic images. And the type of wires, well, of course, as in many places, we don't have many wires. We had to exchange several types of wires. And whether you don't believe it, we have on one FXT, the last tip, the last part of the lesion, we had a pigtail in the aortic, and to orient ourselves, because it's a long trajectory, but then we started to predilate with coronary balloon 1.2 up to reaching a better diameter, and then being able to think about placing the stent. But we worked with the material that we had at the time. Thank you. We understand what you have at hand. And that's why I ask you what you had used, because these are common situations to most realities of the services that we have. Thank you so much. Okay, so now we'll go to the next presentation in charge of Dr. Santiago Federico Coreleu. He's going to talk about the Argentine Registry of Angioplasty of Lower Limbs, sub-analysis in patients with critical ischemia.
My name is Santiago Coreleu. I'm an interventional cardiologist, and I will share the results of the sub-analysis of patients with critical ischemia of lower limbs. This is the Radami registry, which is organized by the Hemodynamics Association of Argentina. So I would like to thank the SOLACI-CACI for the invitation. Some background: Radami is an Argentine federal registry performed in 52 centers across Argentina. We've been recruiting for 24 months in order to analyze the reality of lower limb angioplasty in the country. 142 patients enrolled between 2017 and 2018, sponsored by the Argentine Society of Cardiology and SOLACI, and we analyzed lower limb territories mainly. Why did we think about developing this registry? Because we all know that This is a disease that is on the rise with a lot of incidence in risk factors in the population, that the prevalence of peripheral disease has become important in our routine practice. And we know that there is variety in terms of the types of treatments based on patients and treatment types. And there is still no defined standards, and there's a lot of evolution, technological revolution, and the industry, and also to try to conduct these kind of research studies, because there are not many. The objectives of this sub-analysis to identify clinical and angiographic characteristics of patients with critical ischemia of lower limbs within Rhodami registry, and to assess endovascular results. Since January 2017, December 18, 1,042 patients were enrolled, patients treated with angioplasty of lower limbs. 624 patients, 59%, presented with critical ischemia based on Rutherford classification. Population baseline characteristics: mean age 60, 6 years old, 68 were men. Out of those 600 patients, 83% had hypertension. Smokers and past smokers, 83%, 58%, and 20% with chronic kidney renal failure. And as regards clinical characteristics, patients having previous bypass, 5%, previous CPI, 12%, coronary disease, 24%, and 5% stroke, and 2% previous amputation. This is the Rutherford classification, Rutherford 4, 5, and 6. 40% of the patients were Rutherford 6, that is, were patients with critical ischemic patients. 4 and 5, we have about 60%. Medical treatments prior to CPI: 86% took aspirin, 96 clopidogrel associated to DAPT. Half of the patient received xylostazol, 66 statins, and 32% antibiotics. Most treated territories: iliac very low, femoropopliteal 29, femoropopliteal and infrapatellar 19. This is a comparison between critical ischemia, and we see that treatment time, patients with critical ischemia are treated very fast. I mean, there is a large number of patients, that is 60% of them are treated between a month and over 6 months. We should expect that all the patients should be treated here, I mean, in this period of time. So it's a little slow. Another slide to compare. These are lesions by affected territories. In the critical ischemia, we find that there is a decrease of iliac, there's a decrease, and there's an increase in infrapatellar angioplasty. So these are lesions treated by territory. 52 90% of the cases were treated in more than one territory. And the infrapatellar region is the most important one as regards treatment strategy. These are stents, balloons, DS, and BS. Most of them were treated with DS, and the iliac mainly treated by stent. And in this case, it's a combination. As regards accesses, most of them, 70%, were anterograde, 22% contralateral, very small percentage distal retrograde. That increases over time. Angiographic success, 92%. There was a change in strategy in 8% of the patients. Inter-hospital death, 1.2%. Peri-procedure complications, 5.3%. And amputation. To summarize, mortality, inter-hospital mortality, 1.2%, up to 6 months, and 3.0%, and 12 months, 3.7%. Regarding amputation survival, inter-hospital, 96%. Conclusions. In agreement with literature, patients with critical ischemia in our registry present multiple cardiovascular risk factors and are in the most advanced stages of the disease. Endovascular treatment in this subgroup of patients in our registry showed a high rate of success, intra-procedure, low rate of complications, and an important capacity for bailout. In our country, the number of centers with multidisciplinary teams to treat critical ischemia in lower limbs is low. The treatment of infrapatellar occlusions and foot arteries was not very frequent, and the information analyzed is good to actually assess the current situation in our context. Thank you. Thank you, Santiago. Very nice presentation. Very interesting data. I remember, how we started in this session. One of the issues considered in the first case about this patient that was meant for amputation after the angiography, you will be able to resolve. So how education can actually, solve things. So you see the importance of these registers. Almost 60% of the patients receive statins, so this should be higher. On the other hand, the lesions that were bailed out were in non-infrapatellar regions, and this is the most affected region. And the number of CPIs in these territories was low. So what could we say about this? I mean, we are on the way to actually, this is where we have to focus on, not only on interventionalists, but the referring, the referral clinicians. So congratulations, because this data is excellent. Really, I mean, it has a lot to look to. We could learn a lot from it. When we talked about the medical treatment, I think it's biased because this is peri-PCI, but so I mean, these are the patients we get, and the other thing is that infrapatellar, a lot of stenosis were treated, but you did not treat any occlusions. I believe that you need more thorough treatment in these kind of patients. in many patients that were not amputated, but the ulcers did not resolve. I mean, their ulcers extend through their lives. They're not amputated, but I think that data should be included and analyzed. Even though they were not amputated, but they remain in that stage throughout their lives. Very interesting, Ana. I believe that we are working a lot in terms of perfecting the technique and how these patients should be treated. However, when I see the registries, the percentage of patients treated prior to the intervention is quite the same, and I need to work harder on that.
Cosa digo yo, Claudio, segundo.
I believe the other thing, we're improving a lot in terms of the techniques and the multidisciplinary team. We don't have many of those teams in our centers. Yeah, they're not amputated, but they continue with their lesions. I think that is actually the thing to look at. We don't have this sort of comprehensive follow-up. Any other comments on the registry? I have a question. Did you notice any difference between genders in this amputation rate? It was not on the presentation, but and the possibility of bilateral procedures. Great question. The amputation, I mean, the gender data, I don't have that. We are three. Ana, Andres, I don't have that data, but I don't know. No differences as regards gender and as regards a diagnosis comparing disease was quite similar, particularly critic ischemia. But they were symptomatic, but not all of them had bleeding. Particularly in critical ischemia, there are some differences. This study, and I'm involved because we've been involved since the original design, but participation in support of so many centers, 600 patients with critical ischemia. It's a lot of patients, and it's the only registry, multi-center national registry, and I think that it provides us with a good deal of data. And even though there's a lot to be done and we need to treat more occlusions and more, we need to perform more distal approaches, I think that we're on the way. And this registry started in 2017 and now 2021, and the presentations have gone into occlusions. I think we're on the right track. I mean, registries are not always on time, So if you look at the progression, what we were doing 4 years ago and what is being done now, we have learned a great deal. Of course, we need to continue moving forward, but I think that we're doing fine. I mean, we are on the right track. I agree with you, Andres. I think the optimal medical treatment, I think, is sort of weak, but I agree. Okay, so we're right on time, so we need to wrap up. Thank you. I'd like to thank all the participants. Wonderful cases. I think we all enjoyed these presentations. Thank you to the panel of experts, Andres, Donato, Alejandro, Ana, Angeles. Let's continue because there is a new session coming up on research. It's a research session, and at 7:45 there is the Microport Symposium, and at 8:45 p.m. is the closing ceremony. So thank you. Let's continue developing science.
Good afternoon, everybody. First of all, I'd like to thank the opportunity, the invitation. For us, it's a very important meeting because about a year ago, we started with this department inside SOLACI with the objective, the common objective of many people in Latin America to do research and to publish papers, and for sure, that's very important for all of us. And that this session, we will have a couple of discussions and presentations that are mostly going to deal with the 4 registries that have been developed with the SOLACI research. And for us, it's very important. All the support that we get by Dr. Mangione, all the restless work that Pablo makes, Aníbal now, anyway, everybody, and many important people that help us a lot to advance. So first of all, we'll talk about of the peripheral with Marcelo and Luis, and then we'll talk about the tavern and the pulmonary, that they're in pilot phase. And apart from that, we have been able to develop multiple activities, educational activities related to research, and that have combined and published with some clinical guidelines for TAVR with the contributions of SIAC and other society associations that Carla is going to present. So based on the time that we have, I'd like to thank you and give the floor to Pablo, who is going to start with the sessions. Thank you, Enrique. And I wanted to introduce to all those here, first of all, the panelists, and then each one of the speakers once they are allocated in their topics. Alexander Abisaid, former SOLACI president and an icon in Latin American research. We also have Omar Santaera, interventional cardiologist, chief of the service of Las Lomas in San Isidro, a friend of ours and former president of CACI as well, Aníbal Damonte, also from Argentina, interventional cardiologist, chief of hemodynamic and at HIR, current SOLACI president, former president of CACI too. Congratulations. We have Gustavo Viñolo, interventional cardiologist from the American Institute in Montevideo, Uruguay, and now director of Jornadas SOLACI. We also have Lucio Padilla, who is not only the PI for the BIF trial, Latin BIF trial registry, but he's also the chief of interventional cardiologists in Buenos Aires, expert in CTO and angioplasty. And we also have the panelist Jose Mangione from Brazil, that you all know, director of the Interventional Cardiologist Hospital Beneficencia in Sao Paulo, professor in Sao Paulo University, former president of the Interventionist Cardiologist, and unfortunately former president in SOLACI. It was an honor to work with Jose in these projects, and I wish you all the best in the future.
Professor of cardiology and consultant cardiologist at Chile University, and he is a great man. He's a very very kind with all the initiatives that comes to around him, and he's also very has a large expertise in clinical research. He publishes many articles per year describing the reality of interventional cardiology in the UK. So it's an honor to have you, Professor Mamas, and all the panelists together. Ahora estamos listos.
So now we are ready to start with the session. We'll give the floor to Marcelo Abud, the coordinator of the Latin BIF registry and cardiologist in Santa Fe. And he recorded his talk. He's not going to be able to connect, but Dr. Lucio Padillo, he will be as a PI to answer questions as well. Thank you. Let's roll the tape.
My name is Marcelo Abud. I'm the coordinator of Latin BIF. Thank you very much for the invitation to participate in such an important session to discuss our initial experience with this registry. The origin of this project has to do with SOLACI Latin BIF initiative. SOLACI Latin BIF is a group of interventional cardiologists that got together in order to develop, to work towards continuing medical education, research, and scientific exchange in the field of coronary bifurcation lesions. This group from SOLACI has many activities, many different projects, and we can see they're all oriented to education and scientific exchange. Latin BIF registry is one of them, and I will focus on this. But I will also like to open up the invitation for those of you who would like to participate in this initiative, Latin BIF. So the Latin America Registry of Percutaneous Coronary Bifurcations, when we were developing the registry together with the SOLACI research team, we consider the following objectives: that our registry could respond to some questions that we understand are important for the region. First, to understand the status, the current status of bifurcations in Latin America, to be aware of the results, and based on this information to identify our needs, and from the bifurcation club to create improvement strategies, and of course to generate collaborative publications in journals and congresses, either locally or internationally. The registry began recruiting patients in November 15th. We have now 21 participating centers across Latin America, which are the ones you can see here, from 6 countries: Argentina, Colombia, Mexico, Ecuador, Venezuela, and Peru. Up until now, we have over 45 centers that are about to become members of Latin BIF registry. They go through, a set of administrative process. So in the next few minutes, I'd like to show the initial results that the registry has. The purpose of this presentation is to break down the results, that is, in terms of what patients we're treating, the characteristics of the lesions we treat, and how we approach them. As regards the first question, then, what patients we're treating, we now have 432 registered. Mean age is 60 years old. Most of them are male. And the prevalence of risk factors, you can see this on the table: 82, hypertension, almost 80%, dyslipidemic, and 20% of patients with diabetes, a little lower than what is recorded in other international registries. And as regards ventricular function, around 20% have some degree of deterioration of this function. Clinical presentations at the entry point, most of the patients are 60% of them will have stable angina or unstable angina, and most of them are in functional class 2. And as regards DAPTs, 70.6% of our patients receive clopidogrel and 22% ticagrelor and 7.7% prasugrel. As regards procedure characteristics regarding the approach and techniques, around 80% of the cases where our accessed or the approach is radial, 2.7% radial distal approach, and 20.1% femoral approach. Regarding French, 5 and 6 and 7 French, and the prevalence of multi-vessel disease is 39% of the cases. As regards the location of the bifurcation lesions treated, the biggest territory is LAD, 56%, and then left main, 17%. As we break each territory down, then the left main distal 96% and 4% left lesions ostium, with involvement in the ostium. And then the LAD, we could see that 80% account for the proximal segment, that is involving the bifurcation with the first diagonal branch. And an important piece of information from our database is the number of diagonal branches about this lesion, because one of our the projects would be able to prove this concept that was created from the experimental works from the Korean group on the dominance of diagonal branches. 21% of the patients having 2 diagonal branches have reported that one of them was dominant, and the idea is to clinical prove if this has an impact or not. And as regards Simperflex territory, 81% also involves the proximal territory with the first marginal branch. As regards some lesion characteristics, we could see that based on Medina's classification, around 80% of the cases presented true bifurcations. And as regards the most descriptive characteristics of the lesion, the main vessel, the percentage of stenosis is 77%, and the length of the lesion is greater than 21 millimeters. And as regards to the side branch, then stenosis percentage is 50%, lesion length 10 millimeters, which is relatively, I mean, it's important regarding the technique and the results of the technique. And the SB length, that is the extension of the side branch, is greater or equal to 73 millimeters in 88% of the cases. Another concept that experimental models proved to be relevant in our registry allows us to clinically test it. How do we approach lesions in the region based on what is reported in the registry? Well, 90% of the cases, the side branch is wired for the treatment, and the preparation of the plaque preparation in the main vessel is in 91%, is carried out in 91% of the cases. We use semi-compliant balloons, non-compliant balloons, 61%, and rotational atherectomy in 3%. We haven't reported any cases on scoring balloon. And as regards the side branch, plaque preparation, another concept that is under discussion or controversial, which with provisional stenting, 47% of the cases when we analyze the registry globally, that is when we analyze treated lesions, target lesions with provisional stents, then the plaque preparation rate is 32%. As regards initial strategy, we could see that 73% of the cases initially were attempted via provisional stenting, and 88% could actually complete this based on the initial strategy, that is just a single stent. And as we analyze the provisional stent based on the current concepts and that have proved to be absolutely relevant to develop a good technique, we'd see that final pod occurs in 73.5% of the cases. In 12% of the cases, approximately, of patients that a provisional stent was attempted initially, finally an additional stent was implanted in the side branch. The reasons why this happened, we can see 65% of the cases due to a displacement of the carina, 40% dissection, significant dissection of the side branch, 6% occlusion of the SB, and 70% of residual restenosis. The technique that was used was TAP, to address this situation. When we selected the initial technique, the two-stent technique, this occurred in 77% of the cases, 27% of the cases, and the most important techniques were TAP and DK crush. Finally, the use of intracoronary imaging, IVUS, 9% of the cases, OCT in 1.7%, and FFR in 1.7%. However, this was in the global registry, but when we look at the left main, then IVUS 42% of the cases, OCT 4.1%. Regarding in-hospital events, we observed a relatively low rate compared with other registries, 1.1% death, 2.2% intrastent stenosis, that in both cases required emergency revascularization. To summarize, in our registry, this is a prospective registry that is open to the participation of all LATAM centers that are willing to take part. And the purpose of this registry is to provide us with relevant information to identify the current status of bifurcation PCI in Latin America. We will be able to clinically validate some new concepts, as we said before during the presentation, the SB, the clinical importance of SB lens greater than 73 millimeters, the clinical significance of diagonal dominance, and the classification for the left main is the ABCD classification. Finally, we would like this registry to be one of the most important means to work collaboratively with leading Latin American centers, together with societies, leading societies in these important topics worldwide. If you want to participate, please send an email to this email address, latambiv@gmail.com, and you'll be asked to submit all of this information, social media, in case you have any questions or comments. Thank you very much for the invitation again. Greetings to everyone. Thank you, Marcelo. Thank you for your effort, together with Lucio, Monica Bus, to come up with the preliminary results of LATAMBIV. If there are no questions,
Sorry, Jose, go ahead.
just a comment about it. Congratulations to all of the participants, Marcelo, the whole group, LATAMBIV, Pablo, for such an excellent job you did with this registry. And this is the first registry that is being carried out with the support of SOLACI. Very important registry that it has a very promising future, because there are 45 centers that are interested in participating in LATAMBIV. So this can become a large registry and very important for the whole Latin region. Lucio talked about the little use of imaging, but the results are very good when we see the register results. So probably if you could say something about that. We are aware of the limitations in Latin America, but the results of the registry are very good in terms of the success rate, complications. So if Lucio can say a few words about that. Thank you, everyone. The low rate of use of IVUS is a reality in Latin America, and this is basically related to financial issues. I mean, it's not the fact that we don't want to use it. 9%, and the left main is 42, 46%. And the results are initial results. We'll see what happens in the long term, and which is the PVR and PLR thrombosis stent. But I think that the objective is that 100% of the cases we would like to use IVUS, because it significantly changes not only the final treatment but also treatment planning. To make something, I would like to ask Dr. Mamas what he, in real life, not in the registries of large centers that use, but in real life, I don't think that it's 100% either in real life.
Dr. Mamas, can you tell us if you hear me?
Is the percentage of use of intravascular ultrasound or OCT in left main treatment, please?
Okay, so we published a paper from the UK recently looking at close to 10,000 left main PCIs. And in the latest extracts, it's about 50%, which is quite high for the UK. But if you look at other registries, so for example, the e-Ultimaster registry, it's very interesting. It's no different from the data that you're presenting. So even in the e-Ultimaster registry, where the majority of recruitment is from Europe, overall in bifurcations, it's around 10%. And I think, as you quite rightly say, this reflects the real world. I think it's very challenging when left main OCT or IVUS costs significantly in many healthcare systems. Centres don't get paid for using these technologies, even though we know that they're associated with better outcomes.
Thank you, Mamas, for your answer. And maybe yo tengo para Lucio también. Lucio, ¿quieres?
I have a question for Lucio. Lucio, would you like to talk about the TAP technique? Half of the two-stent strategies were TAP and 80% without. So what's your view? What's your opinion as an expert? What we see is that when we use a two-stent strategy, 25% is being used, TAP is used, and the other 25 DK crush. And if we go to the left main, it's pretty much the same. In 70% of the PCIs performed up to now in the left main, and in general, it's with PCIs, it's very much the same, but over 70% end up with POT. So we are trying to learn about the best strategy or the last strategy to use in order to optimize the end treatment, the final treatment. I don't know what Dr. Mamas or the other experts can say about this type of techniques, and which you consider, which you think would be the best techniques to use in the left main, with the left main procedures. Would anyone like to say something about this?
I think published the Ultimaster registry, looking specifically at the question of POT versus final kissing delivery. Certainly in terms of target lesion failure, it's very clear that POT associated with a reduction in LF is final kissing delivery. I think the most important work from the BCS registry is intravascular imaging, which is associated with 30% reduction of mortality at 1 year following main PCI. So my view is in all cases, intravascular imaging, as much as your healthcare system, financial situation will control.
Yeah, thank you, Mamas. And Aníbal want a question, a comment, sorry, as well.
Sí, Pablo, gracias.
I believe that this bifurcation registry, which is the first registry we're developing since the opening of SOLACI-CACI research, I think that this is really very valuable information. For example, I was looking at the crossover rate, the provisional strategy, 12% of the patients approximately required to shift to a two-stent strategy, as opposed to other regions in the world, Europe, where the most frequently used technique was TAP. Therefore, this piece of information, to have the Latin American scenario reality, and this is the objective of Latin Beef. I think this is essential, and we'll be able to obtain a great deal of information, either to sustain, to maintain strategies, or to change strategies. So let's move on. Thank you, Aníbal, and thank you for the comments. Carla, we'll come back to the questions, but let's move on to the next presentation. At the end of the session, we'll have some more time for questions and answers. Now we'll give the floor to Sanjit Jolly, professor
and McMaster University. He's also a very well-known clinical trialist of the Population Health Research Institute, and he has executed multiple large randomized trials. One of them is the one that we're going to talk about today in terms of research methods, which is the TOTAL trial, one of the largest devices trials ever done, with more than 12,000 patients followed for more than 2 years, I understand. So welcome, Sajid, for this session.
Thank you, Pablo. It's my pleasure to be here.
Yeah, sorry, Sanjit is on vacation, so that's why we're going to accelerate a little bit the session. So now we're going to show the presentation from Sanjit. So vamos a alterar el orden de la sesión. Necesito ahora si podríamos ponerla.
We'll shift now. Okay, we'll listen to Sanjit's presentation.
It is my pleasure to be able to present at SOLACI 2021. I am Sanjit Jolly, Professor of Medicine, Interventional Cardiologist at McMaster University. And my talk is entitled Pitfalls and Lessons Learned from Device Trials. And this is really particularly about the experience of one of the largest device trials ever performed in interventional cardiology. These are my disclosures. The question is, why is this a problem? I think most device trials have tended to be small, less than 1,000 patients, and they've been really focused on surrogate outcomes. There's been a mix of registries and randomized trials, and regulatory requirements, whether in the United States or around the world, have been less stringent for devices than drugs. So we've generally gotten smaller trials or less reliable data. This example is talking about thrombus aspiration during ST elevation MI. On the left-hand panel is an example of an anterior ST elevation MI where you've had distal embolization after stent deployment and poor TIMI flow after prime PCI. And on the right-hand panel is what you can get from a manual aspiration device. You can remove the thrombus prior to stent deployment. And this simply made stents, and it's, there was really a good hypothesis why this technology can improve clinical outcomes. The TOPAZ trial, now published more than 10 years ago, was a single-center trial of just over 1,000 patients that had a primary outcome that was a surrogate outcome, myocardial blush grade 0 or 1, so impaired tissue perfusion based on myocardial blush grade, and there was a modest improvement in myocardial blush grade with aspiration thrombectomy compared to PCI alone. At 1 year follow-up, surprisingly, there was a significant, nearly 50% reduction in mortality with thrombus aspiration. And this technology now became part of guidelines and rapidly propagated. And we designed the total trial, which was a randomized trial of 10,700 patients, one-to-one randomization of strategy of routine upfront manual aspiration thrombectomy versus PCI alone. And the primary outcome as shown there was CV death, recurrent MI, cardiogenic shock, or neuroworsening class 4 heart failure up to 180 days. This was published in the New England Journal of Medicine in 2015. And what we showed was that, in fact, there was no difference in the primary outcome of CV death, MI shock, or class 4 heart failure, 6.9% versus 7.0%. No difference in CV death, recurrent MI, shock, or even class 4 heart failure itself. Surprisingly, there was a more than doubling of the risk of stroke within 30 days, 0.7% versus 0.3% with thrombus aspiration. As a result of these findings, guidelines changed from recommending routine thrombus aspiration to, in fact, making it a class 3 for routine thrombus aspiration in patients with STEMI, that it should be used selectively as a bailout option. Now, the question is, how do we put this together with the TOPS trial and the surrogate outcome? And in fact, we went to the Data Safety Monitoring Committee, and we went to their interim analysis to help us understand why things were so different between the TAPS trial and total. Here are the interim analysis the Data Monitoring Committee reviewed at each interim analysis. And you can see early in the trial, particularly when there's less than 1,000 patients, there is a benefit for cardiovascular mortality with thrombus aspiration. And as time went on, that benefit actually became less and less. It was no longer significant. And that's very important. When you looked at the primary outcome, very similar findings where there was appeared to be benefit early on. And then by the end of the trial, in fact, it was completely neutral for the primary outcome of CV death, recurrent MI, shock, and class 4 heart failure. One of the important things is when you look at stroke, in fact, stroke only became significant harm by the end of the trial. So had we not completed the trial, in fact, this finding would not have been statistically significant. So what would have happened if the Data Monitoring Committee had stopped at the first interim analysis? We would have wrongly concluded that, in fact, thrombus aspiration reduces mortality, and we would not have detected the potential harm of stroke as a result of thrombus aspiration. So very, very important. In fact, there is good data from randomized trials where trials that have compared the same intervention where they stopped early versus those that continued on. And trials that were stopped early have 30% greater treatment effect than those that did not stop early. So you may overestimate the benefit if you stop early. And this is particularly a problem with small trials with extreme results. And I think this is very, very important because we do see small trials in interventional cardiology where we see 50% reductions in outcomes like mortality. That is likely too good to be true. This is data from this publication in JAMA, and it really shows on the bottom panel the number of outcome events, and this is the ratio of relative risks between a trial that stopped early and versus a trial that continued in the same intervention. And particularly when you had less than 200 outcome events, you were more likely, if you stopped early, to in fact overestimate the treatment effect, by a large margin. Trials that have large numbers of outcome events, such as more than 500 outcome events, if you stop early, you're less susceptible to that. So I think the key important issue is that we need large trials. And if you have 500 outcome events, that's probably a pretty reliable estimate of your finding. So in summary, small trials and interim analysis are prone to chance findings. And I think this is really highlighted by the story of thrombus aspiration with the TAPS trial and the interim analysis total. We need large randomized trials of devices to really assess if they can improve outcomes such as mortality and MI. And we need to involve all parties, industry, regulatory bodies, and clinicians in making this happen. Thank you.
So thank you, Sanchit, for this great presentation. I think it's a very important topic. And before we have questions from the panelists or the audience, I want to ask you something that, maybe this is a lesson why we need large randomized trial for almost everything. Do you think that that is the case, and what is not the case? In which situations would you push for a large RCT, let's say, for another controversy, let's say the use of Impella or LV support in high-risk PCI? What is your, or maybe other scenarios, maybe other devices? So what is your take on which scenarios need large trials and which they don't?
Yeah, that's an excellent question, Pablo. I think the advent of registry-based trials perhaps is the future, and perhaps Latin America can be a leader in that we certainly do need, that we have very expensive device therapies. And, TAVR is a good example where RCTs really revolutionized. They showed TAVR saved lives, and that area exploded. We really need the same sort of data for advanced therapies such as Impella. It is difficult to do trials where, for example, with ECMO, in COVID-19 patients where, they have very little options. But I think, the more we can propagate and integrate trials into our clinical practice and to make it really as easy as possible. And that's the advantage of potentially registry-based trials, because the industry is only going to do a small niche of trials. And it's up to us as a community to do the rest together.
Yeah, exactly. We need to push for it. So thank you, Sanchit, for your answer. if there is no other questions,
I can see.
Yeah, Fernando. Fernando, Sanchit, when would you consider thrombus aspiration nowadays? Where would you see there is still a role?
Yeah, no, absolutely. I think I tell our interventional fellows that thrombus aspiration still has a role. It goes now from a religion where you should take it for every case to being very selective. So I generally, if a vessel is occluded, I open it up with a small diameter balloon. If I still have TIMI 01 flow with a large amount of thrombus, then I'll take the device. And that's really the bailout arm, the control arm of the total trial. Is its selective use probably in 10 to 20% of cases, no longer 80 to 100%.
A quick question, Pablo, to my friend Sanjit. How are you? This is Alex Abizide. How are you?
I'm doing well, Alex. Nice to see you.
Thank you. I have a hard time to design studies for vulnerable plaque, for non-culprit lesion. I want to pick your brain here a little bit to see what are your thoughts about non-culprit lesions and forget about physiology in such lesions, right? So what would be your advice when you design clinical trials for vulnerable plaque?
I think number one, you need to have enough outcome events to show a difference. So you need to select populations where you're likely to have enough outcome events. So, perhaps the non-STEMI, STEMI population, where you're looking at OCTing those vessels, are going to be more likely to show benefit in terms of treating those vulnerable plaques than you will with a stable CAD population. I think that we really need, it's always a basis. We need really good, large OCT registries to help guide us. And we need to precede the RCTs potentially for some of these items. So, once you do the RCT, everything, you really need to know where you're going to intervene and where you're not going to intervene. So
perfect, Sanchit. So if there is no other questions, you are in your cottage, so probably better for you to go and spend some more free time on your vacations, and probably say publicly that something I learned from you is that how hard is to run properly a large trial. There's a lot of responsibility, and especially if you want to make a game changer like was Rival and Total, and hopefully clear synergy in the future. So you are a very good example to follow in your responsibility and your dedication of clinical research.
Thank you, Pablo. All the best. Bye, everyone.
Okay. Thank you, Sanchit. So, fue un placer tener a Sanchit con nosotros, y ahora pasamos a la próxima sesión, que es...
Now go to the next session. Luis Virgen, coordinator in charge of Luis Virgen, co-PI of the Latin Peripheral Registry, SOLACI Peripheral. He's the president of the Cardiology Society in Jalisco, Mexico, and president of the Virgin Institute in Guadalajara, Jalisco, Mexico too. So Luis Virgen, welcome to the sessions, and we'll hear from you now. Hello, I'm Luis Virgen. I'm interventionist cardiologist from Guadalajara. I want to thank SOLACI Peripheral for allowing me to show the preliminary results. I thank the other coordinators, Maximiliano, Gustavo, Ana, the research team, Pablo, Monica, and the director of Latin Peripheral, Mauricio Cavalieri, for this opportunity. The SOLACI Peripheral Registry is a registry that has as a characteristic to include patients with angioplasties in the lower limbs, with intermittent claudication and critical ischemia. For this registry, we don't include severe or embolic ischemias. All the centers in Latin America can participate without a minimum number of cases, including interventional cardiologists, radiologists. When the Latin Peripheral around 2020, we decided to devote ourselves to create this Latin registry during 1 year, including the most important variables for this pathology. And in May 2021, we were able to actually have a pilot phase in 2 countries. Now, August 2021, we have 10 centers, 3 countries, this preliminary validation phase with 85 patients. Our goal in the next years is to have more than 1,000 patients, dozens of centers, several countries in LATAM, and to start dividing it in 2 pathologies. These are the 10 centers that participate until today, most of them in Argentina. There is 1 center in Colombia and 3 centers in Mexico. I thank all of these centers for participating with their patients, and we hope that very soon we can include many other centers in LATAM. The results of these 85 patients have been the following. Mean age 67 years old, 30% women, 67 Latin, 31 Europeans, including patients in Argentina, the body mass index 26, creatinine normal in most patients. It's interesting to see the number of patients that take aspirin, 89%, statins, 82%, clopidogrel, 78%, and cilostazol, 52%. 94% of the patients in this registry have a hypertension, 78% hyperlipidemia, 23 are smokers, 35% have diabetes, insulin dependent, 21 previous vascular disease, 10% with a previous infarction, and 30% with coronary revascularization. Regarding the background of these patients, 15% of them have had amputations at some point, 15% have had a surgical revascularization of the lower limbs, and 30% of them have had an angioplasty before of the same limb. Regarding the assessment, the centers in Latin America, 80% of them, they do diagnosis using Doppler of the lower limbs. Only 10% use a CTA, and only a small percentage with a previous angiography. Previous patient, 42% Rutherford 3, 9% Rutherford 4, and 40% Rutherford 5. That means that only 4% were in Rutherford 1 or 2 and 5% in Rutherford 6. Most of them then Rutherford 3, 4, and 5 were in priority and urgency, only 9%, because in this registry we don't include severe patients. In the case of the WIFI, 45% they have a small ulcer, 34% a deep ulcer, and 4.3% gangrene or an extensive ulcer. 92% of the patients had some sort of ischemia. 8.8% had very little ischemia or no ischemia. And in terms of infection classification, let's see that 30% did not have infection, 0% had severe infection, and around 60-70% had a mild or moderate infection. Access pathway, well, we use the common femoral access in 80% of the cases, superficial 10%, radial or bronchial, and they decided to use introducer 6, 5 French. Only 1 patient we use 8 French in iliac treatment, and 8-9% we used 7 French. In terms of the ultrasound to do punction, 27% of the punctions are guided with ultrasound, and initially we prefer to use the anterograde technique in 87% of the cases, and from those only 78.7% were of the cases were successful, 21% of the retrograde access. Look at these guides and support. Many are in the femoral segment, femoropopliteal iliac, and that means that the strength is 0.035, the most commonly used in 59% of the cases, 22% of the cases 0.05, 14 and 0.008 in 38% of the cases. 38% of the patients also, we only used a single wire with no support. 25% of the cases we used the same balloon as a support. In 23% of the cases we used the catheter, and the microcatheters in 34% of the cases. 72% of the patients were treated in only one area, and 26% were treated in two areas, and 2% three areas. When we see this 28%, most of them were in the femoral section and intrapatellar section, 28 iliofemoral and 8% infrapatellar. So most of them were femoral lesions below the knee, and when they had only one, they were iliac or femoral. Within the territories or the areas, we had the femoral popliteum, 55-60%, 25 iliac femoral, and only 40% intrapatellar. In the femoral popliteum, 40% were in classification type A classification, and 60% were in type CD. In terms of the lesion characteristics, you can see that this depends a lot on the sector, on the area segment. In iliac infrapatellar, we see more calcification, stent restenosis in the femoral section, and the infrapatellar, because we didn't use stent, we didn't find any stent restenosis patients. The first time that we treated the patient, most of them had their first time with this treatment. Few patients had a second, a new revascularization. When we look at patients, if they were part of an intervention in staged intervention, we see that the iliac was 20% of the iliac. They were having a staged revascularization. Femoral and intrapopliteal, it was just a single intervention. So the material that we used, well, we see that in the iliac femoral, less balloons, more stents, femoral popliteal, more balloons, with a trend to use the DEB. And in the popliteum, most of the cases with balloon only, and in the infrapatellar and femoral popliteum, the stent as a bailout technique. So what we see in the literature, we're seeing that that is in our registry with practically 89-87% of success rate during those procedures. Other data that we collect when we analyze this, well, the larger in-hospital events, follow-up, angioplasty and pre-angioplasty anatomy materials, such as stents, balloons, atherectomy, and the medication that the students will use or are using. So it's a very ambitious project, and we have the upcoming years to have results, not preliminary results, but with many more patients. And to do that, we need everybody's participation from all the centers in Latin America. If there is any interest, please let us know, contact us, because we want everybody to participate. Send me an email at research@solaci.org to participate in this trial. Thank you so much for your attention. Thank you, Luis, and congratulations for your participation and for the registry. Gustavo, Ana, Dr. Cavalieri, the SOLACI Peripheral. I have a lot of expectations and a lot of information that is still missing in Latin America. I'd like to ask Dr. Omar Santera, who has a lot of expertise in peripheral, what do you think about the 30% bailout stenting in the femoral, superficial femoral segment, if that's aligned with your practice or the rest of the reports, and then the comment that Luis has about that?
I would have liked to know, I don't know if you said it, Luis, what degree of complete obstructions you had in the superficial femoral, because this is directly related to stenting bailout. Probably when you recannulate a lesion 80 millimeters of long, we'll have dissections, entries and re-entries, and most likely, even though the distal flows is good, then we would place self-expandable stents. I mean, long self-expandable stents, so we don't need to add stents as we did before and in the past. I mean, so especially in the femoral territory, whether that there's in the registry many total occlusions, because recannulation almost always, to our experience, is followed by stent implantation. Would you like to make any comment about that finding? I believe, and by looking at the data, there is a mix of patients, critical ischemic patients, and so at some point you need to sort of divide them. It's a more of a recurrent type of patient or more ischemic critical patients. So in the femoral segment, if we thought about 15, 20 centimeter lesions, so that is a fourth of these patients will end up with a stent, so bailout stent, if we use, for example, a drug-eluted balloon. But if I agree that when you're talking about longer lesions, the possibilities of a stent is a little larger. So I think we have to still work on or analyze the data. We haven't had any reported cases, so it's all preliminary. I don't have the number of occlusions by anatomy, but we will take that into consideration, Omar. And also the length, right? The length as well. Yeah, both things. The length of the obstruction, the occlusion, the length of the states, the localization of the anatomy, whether it's severe, total occlusion, it's broken down like that. Okay. A question to Luis, Omar, and the rest of the panels. If you have specifically analyzed not only total occlusion, but also the diabetic group or non-diabetic group, and something that I saw in the Cleveland Clinic is the prolonged balloon 2 minutes, 5 minutes, and the TVR rate. So what I'd like to know is if in diabetic patients or non-diabetic patients, in a situation with balloon, is there any difference? I mean, do you have some data, or what do you think about it? In relation to diabetic patients, if we look at 60% of diabetic patients, 30% insulin dependent, even though it's a very number of diabetic patients, but this is, you know, relative to the type of disease, I mean peripheral disease. So these data we will analyze them very much in depth. And about inflation, the peripheral problem is, I mean, there's so many variables, so many segments, but it took us a year to actually determine the variables. So we had to really think them out. Otherwise, we would end up with a huge database, but we'll do a study that it doesn't even cover 100 patients. So it's something that we need to begin. We want to start analyzing, and that has to determine the prognosis. Particularly if I start, I mean, there's a probability of a dissection, then the probability of stenting is higher. And this is also in accordance with Jolly said, if it's randomized, better. Luis, you mentioned that you want to perform an inflation, randomized. We can think about it, analyze it, but the platform of the registry, in a way, describes clinical practice in a region, but as a platform, in a little while we'll have a new study, but we can do this once the registry is in place. It took us a lot of time to develop this because this database, and I think that we were able to create this unique database, really. Thank you, Luis. Jose, you have another question? Well, first, congratulations, Luis, for your work together with Luis and SOLACI Peripheral team, another registry that has total support from SOLACI that is really promising. Congratulations. My question is, actually, I'm being curious about it. Latin America, most of interventional cardiologists who practice also do peripheral, or is a minority of interventional cardiologists who do peripherals? So I'll answer that. First, I want to thank Dr. Mangiani, because Mauricio and myself, I mean, we were supported by SOLACI since from the very beginning, and Pablo for many months. We worked very hard to complete this project, so I'm really grateful for their support. And as about cardiologists, I think it all depends on where they were trained. I know that in Argentina, there's a number of interventional cardiologists that have some training in peripheral. I was trained in Brazil, and there are very few interventional cardiologists who do peripheral, and this has increased. So there's a chapter in the Hemodynamic Society, but it's still a minority. And in Mexico, I think it's increasing, but it's only 10% of interventional cardiologists do peripheral. That were trained probably in other centers such as Italy or the United States. So I think it's an area that is growing. Thank you, Luis, Jose, and everybody for the support. And congratulations on the registry. Lucio, you have a question, but we need to continue. We'll move on to the next talk. By Carla Agatiello. She's in charge of the TAVR program at Hospital Italiano, one of the largest programs in Argentina and in the region. Carla, we will listen to a pre-recorded session, and then we'll have a look at the questions. Good afternoon. My name is Carla Agatiello. I'm a member of this group that was able to come up with the first SOLACI-CACI registry using the trade technique. There is a large number of experts in this guideline. Well, this is the background. We know that TAVI has been increasing in Latin America, and it's expensive technology. There are no current guidelines in the region. We base our decisions on European and American guidelines. Their local recommendations are not consistent or are quite poor, so we believe we needed to have a registry or this guideline in Latin America. The goal was to develop high quality and transparent information to help physicians and other stakeholders to assess TAVI versus SAVR in Latin America. We use the grading technique to develop the document, and we put together a team with different roles. We had the writing team, the methods team, the revisers, and a group of experts. You can see experts from different countries and different specialties, and also the method systematic review and experts group teams. As you can see, we begin with a research question that is exposed to all of the scientific evidence possible to answer the question, and then we score. We use a specific grading system, I mean the low or high level of evidence, and this evidence is exposed to a panel of experts in order to determine whether it's recommendable or not. The investigation question, elderly patient 75 years old, because the other guides began with 70 with symptomatic severe aortic syndrome suitable for transfemoral approach. The intervention transfemoral TAVI and the outcomes patient important outcomes. And you can see the why. I mean, why elderly or above 75? Because, I mean, there's not much uncertainty in terms of long-term durability. Trials included patients older than 65, and then 75 was an optimal age to start the guide and speak of patients, elderly patients. Regarding the process, we looked at secondary outcomes. These outcomes were ranked in terms of importance, critical, important, and not important. And this was, I mean, we evaluated all of the evidence, and we did not consider the financial focus, and if the experts had to base their vote on a favor or against TAVI, and the most important reason for their decision. Evidence was based on 8 RCTs in almost 8,000 patients. Critical outcomes, 30 days, mortality, CV mortality, stroke, and then longest follow-up, and then other non-critical outcomes. In summary, and based on the reported evidence, for the TAVI issue, were in favor. I mean, evidence was in favor of TAVI, and the balance was, favored TAVI in red. I mean, which was against the expense, how expensive it was. I mean, the system was. That sort of balanced it in favor of TAVI. In 2020, the recommendation of SEVER, and by analyzing all of the evidence, the recommendation was moderately in favor of TAVI in Latin America, and the recommendations had a strong evidence to support this and were based on a heart team or a panel of experts in each of the centers, and they had to be based on these expert group decisions. When the balance was in favor of TAVI, those were elderly patients over 75 years old that had a high or moderate risk for surgery. would have a frailty criteria, those patients that would have morbidity requiring a quick recovery, this would be in favor of TAVI, and that would favor surgery if the anatomy was not favorable for TAVI. If they were not feasible for transfemoral approach, if they had other valve therapy or multiple complex vessels to be treated, target vessels, or patients having issues in terms of prosthesis durability. Therefore, this is how we could actually, divide the scenario in favor of TAVI and against TAVI, or in favor of surgery. This first step of SOLACI guides is a very important step because we can have so many people working together, and we can have solid evidence in order to be able to communicate our stakeholders and patients when TAVI is properly indicated and when the situation is not favorable. Thank you very much for your attention. Thank you, Carla, for your presentation and your participation in the development of the guidelines. Even though this was developed by a group of people representing very important societies in Latin America, this represents all of Latin America, and we expect to be that it's evaluated by
one of the TAVR leader experts in Latin America. And which was your impression about the recommendation and the process? Do you think is reasonable? The conclusions, do you think, are applicable to Latin America, all the context? So, Dr. Abisaid, please.
Yes, thank you so much, Pablo. I think it's very, very reasonable. We also publish our guidelines here in Brazil, and even for patients with low risk, with older than 70 years old, it's considered to be feasible and applicable. So I think that we are updated, at least in the Brazilian guidelines, but I would love to see a Latin America consensus as well. So I think that it reinforces as an international society to help us with the payers, because the problem, Pablo, as most of us here in Latin America will face, is reimbursement. So the level of evidence and the guidelines will certainly help us to fight with the government authorities to make sure that it's going to be reimbursed. I think my question to you and to the group, Mangione, and also to mamas, I see mamas here, is about the anti-thrombotic regimen. Do we have a consensus, or it's still too early, mamas, perhaps, to decide what is the formal recommendation for TAVI with and without atrial fibrillation?
So, mamas, you can go ahead and answer.
Yes, I mean, certainly with atrial fibrillation, that there's lots of data now suggesting that NOAC should be used in preference of VKA. I think in terms of non-atrial fibrillation patients, I think that's quite an interesting discussion. We're getting a lot more data now that the FDA mandates CT in these patients, and that the presence of subclinical thrombosis and HALT in these valves. We know that subclinical thrombosis is associated with bad outcomes. What we haven't seen, however, is using NOACs in these sorts of patients improving outcomes. If anything, it's associated with worse outcomes. So certainly at least one trial has shown that. So to my mind, and certainly in my centre, we don't tend to use dual antiplatelet therapy for a long time. It's single antiplatelet therapy, and we certainly don't use the neural anticoagulants in patients with TAVR. But I think it's very much an evolving area, and there's going to be new data presented at the ESC as well around doxaban, which will be interesting.
I totally agree. And Pablo, one last.
Totalmente de acuerdo. Y la última pregunta, Pablo, en cuanto a la durabilidad.
20-year data on SAPIEN and Evolute, and remember it was core valve, because those are the two valves that we really started to implant in our patients. My question to these experts and then Mamas can help, and perhaps Carla can help, is that do you think that when we have this more solid long-term data with TAVR, and when I say TAVR, almost 20 years is going to be SAPIEN and Evolute, do you think this is going to be a class effect for the other valves, for the newcomers? Can we extrapolate the data that we generated with SAPIEN and Evolute to the newcomers?
Well, thank you, Dr. Abizaid. Carla, ¿estás ahí?
¿Puedo decir algo cortito?
Sí.
Disculpen que estoy saliendo de infarto.
I'm going to say something very short. I think that that's what the newcomers are, are doing. They're seducing us. It's not the same, even though we have data, and we will have data for the past 20 years. TAVE, it's not the same. In France, for instance, they've been using it for 20 years. The implant that we did, the stents that we used at that time, they were not the same. It's very promising that we have 15, 20, 18 years of follow-up with devices that we have been using, but we can't say that the newcomers have the same amount of evidence. So we have to take that into account when we decide to adopt new technologies. Thank you, Carla. Dr. Mamas, do you have?
Forget is that the indication and the types of patients that receive TAVR have completely changed over the last 20 years. We're now implanting them in much younger and less comorbid patients. And we know that in younger patients, the histological data would suggest, and the imaging data would suggest that, valves deteriorate and much more quickly, and there's much more aggressive calcification of leaflets, for example, in younger patients. And so I don't think that we can apply data that was implanted in patient populations 20 years ago with different valves and completely different patients to more contemporary practice.
Okay, thank you, Mamas. I think it's totally reasonable, because we are kind of behind, because the evidence is developed, takes a lot of time to know what is, in the long-term durability, then it will always be a problem. Catching up with, it's different in cardiogenic shock trials in which the durability is not a problem, but in these trials in which the device needs to be durable is of course a problem. So, Lucio, do you have a comment?
Yes, Dr. Mamas, what do you think about this? We are doing nowadays in our institution discharge of the patient the same day, this old patient with previous pacemaker. So we are thinking about, do you think this patient will be benefit with this early discharge, or do you think it's the same in the COVID area?
I mean, so in my unit, we discharge patients generally the following day. I think in the COVID era, it's important to get patients out. And I think that's the other thing that around guidelines and recommendations, they have to be adaptive. And so, for example, we've published a paper in Circ Intervention in the United Kingdom showing that during COVID, there's 5,000 untreated cases of aortic stenosis. We're not going to catch up. And the only way to catch up is to change the threshold under which we undertake SAVR versus TAVR. And I think for any hope of catching up, we're going to have to change from cases that traditionally we would have done with SAVR to TAVR. And if we don't, then we know that with a particular waiting list, that there is a fall off of patients. We know that they have an increased risk of heart failure hospitalization at 80 days on the waiting list, and a 3 to 5% risk of mortality. So I think we have to get patients out quicker and also change how we treat patients with critical aortic stenosis, particularly during these challenging times.
Thank you, Mamas. That is actually one case we discharged the same day. Was a specific case. So we don't do that in usual practice. It was just just to getting ready for the future. So Jose, you have a question?
Yes, just a comment about the gears of Latin American guides. It's a tremendous work from your group, Pablo It's will help offshore the expansion of TAVI in Latin America, because we have now guides with excellent quality, so excellent that it was published at the heart. So, my friend, congratulations for this achievement for Latin America. Okay, paper with excellent quality. This is my comment. And about the antiplatelet therapy in this patient, I think we have some studies in the literature showing that in patients with the atrial fibrillation, you just have to keep this patient into oral anticoagulation. No need for antiplatelet therapy. And now after the publication of popular TAVI, I think for patients with no atrial fibrillation that doesn't need oral anticoagulation, I think the single antiplatelet therapy is enough for this patient. In our institution, our experience, we keep these patients only with aspirin. No more DAPT for this patient, only with aspirin. This is our experience. And about the minimalist approach, I think it's a tendency in the world to practice the minimalist approach. No, just a conscious sedation, no transesophageal echocardiogram, okay, and to discharge the patient from the hospital sooner, as you press in the early days. So in our experience, we discharge the patient from the hospital 24 or 48 hours after the procedure, with uncomplicated procedures.
Thank you, José. Gracias, José, por tu comentario, y la verdad que fue...
Thank you, Jose. It was everybody's work, so it's a great satisfaction. Thank you, Jose. Before we go to your question, I'd like to ask, because I was going to ask Dr. Viñolo in Uruguay, Alexander mentioned that we have to support the guidelines, even though they have their own recommendations, to do a similar recommendation in Latin America using a different guidelines method. They support the practice. How do you see that in Uruguay? And to know what your question was, because you raised your hand. Hi, good evening, everybody. Yes. That's why I raised my hand. Dr. Mangione pointed out the development of the guidelines was going to have the potential to generate the technique, the expansion of the technique in Latin America. And the guidelines say that it's addressed to Latin America. So a question that I would like to ask you, I leave it there and then I'll tell you what happens here, is if there is any chance, methodological chance or resource approach to adapt the conclusion to the force of evidence that you had for the different realities in Latin America, because they're quite different. In other words, the possibility to expand the techniques in different places, different regions, different cities, different countries are very different. There is a lot of inequality. There are lots of differences in terms of reimbursement for that technique. So you see, for instance, that a recommendation, a guideline that says that can put an IC that has no possibility to get finances for that technique, and perhaps in a tight spot, big ethical tight spot, because the recommendation is very important. And I, of course, share it. But all of a sudden, to get to that point implies to overcome a huge gap that may be hard to bridge. So is there any resource, any methodological resource, according to the income that we get, we can put pressure for that recommendation? Here in Uruguay, we have a very special situation. We had a slow and flat curve when the technique was developed since 2008 onwards, that we saw it accelerated, but not because there is a financing system in the last 5 years, but mostly because we resourced to what we know here as protection resource. So it's a lawsuit that the patient files against the government, the state, in order for the government to pay for that intervention. So that has allowed the expansion or an increase of the use of that technique in our country. Remember that here we are 3.5 million people in Uruguay, and perhaps now we will reach 250 TAVIs total. Since the beginning of the procedure up to now, with an important number of TAVI in the last few years, I would say in the last 2 years, the technique has developed exponentially. But the question was mostly how to adapt the strength of this recommendation to the reality of each country, knowing that the resources are so uneven. Gustavo, your question is very, very important. Actually, the biggest concern of the guidelines to implement TAVI has to do with the cost. And the grade is about in favor or against the recommendation of a new technique. So the main thing that we had in mind was to have a weak recommendation is the cost. Between 30 and 50% voted for a strong recommendation, but it didn't reach 80%, so it didn't make it to strong recommendation. So some statistical methods to do it, ICER, for example, in the UK, NICE calculates ICER for all the interventions. And it puts a threshold, willingness to pay. How much does it cost to increase one daily? And they set that cap. That analysis in Latin America is impossible to do because we not only have different healthcare systems or financing systems in the country. Even in my own healthcare center, I have patients with different coverage. So in the country, different states, different cities, if I don't have the clear costs or the resources of this healthcare system, it's impossible for us to do an extra a comparison that we can extrapolate. So the analysis in the guidelines team says, okay, let's not do the economical analysis because of that. As an alternative, we found out the prices of TAVI in Latin America, the range, how much does it cost to the healthcare system, and taking that into account, we found that it increases costs by using TAVI, despite the reduction of clinical events and better quality of life for the patient. And once that was submitted to the panel, it was the biggest reason why we would not do a TAVI. And Gustavo, about your question, how to adapt that to each center, I think each country in their healthcare system, they should do some economic analysis. If it's not at country level, because the country uses different healthcare system, that in here you have public and private and payers. So each one should say, okay, we analyze, let's use the money for vaccinations, let's do TAVI, but there has to be a formal analysis. And here in Latin America, different from what happens in the UK and in other places in the world, does not happen. In Latin America, that does not happen. Thank you for your question. I hope we have answered. There is a question by Omar, but I also want to hear from Omar. We have Enrique that he just connected again. Omar, you have a question.
Responde primero, decir que todas estas cosas que estamos hablando y exponiendo están bajo la tutela del área de research, del cual vos sos el director, que todos los datos que quedan en nuestra sociedad quedan en nuestra red CARP, y estos datos están a disposición de aquellas participantes de registros que quieran utilizarlo. O sea, es muy importante que SOLACI tenga su base de datos, y su base de datos
their own database, and the database can be used by the members that are part of the registers for analysis purposes, or to include them in their papers. So I think that the investment by SOLACI in terms of research is being fruitful and will be very fruitful. That's something I wanted to say. Thank you, Omar, for your contributions in the department. Thank you very much. The SOLACI registries are made in the RECAP platform. Each center has real-time access So in 10 minutes after entering the data, they are already available. So the collaborating center can have access to the data. Collaborative data of all of the centers together, the multi-center, yes, I mean, that has a specific approval protocol, so that they become part of the global database, but local database belong to each center and the RecDAP platform. This is why we emphasize, we invite everyone to take part in this. Thank you, Mark, for the comment. Aníbal. Thank you, Pablo. I think that the challenge we have as a society now, as a region, Latin America, beyond the achievement, I mean, or of the achievement of, publishing these guidelines to put together registry. There are countries in the regions that have their own registries. They've been very successful. For example, the Brazilian registry. But I think that there's a need to have a LATAM registry. And I know that the research department is already working on this. So after the guidelines, the start of the registry will be crucial. This is the next step. Thank you, Aníbal, for your comment. Enrique, together with Fabio Brito, is the PI of TAVI registry. I'd like to hear your comment. You actively participated in the guidelines, and what's your... Thank you, Pablo. This is very hard work. I see clearly that SOLACI supports the hemodynamics professionals in the region to develop a user-friendly platform so that everyone can have access to the data, and the results and publications are very important in order for improvement purposes, the mortality, the causes of mortality, the challenges, and to seek to improve TAVI quality, to train LATAM people. So SOLACI's key role is to support and be sort of a catalyzer that would promote and improve the process so that more and more people can have access to these therapies and other therapies. So this joint work, I think, is key and important for all of us. Thank you, Enrique, for your comment and for your work with the department and TAVI. As Aníbal said, we're all looking forward for the launch. This is on a pilot phase stage, but this is the initial stage, and now we'll open the invitation to other centers. There's one more talk by Deepa Bhatt. He's the executive director of the Interventional Cardiologist Center in Boston, and also a professor of medicine at Harvard University. His talk is very interesting on lipid management, which is part of his research area. He could not, due to personal reasons, he was working, but he pre-recorded his talk. So let's listen. Let's take a listen.
Hello, I'm Dr. Deepak Bhatt from Brigham and Women's Hospital and Harvard Medical School. It's such a pleasure to be able to speak to all of you at SOLACI this year on the topic of lipid management post-PCI. These are my disclosures, which include research funding from a number of different companies paid to Brigham and Women's Hospital for my role working on research with a number of different lipid-modifying drugs and other drugs and devices. And my discussion may include off-label and/or investigational uses of drugs or devices. So let's start first with just what the big picture is. Of course, you're all familiar with secondary prevention, that is, treating patients with actual cardiovascular disease, and with primary prevention, which is treating risk factors for the development of cardiovascular disease, things like dyslipidemia. But you may not be as familiar with the term primordial prevention, which is the encouragement and adoption of healthy behaviors to prevent the development of risk factors in the first place. And this includes things like a healthy diet. I would say, in general, the best diet is a plant-based diet, one that's high in grains, whole fruits, whole vegetables, that type of diet, and coupled with a low-calorie diet. That's really what the evidence points to as the best diet, to the extent patients can adopt and tolerate that. Regular physical activity every day is important, maintaining an ideal body weight, avoidance of tobacco and smoking, including vaping, and some things even starting with fetal and infant health, and trying to minimize environmental pollution, namely air pollution. These are all things that we can do individually or as a society or as healthcare leaders to try to prevent the development of risk factors and ultimately cardiovascular disease. So along those lines, let me speak a bit beyond lifestyle modification to pharmacotherapy. And of course, everyone undergoing PCI, barring a contraindication, should be on a statin and a maximally tolerated dose. I'm not going to review those data because hopefully everyone already believes in that and is doing that. How can we go beyond that degree of risk factor reduction in LDL control? Well, the IMPROVE IT trial done by colleagues, including my good friend here at the Brigham, Chris Cannon, showed that non-LDL mediated, non-statin mediated mechanisms of LDL reduction also lower cardiovascular risk. In this case, ezetimibe significantly lowering LDL cholesterol, but also significantly lowering cardiovascular events in a non-statin LDL reduction mode of action. So that really conceptually was quite an advance. Now, the degree of risk reduction is modest, but it is achieved safely and now with a generic medicine. Next, beyond the ezetimibe approach came PCSK9 inhibitors, such as in the FOURIER trial, where there was also a reduction in LDL cholesterol. In this case, a much larger reduction. PCSK9 inhibitors reduce LDL 50 to 60% or so, and there was a corresponding decrease in cardiovascular ischemic rates. Also, here, a colleague of mine from Brigham and Women's Hospital. And along with the FOURIER data set, soon thereafter came Odyssey Outcomes that examined another PCSK9 inhibitor. FOURIER was evolocumab, Odyssey was alirocumab. Here as well, a large reduction in LDL cholesterols on a background of statin therapy, but still a corresponding incremental risk reduction going beyond what statins can do. So this really shows that whether it's ezetimibe, PCSK9 inhibitors, we can do more with respect to LDL reduction than statins alone, but also more that we can do with respect to cardiovascular risk reduction. And Odyssey in particular was patients that are relevant to this target audience. That is, these are patients with acute coronary syndrome that had been enrolled. In FOURIER, it was stable atherosclerotic disease. Here in Odyssey, specifically those that had a history of acute coronary syndromes, many of whom, of course, undergo PCI. Now, the one other thing that was noted in Odyssey, perhaps because it was an ACS population as opposed to the more stable FOURIER population, was the effect on death. And what we saw in the overall trial was a lower rate of death, but this was most marked in those patients that had higher baseline LDL cholesterols. So those with an LDL cholesterol greater than or equal to 100 milligrams per deciliter, that seemed to be the patients who were really benefiting from the addition of a PCSK9 inhibitor with respect to the mortality reduction. And this is a post hoc analysis, but still it makes sense. The higher the baseline LDL, the more likely the patient will benefit from intense further LDL reduction. And this leads to this concept of cholesterol years. I'm sure you all have heard about pack years. That is the number of packs a patient smokes of cigarettes per day times the number of years, pack years. Well, here's that same concept for cholesterol years, where the risk that a patient faces depends on how high their cholesterol is and for how long. And it's an area under the curve phenomenon. So if someone has severe familial hypercholesterolemia from the time of birth, well, they start to have problems at a pretty young age because their cholesterol is very high. But even people with more modest hypercholesterolemia, if it goes on for long enough, 50, 60, 80 years or so, well, then eventually there's a good likelihood they'll develop atherosclerosis, in some cases symptomatic, in some cases fatal. So very important in people who are at risk, either because they have very high LDL cholesterol or high cardiovascular risk, and especially both, to use lifestyle modification to reduce LDL on a population level, and in appropriately risk stratified people, also potent pharmacotherapy, starting with statins, but then also ezetimibe and PCSK9 inhibitors as appropriate. That's all I'm going to say about LDL. Let me shift now to triglycerides. And there are a number of drugs out there in the past, in the present, in the future that are being evaluated for triglyceride reduction. Some of the most interesting things are these molecular approaches targeting RNA to lower triglycerides. This lowers triglycerides by 50, 90, over 100% in some cases. And if this molecular approach of targeting RNA is found to be safe in large cardiovascular outcome trials, this could be an effective way of incrementally reducing risk. That is not just LDL cholesterol, but targeting triglyceride-rich lipoproteins. Now, one way of lowering triglycerides is with omega-3 fatty acids at high doses. I don't have the time to describe all the differences between omega-3 fatty acids, other than to say there are lots of differences. And the one that has the best data supporting not just triglyceride reduction, but more importantly, cardiovascular risk reduction is here in the middle, EPA or eicosapentaenoic acid. That was initially studied in the JELIS trial, where there was a significant reduction in major adverse cardiovascular events in over 18,000 Japanese patients randomized to a prescription version of EPA or eicosapentaenoic acid called icosapent-ethyl, or to control, a 19% relative risk reduction, with benefits that were consistent in both primary and secondary prevention. And another study, randomized as well, but open label, control, but no placebo, was a CHERRY trial looking at intravascular ultrasound in 193 post-PCI patients randomized to either atorvastatin alone or 1.8 grams a day of EPA or icosapent-ethyl plus 4 grams of atorvastatin. So an open label but randomized trial of EPA versus no EPA. And this was a pretty short-term study for an IVA study, 6 to 8 months. But even at that early time point, a significant decrease in plaque progression rates in patients on EPA plus statin versus statin alone. And this is intravascular ultrasound, but more recently using non-invasive CT, same active ingredient, icosapent-ethyl, again, that's a highly purified omega-3 fatty acid of EPA or icosapentaenoic acid, shown at 9 months to have significant effects on a variety of different measures of plaque volume and composition. Though the primary endpoint in this interim analysis wasn't met, so as pre-specified, the trial went on to the full 18 months, and there was a significant difference in the low attenuation plaque progression rates in favor of icosapent-ethyl versus placebo on non-invasive CT angiography, and multiple other measures of plaque volume and composition also favorably influenced. And of course is the REDUCE-IT trial, a cardiovascular outcome trial of icosapent-ethyl, again a highly purified icosapentaenoic acid versus placebo, large reductions in the primary and key secondary endpoints. So ischemic events across the board significantly reduced, including a significant 20% reduction in death from cardiovascular causes. And finally, let me share with you REDUCE-IT REVASC. I think of particular interest to interventionalists, where we examined within the overall REDUCE-IT trial the time to coronary revascularization as an endpoint in the overall trial, finding a significant 34% relative, about a 4 to 5% absolute risk reduction, highly statistically significant. And one of the independent predictors of REVASC, interestingly, was elevated triglycerides. And in terms of the time of benefit, it was a hazard ratio that was below 1 right after randomization, you can see in the dark blue line, but consistently statistically significant where the 95% confidence intervals, these dashed blue lines, are under 1, consistently significant by about 11 months. So you could say by about a year, a very early, robust, statistically significant benefit in reducing revascularization. And within REDUCE-IT, significant reductions in elective, urgent, and even emergent revascularization. And interestingly, there were reductions in this blinded trial with independent adjudication of endpoints in time to PCI and also in time to CABG. So there was less CABG in this blinded trial in patients randomized to EPA versus no EPA. How does this stack up with other prior trials? Well, the risk reductions in revascularization, even more broadly in ischemic events, and reduce it, well, you'd have to go back in time to the 4S trial, which is a trial of statin versus placebo, to see this degree of risk reduction, which was on top of statin for icosapent ethyl, or EPA, versus placebo. So to summarize then, in patients at high cardiovascular risk, including those who've undergone PCI, those patients are at the apex of the risk pyramid here. And we really want to focus our preventive efforts, lifestyle modification, intensively delivered for sure, but including pharmacotherapy, polypharmacy, appropriate polypharmacy in these patients at the highest risk of recurrent ischemic events, as well as procedural therapy. These are really quite complementary. So hopefully this quick review of some secondary prevention, broadly speaking, but also targeting patients with a history of PCI, has been useful to you. Thank you once again for the opportunity to come speak at SOLACI. It's always a pleasure to speak to this great audience. Thank you.
Bueno, muchas gracias, doctor.
Thank you, Dr. Bad, for your presentation. An honor, really. He's leading a very important program on cardiovascular reduction. And once the patient is revascularized, we don't want the patient to come back to the operating room. So the medical treatment is really key. We're running out of time, so we'll have to move on to the Microport Symposium. I'd like to thank all of the panelists, the audience, the speakers. Thank you very much. I look forward to meeting you soon.
Hello, everybody. We're going to start this section, this important section, symposium from Microport, leading with evidence, choosing with confidence. It's an important symposium. We have a well-known physician, experts, that will talk about the TAVR procedure and also coronary procedure in this session. First of all, I'd like to thank this kind invitation from William. Thank you, William, for me to be the moderator of this session. Before I start really the session, I'd like to give the word for William to say some words from Microport and to show us also a video. Isn't it, William?
That is correct, Dr. Mangioni. So thank you very much, Dr. Mangioni, and buenas noches, boa noite, good evening, and for some of the participants, good morning, and welcome to this last activity of the SOLACI-CACI Congress, which is our Microport Symposium, where we are going to share with you some experiences with two our products, actually our TAVI and also our drug-eluting stent, Firehawk, which are part of our broad portfolio of products. Microport is a company that has products across 12 therapeutic areas, and we are bringing them now to Latin America. You will see us in the different countries, structuring operations, reaching out to the physician community in the very near future. Yes. So with this, I would like to share with you a brief video that describes Microport, which is a player that is arriving now to the interventional cardiology arena in Latin America.
Microport Scientific traces its origin back to 1998.
We're a group of dedicated individuals joined together in a small office at Zhengzhou High-Tech Park of Shanghai to transform medical treatments and enhance patient outcomes. Through years of growth and innovation, Microport is now a leading multinational medical solution provider, including cardiovascular intervention and structural heart, electrophysiology and cardiac rhythm management, orthopedics and soft tissue repair, endovascular and peripheral vascular diseases, neurovascular intervention and neurosciences, life sciences, urology and gynecology, respiratory and gastroenterology, surgical devices and medical robotics. With over 300 products currently approved for use globally, Microport is contributing to a better world through its life-saving medical therapies and quality-improving care. Microport devices are being used in patients every 6 seconds to help save a life, improve quality of life, or create a new life for tens of millions of patients worldwide. We currently have a global workforce of over 7,000 employees from over 30 countries. At Microport, we're always enthusiastic and passionate about maintaining the highest standards of quality in all aspects of daily operation of our business, because we believe it takes hundreds of millions of small details to achieve one triumphant success. Microport has created a unique management concept named Integrated Horizontal and Vertical Organization Management Model. The main vertical functional departments, supported by horizontal club-like organization. This innovation concept targets to break department silos, promote cross-departmental cooperation. At Microport, we are committed to our corporate social responsibilities, are constantly seeking new ways to improve the well-being of people and local communities. Microport is committed to become a people-centric enterprise that is dedicated to deliver a wide variety of emerging medical technologies and ultimately to improve and reshape human lives.
Okay. So this is a very brief description of Microport. Microport has a global footprint. It is really a multinational company that from Asia, where the headquarters are located, we are expanding both to America and Europe across 80 countries and regions, reaching out already to more than 10,000 hospitals. So in our region, Latin America, we are going basically to continue our journey with the Microport Life Triangle, where the patient always comes first, and together with the physician community, who is very well represented here tonight, we want to really support the care that you provide to the patients. So as we speak, you saw in the map that we have the Brazil operation, and we are opening up actually the Colombia operation next week, and we will be a lot closer to the medical community and the patients. We are very committed to right now support the physicians, the institutions in their care of the patients, especially in a critical moment where Latin America, that is the continent that was hit the hardest with COVID, starts finding its way out of the pandemic. So we will be there supporting the physicians, the institutions, your practice, while expanding the access of the general population to the therapies. So as the Vice President for Latin America for Microport, I really want to thank you again, Dr. Mangioni, for being the chairman of this session. Thank you also to our panelists, Dr. Abizai, Dr. Stefan, and also to our speakers, Dr. Lansky, Dr. Song, and Dr. Shen. So with that, Dr. Mangioni, I will transfer it back to you.
Thank you, William. Thank you for this nice presentation of your company that is growing so fast in the field of interventional cardiology. Congratulations. Before we start this meeting, I'd like also to present our panelists, two experts, panelists in interventional cardiology. The first one is Dr. Alexandre beside. It's my friend here from São Paulo, Brazil. Dr. Alexandre is a technical director of invasive cardiology in Instituto do Coração, the Heart Institute here in São Paulo. And he is also physician in interventional cardiology of the Heart Hospital in São Paulo, two very well-known institutions here in Brazil. It's a pleasure, Dr. Alexandre, to have you with us in this meeting. Thank you. And I'd like also to introduce Dr. Matias Effman from Argentina. Dr. Matias worked in the Sanatorio Gemes de Buenos Aires. He is also director of the structural program at Sanatorio Gemes and the Sanatorio Finocchieto in Buenos Aires. Also, thank you for your participation to take part of this meeting with us, Matias and Alexandre. We're going to change we are going to do a little change in the program of this meeting for a real reason, because Dr. Alexandra Lansky is spending her vacation in France, and now in France is 2 o'clock in the morning. So I'm gonna change the program. The first speak is gonna be Dr. Alexandra. Dr. Alexandra, you talk about the 4-year, the target AC trial, 4 years results of this all-comers trial. So Dr. Alexandra, the word is yours. Feel free to make your presentation. Thank you for your presence with us.
Well, thank you so much. I want to really thank you for agreeing to switch around the schedule. And yes, so I'm going to be talking about the target all-comers trial and presenting to you the 4-year results. And it's really my pleasure to do this on behalf of many investigators in the steering committee for this clinical program. Here are my potential conflicts of interest. And I'll start this off just talking a little bit about the device. This is an abluminal groove-filled biodegradable polymer that targets the release of sirolimus. So you can see that this is a thin strut cobalt chrome platform, strut thickness of 86 microns, with these abluminal grooves that contain DLPLA bioabsorbable polymer and contains the sirolimus at a dose of 0.3 micrograms per millimeter squared. And as you can see here, the release is about 90% release at 90 days. So it's very targeted and minimum dose of sirolimus. So the trial design is here for target all-comers. This was an open label non-inferiority trial. Really minimum exclusion criteria. There was no lesion or vessel limitations. And you can see it was a 1-to-1 randomized study of 1,656 patients enrolled at 20 sites in Europe. You can look at the flow here of the trial. There was an OCT sub-study here in 50 patients at 3 months, and an angiographic sub-study at 13 months. And our primary endpoint, as is traditional in these studies, was at 12 months. So the primary endpoint was target lesion failure, defined using traditional definitions, including a composite of cardiovascular death, target vessel MI, and ischemia-driven target lesion vascularization at 12 months. And again, 2 powered secondary endpoints, an in-stent late lumen loss at 13 months after the clinical endpoint, and neointimal thickness at 3 months based on OCT. Now, importantly, the dual antiplatelet therapy was based on guidelines and really at operators' discretion. I should point out that this trial was very well conducted. You can see many well-recognized institutions. Cardialysis did the statistics. There were core labs, Data Safety Monitoring Board. Harvard did the clinical event committee. So really very high-level trial conduct. Here, the statistical assumptions and the patient flow. Just to go through the patient flow here, again, 1,653 patients. You can see at 1 year, we had 96% follow-up. And when you follow patients out to 4 years, we had about 94% follow-up in both groups. Again, very good for this kind of study. And then in terms of the statistical assumptions, we had 85% power in this study to demonstrate non-inferiority in the primary endpoint at 12 months. Our assumptions were that the control event rate in terms of target lesion failure was 7%. We had a non-inferiority margin of 3.5% and assumed that we would lose about 5% of patients at 12 months. So high level, here are some of the demographics and lesion characteristics. I think they're pretty typical of an all-comers patient population. As you can see here, just things to highlight, we had just short of 10% ST elevation myocardial infarction patients in this study, mostly smaller vessels, less than 3 millimeters, long lesions. Only about 20% had multiple vessels treated. You can see that the vast majority of patients had complex lesions, so B2C lesions in more than 80% of patients. And then low numbers here of in-stent restenosis, total occlusions just shy of 10%, bifurcations requiring 2-stent strategy about 20%, and low rates here by core lab of severe calcification. Just wanted to show you and remind you of the angiographic results. So again, this was based on late lumen loss in stent, designed for non-inferiority, and we met that endpoint. So you can see that the late lumen loss here was 0.17, it was non-inferior to science based on the assumptions. And then the OCT endpoint, again, we're looking at neointimal thickness here, met that endpoint as well, is slightly lower with the Firehawk compared to science. And importantly, when we looked at strut coverage at 3 months, it was 99.9% compared to 100% with science. So again, meeting non-inferiority for this endpoint. So we presented and published the primary endpoint at 12 months. You can see just based on these Kaplan-Meier curves of target lesion failure that there was really no difference out to 12 months, and beyond that to 24 months, we met non-inferiority. And here's the landmark analysis, again, showing the outcomes out to 12 months and then beyond 12 months to 24 months, with these curves essentially superimposed on each other. So really very good, reliable performance in terms of target lesion failure. So now I'm taking your results here out to 4 years. Again, this is our primary endpoint, but you can see absolutely no difference in these outcomes, numerically favoring Firehawk, but not significant out to 4 years. These are the rates overall and the components of that primary endpoint. So you can see target lesion failure was about 14%, target vessel failure 16%. I think this is interesting. The major adverse cardiac events was 25%, more or less, not different between the two groups. I think representing the high risk of an all-comers patient population. And then mortality, cardiac death, myocardial infarction, etc. None of these were different out to 4 years. Now looking here at the 4-year outcomes in terms of revascularization, again, if you look at the overall revascularization rates, they were quite high, 17%. I think that represents the complexity of the patient population. But importantly for the device, ischemia-driven target lesion revascularization was less than 5% in 4 years. So that is really outstanding results. And again, no significant difference favored the Firehawk device. Here's stent thrombosis. So looking at the safety outcomes out to 4 years, I'm displaying this on an annual basis. We're looking at definite and probable stent thrombosis. What is interesting to see here is while there's no significant difference at any one of these time points, you can see that numerically we're seeing more definite stent thrombosis with the Xience compared to the Firehawk. So potentially, if we take this out to 5 years, this may become significant, but at least numerically. And here we're looking at very late stent thrombosis at 4 years. Again, no significant difference, but numerically better for the Firehawk. And here are the numbers and the actual differences between the groups. So again, here just looking at the Kaplan-Meier estimates of all the primary endpoint and the components, once again showing absolutely no difference between the groups. I wanted to show very briefly a sub-study that we did based on dual antiplatelet therapy. You can see that in stable patients, there was discontinuation of DAPT here at 6 months and then again at 1 year. And in the ACS patient population, most discontinued at 1 year. And still there was about 25% with still on dual antiplatelet therapy at 2 years. And what I'm showing you here are the outcomes based on device after discontinuation. And while there's no significant differences here in any of these endpoints, you can see that there are trends favoring Firehawk here in terms of target MI and ischemia-driven target lesion vascularization. So just to conclude, I think this very important study in an all-comers patient population, I think first of all, Firehawk met all the safety and efficacy endpoints compared to Xience at 12 months. It maintained those outcomes out to 4 years. We had very low ischemia-driven target lesion vascularization rates at 4 years. I think in the patients that discontinued DAPT, at least at 2 years, we saw trends for a safer performance with Firehawk compared to Xience, at least trends. And just to state here that we will be presenting the 5-year final results at PCR next year. So May of next year, you can expect to see the very final results. So that's all I have. Thank you.
Thank you, Dr. Alexandra. It's a nice presentation of this trial, important trial, all-comers trials, comparing Firehawk with we can say gold standard of stents, Verolens stents, Xience, and showing good results in an all-comers population with some adverse characteristics, calcification, almost 40% of the patient in acute coronary syndrome. So very high risk population, we can say. I'm sure that our panelists would like to make some comments, some questions for Dr. Alexandra, Dr. Abzadi, Dr. Matthias. Feel free to make your comments and questions.
Thank you, Majoni. First of all, I know Alexandra for the past, I think, 25 years. We did our fellowship together in Washington. And since then, Alexandra has been giving great contributions to our field. She's a great scientist, a great trialist. And again, thank you so much for one more important publication with close to 2,000 patients. to introduce a new DS, which is great for our community. Now, my question to you, Alexandra, is when we are talking about a novel, a drug-eluting stent, we always see the safety feature. There is no doubt that this stent is very competitive with very last or latest generation features, such as, low, very small strip thickness, a limus drug with a very advanced polymer technology. But my question to you is that, yeah, of course, you need to design a study like that, a pivotal trial to show non-inferiority. But what comes next? We always seek for short DAPT. Do you think that this stent will perform well if you have to stop the antiplatelet therapy early on, and particularly for those patients with high risk for bleeding, but with acute coronary syndrome? Do you think they were ready to push a little bit the envelope in a new device like that for short DAPT in high-risk patients?
Yeah, thank you, Alex. And, I have to also say that, we worked 25 years, it was longer than 25 years ago as fellows, and it's just wonderful to be here together with you. I think with respect to your question, the all-comers patient population obviously is pushing the envelope in terms of challenging the device. And I think the results of this study are important because we're showing that in this highly complex patient population with a high proportion of patients with acute coronary syndromes, we are seeing patients. And, we'll have to wait and see what those results are. But my, from all the information we have so far, whether it be the OCT results where we're seeing, excellent coverage early on, we're seeing numerically lower rates of stent thrombosis, very late stent thrombosis with Firehawk compared with the standard. I mean, Xience is truly the standard stent that we use in clinical practice. So I would say, yes, we are ready to push to reduce DAPT with this device, but like with anything else, we're going to have to test it first and really look at the high bleeding risk patient population, etc. And again, those trials are currently ongoing. So the results will be out pretty soon, I think.
Thank you.
Okay. Thanks, Dr. Macias. Yes, I would like to make some comments.
Yes. Thank you, Jose. I have a question for Alexander. The question is, some events was higher in both devices, like revascularization. So my question is, what is the analysis about these higher events than others, other trials? You mentioned that there was a high rate of complex lesions, but also I would like to know what was the rate of vascular ultrasound use in all this population.
So, I think that's a very good question. So I think that your comment has to do with the overall rates when we look at the patient-related outcomes. 25% of patients actually had a major adverse event at 4 years. So that, is relatively high. If you go back and you look at similar all-comers patient population, it's comparable to what we've seen in those patients. And what that tells us is that we have an all-comers cohort here. These are high risk, they have multivessel disease, and they have progression. I think the key thing comes down to trial design and the whole adjudication of events. I think the important thing related to this device is that when you look at the target lesion per se, and you look at ischemia-driven revascularization, the rates are extremely low, so they're less than 5%. So, so I think, what we're looking at here is a high-risk cohort of patients, excellent performance of the device. In terms of the intravascular ultrasound, I went back to look to see if we had collected that, and I couldn't actually find, you know, the proportion of patients with IVUS, so I can't address that question. But I think, you know, there's no question that I think it's a signal that tells us that we're really looking at a high-risk patient population when you look at the overall MACE.
Okay, I think it's time for Dr. Alexandra leave the meeting. Okay, you really deserve some rest. 2 o'clock in the morning in your vacation. Okay, enjoy your vacation, Dr. Alexandra. Thank you for your presence and this beautiful presentation. Thank you very much. Okay,
Thank you.
bye. Okay. So let's continue our section, our meeting. Now is a very interesting topic about TAVR. So Dr. Wanyan Song, you're going to present the 4-year clinical outcomes of vital flow transcatheter aortic valve system in patients with severe aortic stenosis. Dr. Song works in Beijing Hospital, Capital Medical University. He is also professor and director of Interventional Valvular Disease Center. Okay, Dr. Song, it's a pleasure to be with us, to have you with us, and please feel free to make your presentation.
Yeah, thank you, Professor McGoldney. It's my pleasure, you know, to be invited to your meeting. So I'm going to report the 4-year clinical outcomes of Microport vital flow TAVR system in patients with severe AS. I'm going to introduce in 4 aspects. So let's say the device first. This is bovine pericardial leaflets with double PET skirts, inner and outer skirts. And also this is a self-expanding valve, just like portico design. We can see the large cells on the top and the high density cells on the basic. Vital flow has 4 sizes. It's 21, 24, 27, and 30 millimeters to be used to different aortic stenosis sizing. So the most specific for this valve, I think, is electronic mode to deploy, you know, the valve very stable and very accurate during the deployment. So this is a motorized handle, and the profile for this delivery system is 16 and 18 French. I think vital flow registry, this is a second registry in China. This is a prospective multi-center and single-arm trial. The trial enrolled 110 patients. All patients was followed up at 30 days, 6 months, 1 year to 5 years per year post-TAVR. All-cause mortality was a primary endpoint at 12 months. The second endpoint is device success, procedure success, major stroke, valve performance, improvement of heart function, MACE, and improvement of life quality. So among these 110 patients included in this trial, the mean age is 77 years old, and all patients, I think, is a high-risk patient for TAVR. And this trial included 38% of bicuspid aortic valve in this study. This is a traditional Chinese morphology because, you know, our patients is younger, I think, than Western countries. So Maybe that's the reason why we have more bicuspid valve in China. And also in the first trial, the winners trial in China, we also included 44% of bicuspid valve in the study. This is absolutely severe aortic stenosis. The orifice, I think is 0.6, and the mean AV gradients is over 60. 94% of patients was performed TAVR from the transfemoral access, and 5% from transcarotid access, and 1% was ascending aorta. Because the subclavian artery is relatively, small in China, so that's the reason why we use more carotid and ascending aorta access for TAVR. The most popular size in this study is 24 millimeters. The second one is 27 millimeters. And the 4% we use 30 millimeter size, and 7% we use 21 millimeter size. From the hemodynamic follow-up, we can see during the 12 months follow-up, the performance of vata flow valve looks very good. The main orifice is 1.8 during the 12 months follow-up. And the main gradients from the vata flow is less than 10 millimeters mercury. There's no moderate and severe PVL at 1 year follow-up. You can see when we perform the 30-day follow-up, there's 2% of moderate PVL, but during the 12 months, there's no PVL during the 12 months follow-up. So 1 year mortality looks very good. Also, this patient is high risk. All-cause mortality is only 2.7%. So cardiovascular mortality is on 1.8%. All stroke is 4.5. There's no major stroke during the 1 year follow-up. The major vascular complication is 2.7. However, vata flow has, the permanent pacemaker implantation is almost 20%. I think this is because, this is only the second registry for TAVR in China, and most centers are in the learning curve. So you can see 6 patients with only 1 degree AV block was implanted with pacemaker. So I think that's the reason why they have such a high pacemaker risk. During the 4 year follow-up, all-cause mortality is 12.7. The cardiovascular mortality is 7.2%. The major stroke is 1.8, and also the new pacemaker is 20%. So we have 100% follow-up during the 4 year follow-up. So conclusion, vata flow, the new designed electronic mode TAVR system has good hemodynamic results at 1 year follow-up. It has low all-cause mortality and cardiovascular mortality rates at 1 year follow-up. And all-cause mortality rates at 4 year follow-up is 12.7. The cardiovascular mortality rate is 7.2. So the 4 year clinical outcomes support, the safety and efficacy of vata flow in the treatment of patients with severe AS. So I'm going to report one case. I know Professor Zhang will present a traditional vata flow case. So I'm going to go very quickly with a classic case with vata flow. This is 79 years old male with severe aortic stenosis. The ejection fraction is normal. So this is sizing, and also we can see the sinus. This is function, bicuspid valve with left and right fusion, calcium concentrated in the non-coronary sinus. And we can see the long strips of calcium extending from the supraannular to the anterior mitral leaflet. This is sizing. We always use the multi-planar measurement from my center. So we can see from the areola to the supraannulus level, every 2 millimeters, we tracing, for the sizing consideration. So this is like a tube-like, area to seal and to anchor the valve. So this is the one I want to mention. The idea is from Matthias. He used accurate nail 2, the all-in-one technique. So I tried, to use the 20 French sheaths with all-in-one artery technique. We can go very smoothly with 20 French core sheaths with a 5 French pigtail and the weight of flow delivery system. The other one I want to show is not this. We always perform angio before the TAVR procedure. The other one I want to show is the position of weight of flow. The classic, the positioning for weight of flow is like this. It's always 0 positioning or even a minus positioning for weight of flow to reduce, the PVL. That's why, the reason there's no moderate and severe PVL during the 4-year follow-up. Yeah. So this is echo. Thank you very much for your attention.
Thank you, Dr. Song, for your presentation. It's a very interesting device, a new device, a self-expanding device with a supraannular position and with a skirt in the base of the valve, so to avoid the paravalvular leak. And you showed only 2% of moderate paravalvular leak, so a very low incidence of moderate paravalvular leak. So I'd like to also to hear some comments again of our panelists. Let's start with Dr. Matthias. Dr. Matthias, you have some questions, some comments about this new device, a new device of TAVR?
Yes, thank you, Jose, and congratulations, Dr. Sean, for the presentation. And also, I am impressed that do you use the all-in-one or single puncture technique. So this will be my second question. It's about how did you feel it, the pigtail inside of the same sheet? But this is the second question, just to know what is your feeling. But the first is that the pacemaker rate, the definitive pacemaker rate at the discharge was 15%. So it's high, but it's not as higher as we had with the first generation of self-expandable valves like Corval or other valves, Portico. So the question is, if you think that the reason for this low number of pacemaker with the first generation valve is due to you were treating big proportion of bicuspid valve instead of the normal population that we treat here in Latin America or in Europe.
Thank you, Matthias. I think this is a very good question. I think there might be there might be no difference between the pacemaker rates between China and Argentina. I think the reason why they have higher pacemaker raise after the procedure in VitaFlow trial. That's because, most centers in the trial is in the learning curve. So they are very nervous about, the patient, even with 1 degree of AV block. So, and also in the trial, they want to maintain, very high survival rates. So to make sure the patient is no problem. So they implant more pacemaker, I think. Now, for all comers in our clinical practice, the pacemaker rates with VitaFlow, the first generation, I think is only 7%. So this is comparable, I think, to your center maybe, yeah. And the second question, I think I like, the all-in-one technique, because I don't need to puncture another access for, the patients can be used, to simplify the minimalist tower. I think it's very smooth with 24 sheets we usually use for the all-in-one artery technique. But the problem, we didn't use, the totally all-in-one, because, the wire in China is not recurved wire. It might be, for some patients, it might be difficult, to use the wire pacing during the procedure. Yeah.
Okay, Dr. Song. Just a brief question before hear the comments from Dr. Alex. Do you use normally the coplanar position, or have you been used the cusp overlap technique to minimize the incidence of the pacemaker for these patients?
Yeah, thank you, Professor Magoni. I think we started to use the overlapping view, to deploy the valve since 2019. And I think this is not the overlapping view, because we found in the right caudal view, the LVOT was elongated, so we can easily, to find, the depths we want to put. So I think this makes, the pacemaker raise even lower than before. And also we are more confident, to deploy our valve. Yeah, thank you.
Dr. Alex, your comments, please.
Yes, Mangione, thank you. Dr. Song, I'm very impressed with the results. Congratulations. This is almost 40% of bicuspid. So in terms of proportion, this is the highest proportion of bicuspid that I haven't seen in any study. So excellent results with very complex anatomy, close to 9% STS. So I'm very, very impressed. But I have a couple of questions to you. And the first one, in your opinion, in terms of valve selection, what are the differentiation features of this valve of VitaFlow that you think is going to favor your patients? Is there anything in particularly that you like about this valve superior to the other valves that you have in the market, number one? And number two, I understood that this is a supraannular solution. So any data on valve-in-valve for this particular device? Thank you so much again.
Yeah, thank you. This is a very good question. Yeah, I think VitaFlow tower system, the most specific feature I mentioned is about, the electronic mode. So we can deploy with a motorized handle, and also the valve is not, very tough. So when we deploy the valve, it's always very stable. And I think this is very important for newcomers. So I think the new centers and the new operators will like, this feature. What we're worried about, in China, the morphology of the tower valve, as aortic valve, we have more calcium, and we have the thickness in the leaflets. So we worry about, is if the valve we didn't have, the strong radial force, it might be a problem, when we're facing the valve failure in the future. But when we perform the follow-up for vital flow, but there is no problem during the 4-year follow-up. So this is the first question. And the second question, the valve in valve raise in the vital flow study. I didn't check in the statistic data, but I remember the study was reported by Professor Ger before from Shanghai. The valve in valve raise is less than 10%. Yeah.
Hey, Dr. Zhang, we have to move on because we're a little late in time. So I'd like to invite Dr. Junji Zhang. Dr. Junji Zhang will share with us a live in a box TAVI case in type 0 of bicuspid aortic valve. Please, Dr. Zhang.
Thank you very much, Dr. Marconi. It's my great honor to participate in this special session. So my case is about VitaFlow for the treatment of type 0 BAV with severe calcification. So this was a 6'5" gentleman presented with exertional dyspnea for 1 year and worsened for 20 days. He has a comorbidity with a gastric cancer surgery 10 years ago. So after admitted, the NT-proBNP test will show significantly high, more than 6,000, with a normal EGFR. And the ECG shows sinus arrhythmia with a left bundle branch block. STS score was lower than 4%. It's a lower risk patient. So let me show you the echocardiography for this particular patient. So from the echocardiography, you can notice that this patient was a typical severe aortic stenosis with a mean gradient 78 and the estimated valve open area only 0.4 square centimeter with a reduced LV function 41%. So before the procedure, we do the CT analysis for this patient. So you can notice that it's a typical type 0 bicuspid valve with a severe calcification. So this is the aortic CT analysis. You can notice that in terms of aneurysm diameter, the value was 24.5 millimeter with a parameter 88 millimeter. And we also do the supraannular analysis, just as Dr. Song mentioned for this particular case. So at the level of 8 millimeter over the aneurysm level, the mean diameter only 24.2 millimeter. In terms of the coronary occlusion risk, we can notice that although it's a bicuspid valve, and although the left main height is 60 millimeter, however, the leaflet length of the left coronary is longer. The length is 18. And also you can notice the calcification was more than 1,100. So it's a typical, I think, BAV patient with a severe calcification.
Dr. Zhang, I think we can make a little break now to return to the CT evaluation to hear some comments about the panelists, about these measurements in this type 0 bicuspid aortic stenosis. I'd like to hear, you can go back in your slides, please, to the CT, and I'd like to hear some comments from Dr. Alex Alexandri and Dr. Matias about the CT calculation, if they use the supraannular calculation, the annular calculation, this grade of stenosis in this big bicuspid valve, type 0 bicuspid valve. Please, Doctor, let's start with Dr. Alexandre. Dr. Alexandre, your comments about the CT.
Well, it's well documented, and of course, Dr. Zhang is very experienced. And bicuspid valve is always a big challenge in terms of valve sizing, in terms of where we're going to deploy it. In this particular case, I think that the sinus dimension looks acceptable, but there's always a little bit of fear to close the coronary arteries. So my question to Dr. Zhang is, for instance, for the left coronary, which is 16, now with the leaflet length of 18, would you perform a pre-dilatation in this valve and give a dye injection to see if you're going to close the coronary?
That's a very important question. So according to the CT analysis, there is a risk of left main occlusion. So I fully agree with your suggestion. I will do the balloon dilation, and at the same time, I will do the senior to see the risk of coronary occlusion. Then make a decision to see whether protect the left coronary.
Dr. Matthias, any comments?
I have not comments. Maybe we can move in the presentation, and then I will
in the final
another comment. Yeah.
Perfect.
In honor of the time.
Okay, Dr. Zhang, I think you can go ahead.
Yeah, thank you for your questions. I will go ahead. And according to the CT analysis, so my decision for my strategy for this particular case, I will use a 24 millimeter balloon to do the pre-dilation. And at the same time, I will do the senior to see the risk of coronary occlusion. And also, according to the CT analysis, I will use a superannular sizing. I will downsize the valve because according to the annulus measurement, I will choose 30 millimeter. However, after I measure the superannular, I will downsize, use a 24 millimeter valve. And also, I will use coronary protection. So this is my procedure. You can see left panel is aorta angiogram. There you can notice the severe calcification, and I use a stiff wire with the support of M+AR2 diagnostic catheter to facilitate the wire cross into the left ventricular. Then, in terms of the coronary occlusion risk, I use a Godzilla and the balloon to protect the left main. So I use a 24 balloon to do the pre-dilation, and at the same time I do the senior to see the is there any risk of left coronary occlusion. Actually, it's okay for this particular case. Then after pre-dilation, I insert the VitaFlow 24 device. Actually, at that time in China, we only have the LandQuest wire. It's a non-pre-shipped wire. This wire can give a very strong support to facilitate the valve cross into the left ventricular. Then I will use air and the left and the right cusp overlapping view to position the valve. And consider regarding its downside the valve, so my position is quite high, only 2 millimeter below the aneurysm. So this is my deployment procedure with 108 BPM pacing. So I gradually deployed the 27 millimeter VitaFlow valve. You can notice that during the deployment, the valve is very stable. There is no diving.
It is retrievable, right, Dr. Zhang?
No, it's the first generation, non-retrievable.
Now retrievable. Okay.
Yeah. So this is immediate result after valve deployment. Due to the severe calcification and the BAV, you can notice that there is a width of the deployed valve. So also at that time, the echo coefficient, the gradient more than 20. So I decided to the post dilation with a 24 millimeter balloon with 2 times. Even 2 times post dilation with a 24 balloon, the gradient is still a little high, more than 10 millimeter. So finally, I make a decision to use a big size balloon, 26 big size balloon to do the post dilation again. So at this time, you can notice the stem frame was fully open. So this is the final result. You can notice that there is a very trace regurgitation, and also the gradient was reduced into less than 10 millimeter mercury. This is echocardiography show after 24 hours of the procedure. The mean gradient reduced to 9 millimeter mercury, and also the LVEF was increased from 40 rem pre-procedure to 15.8%. And for this kind of patient, we routinely do the angio to the echo and the CT follow-up at 6 months. This is a 6 months echo follow-up. You can compare the pre-procedure and the 6 months post-procedure. The LV function was improved significantly. And the measurement, you can notice that the mean gradient was 11 millimeter mercury, and with the increased LVEF 72%. This was a CT follow-up at 6 months. From the CT performance, you can notice the stem frequency was well post and expansion. So this is compare the pre-procedure CT analysis and the 6 months post-procedure CT analysis. You also can notice the calcium refract by the stem frame. And also we do the analysis, the parameter at the significantly calcified aortic lesions. The parameter was 79, and the diameter, mean diameter was 24 and 25 millimeter. From this view, you can see, I think this valve, the radial force is quite good. So take-home messages. I think bicuspid valve stenosis with a severe calcification may be treated with good success if we can do the CT measurement accurately. Superaneurysm measurement in combined with conventional annular measurement might optimize the pre-intervention evaluation of the patient. For this particular case, I choose superaneurysm sizing for this patient. Self-expandable TAVR processes such as the Vita flow valve may be a good solution to accommodate BAV anatomy. Thanks for your attention.
Thanks, Dr. Zhang, for this very interesting case of a bicuspid valve. This technique to perform predilation with angio in cases when possibility of coronary occlusion, it's a very useful technique to check if there is or not chance for a coronary occlusion. Also, I'd like to hear the final comments of this session from Dr. Matias and Dr. Alexandre. I will start with Dr. Matias. Dr. Matias, please feel free to make your final comments.
Thank you, Jose. I would like to congratulate for this this case. My comment is that there is not devices designed for treat nowadays for treat this type of anatomy that we have seen in this case. So I feel, and I had the opportunity today to participate in the first beta flow case in Argentina. I feel that beta flow came with three main features. The first one is the radial force, and for sure, if we need high radial force, this is maybe the device to take in our minds. First of all, because today I touch myself the valve, and the radial force is really strong. It's very high. So for this type of anatomy, I think that this valve will have a big role. The second feature that I feel that this valve has solved very well is the sealing, because the skirt is so nice. It's very nice. If you see all the cases that we have seen, the sealing is not an issue. The leak, the paravalvular leak, is less than 1 or 2% in 30 days. So this is another important feature. And the last feature that I think that is very important and will be nice for the new implanters is the motorized system. It's very stable. It's very stable, and also you don't need to pull and push. You put the wire on the ventricle, in the apex of the ventricle, and then you focus in the landmark to deliver the system, and then you press, you click the button step by step, and the delivery is very stable. So these three features, I think that will be the main feature of the valve and the target for patient selections.
Okay, let's finish with the comments with Dr. Alexandre. Dr. Alexandre, please, your final comments about this case.
Thank you, Majoni. I was also very impressed with both presentations. I'm very happy to see new kids on the block, right, coming to help us in terms of valve selection, in terms of competing for better prices, because at the end of the day, we have to benefit more patients. And we still have restrictions in terms of cost, in terms of being able to make these devices available for the vast majority of our population. So thank you so much for Microport, for the physicians who are really involved with this important research. I think we're going to benefit a lot from new solutions and new devices that can help our patients. Majoni, thank you also for your excellent presidency for SOLACI for the past year, in a difficult year. And again, to our friends from China that soon will be able to visit us.
Okay, thank you, Dr. Alexandre, for your words about my president. Thank you. It was really a difficult time, but I tried to do my best. Okay, let's close this section. I think it was a very interesting session, another device in the marketing to help us to treat these patients with severe aortic stenosis. So I'd like to thank Microport again for this nice invitation to be here with Dr. Zhang, Dr. Song, Dr. Alexandra, and Matthias and Alexandre. Okay, thank you very much, and have a good night for everybody. Thank you.
Thank you.
Thank you.
Thank you. Good night.
Thank you all.
Thank you all. Thank you.
Good afternoon, everyone. Good evening. Thank you for being with us so late Friday evening. This is the beginning of the closing ceremony of SOLACI-CACI 2021. With me today, all of the organizing committee and scientific committee members, adult, pediatric, interventionists, technicians, nurses, Dr. Diego Greenfield, who is the president of CACI, and Dr. Mangione, who was the former president of SOLACI. We will give the floor to Jose Mangione so he can give some final remarks on the closing ceremony. Thank you, Aníbal. It's an honor to be here in this closing ceremony. I am very happy. It's for the success of this Congress, the scientific level, all of the sessions, the organization of the Congress was perfect. So congratulations, Aníbal, as SOLACI-CACI President, Diego Greenfield, the scientific committee, on behalf of Alfredo Rodriguez, the excellence of the scientific side of the Congress was perfect. So I leave the position. I'm very happy. So we have the golden key. So I'm confident that Aníbal will do a great job and fruitful administration for SOLACI. And I will quickly like to thank our Mexican colleagues because they kindly did their Congress session so that we could actually, they changed the date so as to keep our dates for SOLACI-CACI. So I am confident that the Congress next year, SOLACI-SOCIMI, will be very successful. To conclude, again, thank you very much to our Mexican colleagues because they kindly supported us in that regard. Thank you all. Thank you, Jose, for sharing these words. Alfredo Rodriguez, who is responsible for this successful scientific program. Dr. Rodriguez, the floor is yours. Thank you, Aníbal. Year and a half, almost 2 years, we delayed this Congress for a year due to the pandemics. I remember when they called me back to become the president of a scientific committee when I was president twice. Once for the first Congress of SOLACI in Argentina, I was the scientific committee president, and I didn't want to be a president again. I was really reluctant, and I was talked into it. Aníbal was the president of the organizing committee, and I had the opportunity to work with him when he was CACI president. I was the editor of the journal of CACI at that moment, and we got along. And I should say that along this time, I believe, honestly speaking, we didn't have any issues. It was, and due to the adverse conditions in the middle of these pandemics, we didn't know about the format of the Congress. So we aimed at putting together a scientific program, and we wanted to have societies and colleagues that I'm sure will be very close to SOLACI and CACI now. I remember second time I was a president in the organizing the scientific committee when I was speaking with Patrick Sarais. We were able to, I mean, the best study of SOLACI-CACI Congress would be considered to be
published in Intervention, and this we repeated this. Now, the best studies presented or submitted in SOLACI, the top 5 studies will be published in the CCI. As Stephen Bailey said, it will be a fruitful relationship between SCI, SOLACI, CCI, SOLACI, and CACI. So we're so excited about it. The Address Currency Society, SCI, and other societies. Today, we were just talking because there's an Australian guy that has tremendous experience in dissecting aneurysm, and that he told us that in Australia they were locked down. He was in an island full of crocodiles, sort of isolated, and everything went out fine. So these are the things that you do, and I mean it's so wonderful to work with these people. So I'd like to congratulate Diego Greenfield, the president of the organizing committee. Such a wonderful team, and Ezequiel Rivero and Carolina Paravicini and Juan Ventura. I will miss you, and I'm so happy that everything went out perfect. Aníbal, the floor is yours. Thank you, Alfredo. I'll try to be as brief as possible. I believe that we feel honored, and despite the uncertainty of organizing this virtual annual Congress, this was a big challenge for us, for all of us. And despite the hard work and uncertainty, as you very well said, we worked together so well. And all of this effort has been reflected on some preliminary figures that I'd like to share. There were over 5,000 people that enrolled, 116 different countries. That is, both rooms had a lot of visits. 10,000 the main arena, 6,000 the other room. So this really reflects the success of our Congress due to the scientific program. As you said, I'd like to thank Carolina Paravicini as a meeting planner and Ezequiel Riveros for their great job during the last few months. Their days have been really long, so I acknowledge their work. I'd like to thank all of the SOLACI, Flavia De Luca, Marisa De Cervis, Juan Ventura, Monica Guzma, who was recently incorporated as a secretary in the new research department, all of the support from Jose Mangione to review this Congress, and for the ins and outs during the pandemics, for all of the participants in this virtual room, Alejandro, Jose, Liliana, Jesus Gamsky, the technicians, the nurses, this very innovative program and appealing program. In Preducar, represented by Gabriel Maluenda, their program was really appealing and successful. I'd also like to thank the digital platform after assessing all of the platforms. would like to thank them because they have committed to all of our needs. They met all of our needs. They supported us before and during the Congress. So thank you very much to them. I'd like to thank the industry for their support. Without them, then we wouldn't be able to develop our practice. I'd like to thank the industry. Despite of the virtual Congress, they supported us. To that industry, my sincere acknowledgement. And finally, I'd like to thank our colleagues from Mexico that have accepted to change their Congress dates. Thank you very much. And finally, I look forward to meet you in SOLACI-CACI 2022. Big hug to you all. Thank you very much. Thank you for being with us in this week on Latin American interventional cardiology. Good evening, everyone.